State Chapter, as well as the members of the Association of Board Certified Minimal Access Surgeons. I would at this juncture convey the message from Dr. Rana, who is our patron and chairman of Board of Management at Gangaram Hospital, who sends his warm wishes and regards and best wishes to the IAGS Delhi State Chapter of the ASI, as well as ABBAS and the event. Thank you very much. I'll now request Dr. Neeti Kapoor, who is a very senior surgeon, the chairman of the Department of Surgery, RML Hospital, New Delhi, and also president of Delhi State Chapter of the ASI, who's a very prominent surgeon in Delhi, in academic circles also, and to say a few words of encouragement to help us get started. And welcome to Dr. Ishramurthy, who's just logged in. Dr. Neeti Kapoor, I hope you can come in now, ma'am.
Who's Shivraj? How are you?
Yes, I'm doing well, sir. I just welcome Dr. Neeti Kapoor, who is the president of the Delhi State Chapter. Ma'am, can you come in now? I think she's just logged out briefly. In the meantime, I'll play a brief message from our president, Dr. Sunil Popat, who had to leave on an urgent business this afternoon. I'm going to play a brief message from him, and I hope you can all see that now. I'll just log in there. So please enable my screen share, Mr. Satish. I'll do that. So please enable my screen share, Mr. Satish. I'll do that.
Good afternoon, friends. At the outset, I would like to thank Dr. Surya, Dr. Kalan, and team for inviting me to this prestigious eCME, the clinic. At the outset, I would like to thank Dr. Surya, Dr. Kalan, and team for inviting me to this prestigious eCME, the clinic. At the outset, I would like to thank Dr. Surya.
There's a bit of an echo here. I'm going to just do it again. Can you?
Maybe you can start, sir.
I'll start again?
Yeah, sir.
Okay, just get rid of the. Can you? Yeah.
At the outset, I would like to thank Dr. Surya, Dr. Kalan, and team.
Yeah, sir.
Okay, just get rid of. There's an echo again, Anil. Could you just take care of that, please?
So just you have to mute, that's all, everyone.
Okay, I'm going to mute myself.
Yeah. So just you have to mute, that's all, everyone.
Okay, I'm going to mute myself.
Yeah.
For inviting me.
So just you have to mute, that's all, everyone.
Okay, I'm going to mute myself.
Yeah.
To this prestigious eCME, the clinic. The topic given to me today is revision anti-reflux surgery tips for success.
Sorry.
To this prestigious eCME, the clinic. The topic given to me.
I'm sorry, I think we're having some playing issues here right now. Anil, can you hear me?
Yeah, sir. Your screen was visible actually.
No, could you? There was some echo going on. Was there echo at your end?
No, sir. Can you check? Is there any device nearby you which is logged in again, like two devices in your?
Okay, let me just disconnect that.
Yeah.
I'll just disconnect that. Dr. Neeti, can you hear us now? You need to unmute yourself.
Yeah. Am I audible, sir?
Yes, you're audible and visible. We'd love to welcome you to our clinic. And can you please, share with us a few words of encouragement from the Delhi State Chapter?
A very good afternoon to all the esteemed faculty, colleagues, friends, our own IAGS President, Dr. Sunil Popat, our incoming President, Dr. L.P. Thangavelu, Secretary and future President-elect, Dr. Iswamurthy, past Presidents, Dr. Dalvi, Dr. Subhash Khanna, and Dr. Raman Goel. I bring to you warm greetings today on this chilly afternoon in Delhi from the Delhi State Chapter of ASI. This is my first academic meet of the year 2022 as President. We all know minimal access is now the gold standard for most surgeries, and I'm sure we are all in for a great academic feast, very meticulously organized by Dr. Suviraj John and Dr. Sudhir Kallan and the entire team at Sir Gangaram Hospital. And I myself are looking forward to participate in this meet and learn a lot. So thank you so much and welcome to all the delegates. Thank you, sir.
Thank you very much, ma'am. Thank you very much for your warm words of encouragement and welcome. I'll just give this welcome address from our president, Sunil Popat, one more try, and hopefully this should run this time. I'll just give this welcome address from our president, Sunil Popat, one more try, and hopefully this should run this time. I'll just give this welcome address from our president, Sunil Popat, one more try, and hopefully this should run this time. I'll just give this welcome address. I'm not sure. Can you hear me echoing again and again?
Dr. Suviraj.
Hello, Dr. Satish. A very warm welcome.
Good afternoon. You can just send that to somebody else and ask them.
Yeah, I'll do that.
You'll ask, can you send to somebody, technical person, and
yeah, I'll do that. I'll
echoing from yours. It is getting recorded and then echoing.
Yes, I think it's doing that. Yes. Anil? Thank you, Dr. Medha, for that advice. I think I'll carry it out. What we can now do, Dr. Ishamurthy is logged in. Ishamurthy, can you hear us?
Yeah, very well. Thank you.
Right, sir.
Welcome.
I think you could welcome everyone on behalf of IAGS while we get this video issue sorted out. Yes.
Thank you. My dear friends, ladies and gentlemen, welcome to this minimal access surgical clinics. It's a novel idea, and we always appreciate the energy, enthusiasm, and the new theme on this e-platform. I think Suviraj and the team in Delhi, under the auspice of not only IAGS but also the ASI Delhi, has done an immaculate job trying to bring 6 different sessions today, and both the national and international faculty, and giving the practical tips for every surgeon, whether you are experienced or maybe in the beginning of the career. I'm sure there is a lot more to go, and especially in this prevailing COVID pandemic, this is a perfect platform. And we have been getting the information in the last 3-4 days regarding how we are going to do. I'm sure it will be an academic treat for all our youngsters. We have publicized to all across the globe, so I'm sure there are a lot of viewers in the virtual platform. I wish you all good luck, but both Dr. Sudhir and Suviraj for excellent this venture. Good luck from my IAGS office.
Thank you very much, sir. Thank you very much.
Sir. Thank you very much, sir.
I think we're all set and ready, and I think we'll make good use of this time. I'll now invite the moderator for this session, Dr. Bhaskar, to welcome our first speaker, who is Dr. Ishamurthy, and then Professor Subhash Khanna, to give their talks. We have a speaking time of 15 minutes and a 4-minute discussion time. Dr. Bhaskar.
Yes, yes, thank you. Thank you very much.
Sir, over to you, sir.
Yes.
And we also have the co-panelists, Niti Kapoor, Dr. Rajneesh Verma from Faizabad. And we also have Dr. Priyank Chlawat as well as Abhishek Bhagwat and Dr. Shivam Khare from Sir Gangaram Hospital. Over to you, Dr. Ganivas.
Thank you very much. Starting the early session of this day and in the minimal access and in the endoscopy surgery. And it's the right time. And also it has to do in a COVID time. Is the COVID given a boon to us to make the people together, even though we are away from the different places in the country. I think I think Ishwaramurthy is very good in teaching in endoscopy. A lot of workshops he conducted, and is a master in that. And he had to do PhD in that in training program also. I welcome the Ishwaramurthy to take over.
Thank you, Ganigaru. Can you see my PPT slides, sir?
Yes, yes,
From
yes.
our end, thank you. Thank you, Sivaraj, for once again for allowing me to be the opening batsman for this tips and tricks of mastery in the art and science of flexible endoscopy, which is close to my heart. Because as you all know, we live in this era of minimal access surgery, especially laparoscopic surgery for more than 3 decades. But the irony is less and less surgeons are competent in performing a very good endoscopy nowadays, even though we all know how important a flexible endoscopy is going to be in future. Because be it providing a GI service or a breadwinner for a surgeon for a day-to-day practice, I am sure the diagnostic and also therapeutic endoscopic is going to be the future. You ask any oncosurgeon or a bariatric surgeon or an upper GI surgeon for that matter, how important for doing an upper GI diagnostic endoscopy himself before we plans to do a surgery in a patient. For example, whether to do a sleeve or gastric bypass, probably a bariatric surgeon will have more than one reasons to do an endoscopy by himself. And also, there are lots of situations where an endotherapy is replacing slowly the laparoscopic surgery. We know that OM is already becoming a standard of care. Esophagus is coming. Endoscopic sleeve gastroplasty is coming in a big way, and we start improving, fine-tuning our skills of performing ESD for a large colonic polyps. And also, endoscopy comes for rescue for any laparoscopic open surgery leaks, like GI leaks, by putting a SEM stent. So there are more reasons for knowing how to do a good endoscopy, whether it is an upper GI and lower GI. Because as a patient's perspective, if you can tell that I can achieve even a big surgery by a small incision, if the patient likes to know that the same thing can be achieved without an incision, he'll be much more pleased, isn't it? So I think we need to understand, like very many facets of laparoscopic surgery, like bariatric, robotic. Now endoscopy also have so many different facets. But all I have to tell you is there are 5 areas. As a youngster, if anyone interested to learn endoscopy, to concentrate your efforts to become a master in that art. First important thing is go for the best of the tools available. If you are given an option, I'll go more to the Mercedes than a Maruti, because high definition endoscopy is no longer an option. It is becoming an essential for a successful practitioner. Whether it's an Olympus, go for the best in the Olympus make. Maybe the basic is CV 170, but even 190 or 290 if you can afford. Because soon you will realize if you are going to have a high definition, the pictures are going to be very sharp, rich in color, and you will be able to magnify. And also thanks to these filters, like a narrowband imaging with the green and blue filters, you'll be able to see seemingly a small lesions. This is only sub-centimeter lesion, like 2 or 3 millimeter. They are so magnified, so clearly seen. So you'll be able to make what I call an accurate tissue diagnosis, what I call an optical diagnosis. That will allow you to make or give an optimum treatment for a patient. And also, if there's a large lesion for that matter, like a Barrett's esophagus, there is going to be only small area where it's going to be some changes, like a dysplasia, high-grade dysplasia. Those can be easily diagnosed, and you can target biopsy rather than going for a blind leap of faith. And also precision in endotherapy also is done with this advanced technology. So go for the best endoscopy. That is my first advice I can give you. Because I'm sure 5 years down the line, artificial intelligence inbuilt is going to be part of the life for every endoscopic surgeon. Because all these tiny polyps are not only are alerted the presence where they are by your squares, and also because of the endocytoscopy, I'm sure your diagnostic potential is also going to be immensely improved by this endobrine inbuilt with the scopes available in the coming years. So tools do matter, but what important is to learn the technique by a structured training. That is a challenge for the youngsters, and develop a team in your own hospital. So to do that, let me give you 3 or 4 tips because of the constraint of the time relevant to the upper GI endoscopy to start with. Like there are 4 important things I want you to concentrate if you want to master the upper GI endoscopy. 1, always have a ritual. When I say a ritual, for example, before you do an endoscopy, for that matter, upper GI endoscopy, do what a pilot will do. That is called a cockpit drill. Check your scope, suction, airflow, everything before you do start doing. The second important thing is your patient. Don't put the scope, then think why I'm doing here and is there any contraindication? Because, for example, a patient with atypical chest pain, suspected myocardial ischemia, ECG, TROP-D precedes endoscopy. Don't do an endoscopy as an act of desperation. Informed consent is an option, but it is a very essential legal document. So all those things you need to strictly adhere to in order to succeed as a very successful, safe endoscopic surgeon. Competence, yes, you can achieve, provided you not only concentrate on technical, but also cognitive skills of competence. Let me tell you about this. Let us concentrate on the technical aspects. For example, if you're going to do an endoscopy tomorrow, you have to ensure you get the basics right. When I say basics, make sure your staff put the patient empty stomach 6 hours at least in a left lateral position with a typical neutral position of the head. How she is holding the head. You have to watch one picture, 1,000 words. And see, it is always never a leap of faith. It is always under vision. There is no blind, forceful push of the endoscopy. That is the dictum of the endoscopy. Because if you put your scope here, for example, at 15 centimeter, the scope should slide in through either the left piriform fossa or through the post-cricoid region very easily. If it is not, either there is a stricture there or you're going into the wrong place. The reason why it is not going, maybe there may be a post-cricoid stricture, or more commonly in our country like in India where anemia is so rampant, post-cricoid web like a Plummer-Vinson syndrome, or even an elderly person like a Zenker's diverticulum. In those cases, don't push, invite trouble like a perforation. The simplest thing is retreat, revisit at a later date, or if you know, and remember what anesthetists do when a difficult intubation, similar principle you can adapt. What I advise for a beginner is carefully you can take a flexible flexi-tip metallic guide wire, pass it through the access channel, and let it just come dangle about 2 or 3 centimeters down like this, and slide this guide wire beyond this piriform fossa, and if it goes freely into the esophagus, then you can guide your scope over it. That is what we call a guide wire directed endoscopy, like a Bugey directed endotracheal intubation. Similar principle you can adapt, provided you have seen once it's been done. The second challenge, I'm sure you all do endoscopy. There are occasions where it will be very difficult even to reach the pylorus because of a dilated stomach in a patient with a gastric outlet obstruction with a full of fluid and food inside. In those situations, what to do? Provided you can wait for 24 hours, empty the stomach, that is the best thing. Even otherwise, you have to know your path of navigation or a trajectory. As soon as you go into this stomach, everybody should see a tridimensional, 3-dimensional understanding of the stomach as a whole. Like, for example, you have to take a path of the greater curvature along this long route to travel to inspect. And when you come out through what I call a short route. For that, what you need to know is, if you enter the stomach, imagine this is a stomach picture, a snapshot. You treat this particular snapshot like a clock. Like, for example, what I'm seeing at 6 o'clock in the bottom, in the flow, is actually the greater curvature. So I have to walk along the greater curvature like this. Then only I'll definitely go into the pylorus. Even though it is a longer route, that is like a motorway, I'll get there. and this is the lesser curve, this is a posterior wall, that is an anterior wall. Like that, you can easily teach your postgraduates, because you need to go upwards and also you have to turn right. To do that, big wheel towards you, if you take it, it'll take the big up, you can look up. And also you torque the scope. In other words, you need to teach your staffs or your youngsters to use both the hands, what I call ambidexterity. Both hands should be cleverly used so that they can torque the scope clockwise, so they can turn the scope right, and then they can go and see the pylorus, say hello to it like this. So this is the trick they have to learn. And once they see the pylorus right at the center of the screen, then they can jump into the duodenum very easily. What they should not do is, when the pylorus is facing downwards or sideways, trying to spend some time. So what will be is, they'll be dancing and the pylorus will be dancing, they'll be getting frustrated. So you have to get everything right. That is, you teach it perfect way in facing. Like for example, if it is a pylorus like that, if your scope is straight, facing straight like that, you can go in like that. If it is down facing, you can't go like this, isn't it? So like that, you need to teach them. And also a challenging task for a beginner would be seeing a lesion high up in the lesser curvature, like in the cardia, like this, a large lesion as you can see. And he may not know how big it is and how to take a biopsy. That you need to teach as a trainer. For example, you see the scope there. For example, the size of the scope is 9.2 millimeter. Now you can see this as a measuring scale. I can roughly tell how big lesion. You ask them to open a biopsy forceps. The open biopsy forceps width is around 8 to 10 millimeter. Then by taking the biopsy forceps open, and you can roughly, like a measuring scale, you can measure it. So these are all the way to measure any lesion. Second thing is, they should not just go in a J maneuver. It's very difficult to take a biopsy, because biopsy forceps cannot travel acute bends like this. So he has to straighten the scope, take the biopsy forceps right up to the tip here, up to here. Then only he has to do a J maneuver. Only he has to come out and take a biopsy, then get in, then straighten the scope. Like that, it is a multiple small mini movements he has to do. All these things had to be taught. Otherwise, if you are not kind to the instruments, the equipments can be very easily damaged. So all these tricks cannot come overnight. Minimum 150 cases. The learning curve, technically, it is around 130 to 140, even in ASGE guidelines. But in my opinion, technical skill is only a part of life. Cognitive skill is more important for you. Because if you see, for example, esophagitis, can your trainee classify like what a Los Angeles or Sabry Miller would do? Or if you see a lax lower esophageal sphincter, does he know what is Hill classification? If he sees a Barrett's esophagus, does he understand a Prague classification? All this knowledge can be given only by going into books or discussing with your senior colleagues, applying it. So, because whatever you do today should be a medical terminology accepted across the planet. That is what important. For example, if I see a bleeding duodenal ulcer today, I should say, Forrest, what type of grade? Is it type 1A, B, like that? It should be of that importance. See, for example, I'll give you some 1 or 2 examples. A hiatus hernia for that matter. If you go in with the endoscopy, you see the Z line here. For example, here there is a Z line, and that is around 35 centimeter. Then you see the patulous hiatus. There you ask a patient to say, then the pinch-cock mechanism, you measure this top of the gastric fold. The distance normally for normal people less than 2 centimeter. If it is more, then you know it is a, what I call, there is an axial hiatus hernia. In other words, proximal, the migration of the stomach like a dumbbell, like this. But what is important is do a J maneuver when you do take the scope inside the stomach and look from below and see how big is the width of this or the transverse length. That is equally important. That's why the importance of what I know is a Hill classification. What Hill classification says is, when you see the hiatus in a J maneuver, the scope, whether it is nicely gripped, or there is a gap, or there is a too much of a gap, or there is a too huge a gap. Depending upon that, the Hill classification varies. Accordingly, you can tell the patient's degree of G or D. So all these things we need to teach our youngsters, and also measurement of the Barrett's I'm sure that it's a challenging even for youngsters nowadays. So you have to tell them, take the scope, go into the gastroesophageal junction like hiatus. That is what I call that top of the rugal folds here. From there, they have to see circumferentially how much is the salmon-pink mucosa, and longitudinally how much of the tongues of the Barrett's mucosa. Both they have to measure. For that, they can have the help of what I call the narrowband imaging, because white light is this one, narrowband is here. The narrowband makes life easy, not only for a magnified nice image, and also with a grading. For example, Barrett's of early, Barrett's of severe dysplasia will have a different configuration, and you will be able to get a targeted biopsy precisely an area where you suspect, rather than going for what we call a blindly 4-quadrant biopsy. All those things you can teach your youngsters. Like that, if we can move on to the colonoscopy also for that matter. But colonoscope, not only it's long, the learning curve also long for colonoscopy, because reaching a cecum is a daunting task for youngsters, and to achieve a 95% cecal intubation rate, you need to train yourself. Not to miss a lesion, not to create a perforation, where are high quality indicators one have to aim for, because you can't take things lightly. We need to tell our youngsters the importance of a good bowel preparation, and after that, importance of all the equipment, a high definition endoscopy, carbon dioxide insufflator, irrigation device, and the theater setup, where you stand, how the patient lies, how many staffs you need, and what is your recording, and what is your disinfection protocol. Everything altogether is very equally important, not just doing a scope. But still, with the time constraint, let me give you some technical tips. 5 golden rules of doing a good colonoscopy. Try to master with your both hands. Like a laparoscopy, be ambidextrous. What I mean by is, instead of you putting your hands on the knobs, asking your staff to push and pull, you do both the things. 1% technique is the optimum, because you need to take control of yourself. The shaft should be in your control, then only you can torque the scope. Because the way you easily enter the sigmoid and go beyond sigmoid is by what I call a clockwise torque steering. In other words, you see how a screwdriver drives the screw. Same way, if you go for a clockwise driving, it will drive the scope gradually in millimeter at a time. You'll get there, provided you follow some cues. For example, follow the darkness. Wherever there is a darkness, there only the lumen is lurking. And wherever this longitudinal tinea coli is directing you, that's where the lumen is going. For example, here the lumen is at 12 o'clock. So bring the big wheel towards you, you look up. Here, for example, the darkness, it is more to the left. So you torque the scope anti-clockwise. So like that, you will be able to do by torquing and making the big wheel, and it will listen to you. The tip of the scope will listen to you. See, for example, here, normally you have what we call alpha looping trying to happen, but by you see this clockwise torquing, this is what will happen. Clockwise, now it's torquing. Another clockwise, like that. Slowly, it will go like this, and you go 1 minute. Don't over distend it. Distended colon is a long colon. Deflated colon is a short colon, easy colon. Don't make the pelvic colon or a sigmoid colon to a intra-abdominal colon. That is very, very important. So what I'll do is, you avoid loop formation, because loop formation is bound to happen, especially when patient is, say, having a lot of pain, or if you're pushing the scope, you're not getting any improvement. The tip is not moving forward. Then you see that is one of the 2 loops are already forming, called classically what I call an N loop and an alpha loop. N loop is a junction of the sigmoid and descending. Alpha loop is where there is an alpha loop formation, and you go right up to the splenic flexure, but it takes all the scope length. And even with the 1 meter, you're still at the splenic flexure. You're not able to go. How to recognize and rectify? If you have a scope guide with the MRI device, well and good. Even otherwise, if you think it is going to be N loop, which is much more common, you can avoid it happening by minimum inflation. Second important thing is a firm suprapubic pressure by your assistant, so that you will not allow the sigmoid colon ascent into the abdomen. That is what you need to do. Like that, then you can always pull the scope. In other words, you have to prepare to take 2 steps backwards whenever you go 1 step forward. So that is the best way to do a reduction of the end loop. Alpha loop, when it formed, the best way to reduce again is what I call a clockwise torque and pull back. In other words, never hesitate to pull back your scope. That is the secret of your success. As I said, your assistant is an active partner. Allow her to apply pressure at the appropriate place, like a suprapubic region, especially for a sigmoid looping. If it is a transverse colon, you are not able to traverse, an epigastric upward pressure might help. If you are not able to go right into the cecum, a right loin pressure will help you. Then you can say hello to the cecum. But one important point I want to tell you is in colon, unlike in a small, the stomach, you don't correlate the level where you are in with the colonoscopic picture, because the colonoscopist will tell the lesion is in the transverse colon. But irony is sometimes the lesion may be still lurking in the descending colon or a sigmoid colon, because there is no signpost in the colon. That is one important message I want to tell you. Cecum, one definite marker, provided you are able to show a ileocecal fold, crowfoot sign, the convergence of tinea coli or appendicular opening. You are able to show them all, well and good, or ileoscopy for that matter. But what is equally important is the withdrawal of scope is more important to recognize a lesion, which, for example, this lesion is diagnosed only on its withdrawal. So you should be very slow, spend at least 6 minutes, spend 1 more minute by what I call a retroflexing the tip of the scope like this in the rectum, so that the lower rectum is also clearly examined, not missing a lesion in the lower rectum. And we do all these things for a very important concept is not, you should have what I call like bile duct injury. You should have a zero tolerance to complication, a zero tolerance to a colonic perforation. How we can do that?
Time, sir.
Yeah, never use force, never go for a leap of faith. For example, here forcefully without a luminal scope, people forced came out like this, and that caused a perforation. As you can see, that typical finding how a perforation feel. Initially, you will feel something like that, and you can come out. You made a hole as big as scope, that is about 11 millimeter. To avoid these things, all you need is a good training under the patient or with the simulators. Thanks to GSL, we have a wonderful system of this GI mentor, because patient safety is of utmost importance, and we are there to train you and teach you. And we have lots of textbooks are available nowadays, thanks to the IAGS for 4G FAGS courses available. And because in my opinion, and I am sure all the people across the country will agree, the future surgeons going to operate mostly in the flexible endoscopy platform, because there is no scope without a flexible scope. Thank you.
Over to you, Dr. Gani Bhaskar. You have 2 minutes of Q&A time. Thank you very much.
Thank you. I think very wonderful total endoscopy and colonoscopy tips and everything. I want to make a take-home message for the colonoscopy and gastroscopy.
See, as far as the beginners are concerned, the gastroscopy, you should know, because everybody knows when we should not do a colonoscopy endoscopy. Contraindication, one has to be very, very cautious, because we have gray hairs only after when you reach 60, 70, but you should know the causes, because I have burned my fingers trying to do endoscopy in a patient who is not fit. So patient with the respiratory distress, patient with the atypical chest pain, acute chest pain, you should defer endoscopy. That is the first message I want to give. Second, especially when you have any scopes for that matter, you have to do a checklist. That is a very, very important thing, I would say. And the third, always be very gentle. Never use force, never do things blindly. When you don't see any lumen, come back, re-examine. And always there is a next day. So remember that you will avoid complication, be it an endoscopy or a colonoscopy. Training, 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 and practice is the only way to achieve perfection.
For starters, can you advise about any relaxant injection, buscopan like that, to easily to enter into the postoperative duodenum without any difficulty. Starting pace.
Yes, sir. Normally, most of us are doing an upper GI endoscopy in an outpatient setting. Usually, xylocaine spray or nowadays electrocaine solution is also available to swallow. We don't even give a conscious sedation, even though that can be safely administered. You have to be very careful. In my opinion, Buscopan is no required not in a normal diagnostic endoscopy. We do use Buscopan when we are going to be stay in the duodenum for a long time, like a ERCP, or when you're spent already 10-12 minutes, the pylorus is not opening up, you want to enter. But in my opinion, if the pylorus is not opening, one, you have distended the stomach so much, there is a spasm, repeated gastric peristalsis is allowing you are not able. So you deflate, wait patiently, it'll open. The Buscopan is not a wonder drug, but you can use it. There is no harm in doing it, but don't rely on Buscopan, rely on your good technique. Patience is a virtue.
Like any sphincter, if you forceful making it going to spasm.
Yes.
Wait for some time, you could do a better way to visualize.
Because cannulating any lumen, it should be very, very gentle, delicate. You have to see how a Haskell is long, get into the ampulla vater, how gently it goes, palpates, enter. Like that, you have to kiss the pylorus and it will open. It is like it will open the door. Never do what I call a forceful entry to anywhere. It is a very important message I want to give you.
Thank you, Rishamurthy. We're out of time. I wish we had more time. I think you require a complete hour for this minimum introduction. Thank you very much.
Thank you.
Rajani Bhaskar, I'll give it over to you to request Dr. Subhash Khanna to come.
Yes. Who is the next speaker?
Dr. Subhash Khanna, is it? He's presenting.
Welcome to Subhash Khanna.
Therapeutic endoscopy.
Subhash Khanna? Is in line?
Yes, he's logged in. And maybe we can take another question from Dr. Ishamurthy meanwhile, while Dr. Subhash Khanna comes in. A delegate has been, another co-faculty has asked, what is the guideline status for performing a good upper GI and endoscopy and colonoscopy? Are you aware of any guideline prescriptions for performing a good upper GI endoscopy and colonoscopy from Dr. Munish Sachdeva, who's a chairperson for the next session, actually?
One of the common thing we normally ask, will be asked is, can a surgeon legally perform an endoscopy and colonoscopy? These basic questions should not come. A surgeon is licensed to perform all basic diagnostic, endoscopic, and also important life-saving therapeutic procedures. See, for example, if you're having a patient with a duodenal ulcer bleeding, hemostasis is close to any surgeon's heart. So he has to stop the bleeding. He can't come out having made a diagnosis. So you have to take a needle, inject, and stop the bleeding. If there is a bleeding varices, if you have seen one, if you're competent, you have the equipment, you perform. There is no harm in doing. But the problem thing is you have to get trained. The very important thing is normally during a postgraduate time, because our country is so vast, our training is so patchy. In some institute, they make a very important thing. They have to perform certain number of upper GI endoscopy, and they have to see some number of flexible sigmoidoscopy. Even a high developed country like USA, if you go there, the SAGES has made it compulsory for surgeons performing under this flexible endoscopic program, now FEST program, because they have seen, even after residency training, not many surgeons are competent in performing. But when they go into the community, it is only they have to perform large number of scopes. So it is our moral obligation as a senior surgeons to tell the youngsters, you are legally permitted to do. But provided you ask a simple question, whether you will be able to do it in your father, mother, that is, are you competent enough to do safely? If you ask the question, if you say yes, you can go ahead and perform. There is no legal issue at all. And coming to the more advanced procedure, of course, there are like level 1, level 2, level 3, level 4 training. The trainings are of various levels. What in IAGS we have done is we made a 2-section training program. Level 1 is for a diagnostic upper GI and basic colonoscopy and EFAGS. Then FOGI, that is a level 2 training, where we go basic therapeutic and also introduction to more advanced procedure like ERCP. Then level 3, now we are going for a single team programs now. Thanks to Professor Subhash Khanna and others, we have started doing ERCP procedures also. So slowly surgeons should know, as I said earlier, I think the future is going to be in the hands of flexible endoscopy platform. And as a surgical fraternity and all the association, it is our obligation to introduce this and also motivate all our youngsters to learn this technique.
Thank you, sir.
I think Subhash Khanna has joined.
Brilliant.
Now. Yeah.
Yes, he should be joining any moment now.
Yeah, I'm here. I'm here. Sorry, it was my net, so I hope everything goes well.
Over to you, sir.
Thank you. Thank you, Dr. Suviraj. Thank you, Dr. Sudhir Kalhan. And hello to all my friends and colleagues here.
Welcome to Subhash Khanna.
Can I? Yes. Is it? I think. Okay. Sorry. Back to Dr. Ghani Bhaskar Rao. Sorry.
Welcome. Nice to see you.
Thank you.
Over to you, sir.
All right. Thank you. I hope the screen is visible now.
Yes, sir.
You can see.
You can go full screen with your slides, sir.
Yeah. Okay. Thanks, Dr. Suviraj.
Please go ahead, sir. I think he's going to share again. Subhash, can you hear us?
Sir, I think, yeah. Log.
I think, Ishramurthy, you're online, sir, with us?
I am here.
Yes, sir.
I am here.
Yeah. So maybe you could, briefly, while Khanna reconnects, just briefly outline what the IAGIS is doing in terms of educating surgeons, especially young surgeons, for basic as well as for advanced endoscopy.
Yes, yes, thank you, Suviraj. As you all know, the last 4 years, IAGS, having seen the importance of this training our youngsters and IAGS members in the arts and science of endoscopy, we started the program, a pilot study followed by a structured training module under the direction of Professor Krishna Rao, who is considered as the Bhima and also the father of endoscopy as far as India is concerned. Under his tenure, with all the enthusiastic endoscopic surgeons in IAGS, Professor Sunil Papat, Subhash Khanna, Sunil Kumar, Sadish Mida, and Dr. Govindaraj, Satyapriya D. Sarkar. There are a lot of people I can go on, and also our colleagues in other areas also like Amol Papai. They're all people joined together. We made a structured program and it was very successful. And we have given both hands-on, both on the patients, simulators and animal models, and also enough cognitive skills by giving importance lectures, both as lectures and also as a book. And also we have a reading manual. As you can, I show you the handbook of surgery and also the endoscopy and colonoscopy books. All this being given, and having succeeded with the EFAGs, now we moved on to 4G. And the first 4G program was done in Guwahati and of course Subhash Khanna once again, and we have done 2 more programs, one in Trichy also recently, and they're all very successful. And the enthusiasm shown by the youngsters make us more frequent programs. Now we do. We are proud to say there are close to 1,000 people who have undergone this structured training under this IAGS, our association, and either in the EFAGs and the 4G, that motivated us to go into the next stage of single theme program. Now we are planning to do ERCP. Already we started, and endo ultrasound is the next avenue. So that's the way we are traveling, because we know the importance, we know the potential, and we know the future. Thank you, Suviraj. I think Subhash Khanna has joined once more. Welcome,
Suviraj. Yeah, sorry for that. Sorry for that. It seems little trouble is there in my presentation. Let me see if everything goes well. I hope the screen is visible now and you can all hear me. So
yes.
the agenda for today for me was to see in the last 3-4 decades where we are and what are the changes and what are the things for which what are the surgery which are lost to endoscopy. When we look at that, we see there have been advances in diagnostics. Equipment have changed from the standard definition. We have gone to the high definition. There have been huge advances in imaging. All these are for the benefit of the surgeons. I'm just coming to that, how these advances in imaging is helping the surgeons. Then endosonography, of course, the surgeon, you want to know the staging, then only you can plan your resectional surgery. Then the capsule endoscopy, modified capsule endoscopy, you want to target your drug therapy, chemotherapy. So you need now capsules with therapeutic facilities. Then advances in therapy, we have seen starting from ERCP, which is now, I would say, mostly in the hands of the surgeons. And then the next advance is the spike glass. The endoscopy in bariatrics is one which we would like to take IAGS should like to take in its hand now a course or a fellowship in endoscopy in bariatrics. Then other advances have been there, and the most remarkable of which was maybe a third space endoscopy like POEM and others for Jenkins diverticulum and others, and then endoscopic drainage with internal stands with different types of, we'll come to that. Detection. Ishramurthy has made my job easier. He has already mentioned about the detection. How do we detect early cancer so that a surgeon can help himself? We all know that if you can detect the cancer early, we can give a 5-year cure rate of 80%. So what we are looking at is detecting a cancer at the level of high-grade dysplasia and intramucosal or T1A or T1B, and that is possible either with the help of advanced a pixel of 300,000, so we have gone to 2 million pixel, and we also have got a magnification of 150 times compared to what we used to get 35 times. Apart from this, there are newer techniques of chromoendoscopy by which you can do tattooing of the lesion, and there are also inbuilt methods, technologies in the machines that starts from narrowband imaging to autofluorescent imaging, endocystoscopy, and confocal endomicroscopy. We call it endomicroscopy. That means while doing an endoscopy, you can do a microscopy. So as I said, for improved patient management, we have a high detection rate of lesions with HD scopes and the cameras, and then we can use any of the dyes, indicocaramine, methylene blue, but the most common one is Lugol's iodine, and we call it chromoendoscopy by just staining the layer, the mucosa with Lugol's iodine or similar agents by different methods of absorption, reaction, or contrast. We can level the lesion. You can see here a Lugol's iodine has stained the normal mucosa, which has been where the glycogen containing squamous epithelium has taken up the iodine, whereas the Barrett's layers are not taken up. So it's very easy to detect early and very easy to target these areas. Similarly, there are other chromoendoscopic agents whereby the early cancers. And what is the role of this early cancers detection? Well, if you can detect it early, you can go for an early endoscopic ablation. And we surgeons have to remember that endoscopic ablation, whether it is a radiofrequency ablation or a guide wire resection or a submucosal dexterity, is surgeon's job. Same thing we are getting now from the processors, whether it is Olympus, Pentax, or Fuji. They are giving us, with the push of a button, narrowband imaging or intelligent scans, whereby you can simply cut down the deeper lengths of the light and use a superficial light to stain or to visualize the mucosa and the vessels, which become either the veins become cyan and the capsullaries become brownish. So little bit of neovascularization or mucosal breakdown you can detect early here. And in ulcerative colitis particularly, you do not know which area has gone this plastic change. If you go doing a narrowband imaging or intelligence scan, you can always detect, and you can see how nicely a single lesion has been detected here.
Video conference ఉంది.
Yes, Gary Bhaskar. Can you hear me?
Yes. But
Right, so I think we
visuals are
just
not.
lost
Visuals are
his
not
connection.
there. Visuals are there. Yes.
Maybe we can connect again in a while. So I think what we can do is move on to the next session while he gets connected so that we don't lose out on time, sir. Thank you as well as the other co-chairpersons for the session.
Thank you.
And please be around because when he comes back, we'll love to have you back with us. We have for the next session, Dr. Sunil Popat presenting on revisional anti-reflux surgery. I request the moderator for the session, Dr. Deepraj Bhandakar, and the chairpersons in this session, namely Dr. Subhash Agarwal, Dr. Arun Prasad, Dr. Munish Sakdeva, Dr. Anshuman Kaushal, and Dhananjay Pandey to join us. And I'll request Mr. Anil Vishwakarma from Olympus to start the video play for Dr. Sunil Popat. Mr. Anil, you can start playing. 5.
Good afternoon, friends. At the outset, I would like to thank Dr. Suvira, Dr. Sudhir Kalan and team for inviting me to this prestigious eCME, the clinic. The topic given to me today is revision anti-reflux surgery tips for success. I bring greetings from Ahmedabad and MASC-GIS. Friends, laparoscopic anti-reflux surgery was started in 1991, and since then it has increased in frequency and it has become the gold standard for hiatal hernia surgery and anti-reflux surgery. However, since many years we are aware that laparoscopic reoperative or redo anti-reflux surgery can be performed safely with complication and success rate similar to open with a much better outcome. The indications are recurrence of reflux, recurrence of hiatus hernia such as rep slippage, dysphagia, gastric volvulus. It happens in 2 to 17% of primary anti-reflux surgery patients, which may require revision anti-reflux surgeries. When fundoplication fails, should we do redo? Failure of fundoplication is less in experienced hands. However, most are managed within 2 years of the initial operation. Rep herniation has now become the most common mechanism of failure requiring redo. Redo fundoplication was successful in 93% of the patients, and most could be safely handled laparoscopically. Surgical reintervention after failed anti-reflux surgery. This was an excellent surgical systematic review, which suggested that morbidity and mortality after redo surgery is higher than the primary surgery and should be done by the experienced laparoscopic upper GI surgeons. The diagnostic tools, first and foremost, is detailed history. As a surgeon, as a clinician, one needs to understand why the patient is having the problem, what is the problem, what is the main complaint, and the symptoms should correlate with the findings on the investigation. A simple chest X-ray can give you the diagnosis of a diaphragmatic hernia, and particularly in post-operative setting, you can make out this is a recurrence of the hernia. Similarly, endoscopy, barium swallow, CT scan, pH and manometry study would definitely help in coming to the diagnosis. So this is one such patient who presented with severe acute nausea and vomiting of a couple of days duration, and she underwent laparoscopic anti-reflux surgery before 2 years, and X-ray showed this. So even X-ray could show that there is a diaphragmatic hernia, but fortunately, as you can see, the Ryle's chip could go into the stomach. She actually had volvulus, but the emergency was saved with the help of Ryle's chip insertion. And the same patient with on CT scan, you can make out that there is a gastric volvulus and there is a hiatal hernia. This is another patient who presented with a rap slippage. And on upper GI endoscopy, as we go down, you can see the GE junction is quite okay. There was no hiatal hernia seen. But as we do the J maneuver, you can see this rap, there is a wide gap. And so there was so patient wasn't having reflux symptoms. There was a recurrence of hiatal hernia, and patient came for a surgery, redo surgery. It is of utmost importance to do a pH and manometry study whenever you are doing a revision anti-reflux surgery to get all the information regarding the type of reflux, the amount of reflux, and the symptom correlation, and also to get the maximum idea regarding the esophageal motility. The procedures which we commonly do for revision anti-reflux surgery is either a revision anti-reflux surgery or redo hiatal hernia surgery, or sometime we may need to do RYGB. So there has been comparison between these two, redo fundoplication versus Roux-en-Y gastric bypass. Basically, Roux-en-Y gastric bypass is advisable in the patients who are coming back with recurrence of reflux and morbidly obese, because in these patients, it will definitely help to have RYGB so that patient can lose the weight as well as the recurrence of reflux can be taken care of. Here I'll be describing the redo hiatal hernia surgery or revision anti-reflux surgery. The position of the patient is same as the primary surgery. Surgeon operates from between the legs, and these are the port position which are commonly used. Supraumbilical port at 10 mm. I use another 10 mm as my right hand working port and 3 5 mm. We remove the 5 mm epigastric port and use a Nathanson liver retractor. The principles of surgery and steps I will discuss along with the video. So here is a patient who came with a recurrence of hiatal hernia. I'm waiting for video to start. And as we are using the Nathanson retractor, you can see you get the best view of the hiatal area when you retract the liver with Nathanson retractor.
So we can pause and just do it again, this point P.
Yeah. So this is a adhesiolysis is one of the most important steps. You will see a lot of adhesions between the left lobe of liver, the anterior surface of stomach, the lesser omentum, and the wrap itself. So these are the adhesions between omentum and the greater curvature. They are being divided, and we follow the fundus, the phrenoesophageal membrane, divide it to enter the mediastinum. The important thing here is to stick to the structure which you can identify. Don't divide the structure which you cannot identify. And gradually we make progress towards the mediastinum. We continue doing the adhesiolysis between the left crus and the G junction complex, coming anteriorly. It is of its utmost importance to always keep the active blade of the harmonic under vision. Now you can see we have entered the mediastinum. Then we have made the posterior window and we use umbilical tape to retract the G junction caudally. We apply the caudal traction at G junction and then continue doing the adhesiolysis and the dissection of the hiatal window as well as G junction and lower esophagus. It is of utmost importance that before embarking on doing a redo hiatal hernia surgery, one has to be very experienced in hiatal hernia and upper GI surgeries. Now this is the dismemberment of the previous fundal wrap. You can either do it with sapler, but it becomes little expensive. So you can dissect it properly, cut and suture. So the fundus is suture closed on one side. So it looked like a very small opening, but always close it before progressing to further step of the surgery. And then we proceed inside the mediastinum, as you can see. Now you can see the posteriorly placed fundus, the fundal wrap, which was inside the stomach. And these are the adhesions between the fundus and the esophagus. So again, we divide it to mobilize it completely. One has to be careful identifying the structure properly and dissecting it in proper plane. So now you can see hiatus completely, the sac is excised all around. The excess fat at the G junction always should be excised so that it gives you good space. Once the dissection is complete, we proceed to cruroplasty, and here you can see the crura, because of the fibrosis, are in excellent condition to hold the stitches. The defect is not that large to demand a need for mesh. If the defect size is too large, say 7 or 8 centimeter, and the crura are not coming together, then you can consider using the mesh. So the cruroplasty is done. Then we bring back the fundus again and check. The fundus is coming nicely together. And we'll be doing here posterior partial fundoplication. So while doing posterior partial fundoplication, we take first stitch through the crus on that particular side and fix the fundus to the crus first, and then fix it to the lateral side of the esophagus. And then the same thing is carried out on the left side of the patient. Once the anatomy is identified properly, the dissection is done properly, then you see there is not much of trouble doing the surgery, not much of bleeding you will come across. And most of these patients recover very fast and discharge on post-op day 1 or 2. Sometimes we come across a patient who was operated by open technique previously. I just show how much the amount of adhesion you can see. So this patient was operated elsewhere with the open hiatal hernia repair and fundoplication, and she developed recurrence and came for the surgery. And here it was difficult first to even identify the left lobe of liver. Once we identified the left lobe of liver, we gradually progressed towards the hiatus and divided all the adhesions and proceeded towards the hiatus. So as you can see here, identification of the structure and adhesiolysis becomes the main thing. I'll fast forward it a little bit. Now we are at the hiatus. You can see a lot of fibrosis, dense adhesions. And one has to be very careful identifying the structure and doing proper adhesiolysis.
You have 1 more minute, sir.
Okay. So when the adhesiolysis is done, then the rest of the procedure is same like last surgery. Some of the common complications are pleural opening, vascular injury, vagal injury, perforation, and recurrence. Most of the time, complication we have seen is pleural opening. You just need to identify it and make a large pleural opening so it doesn't lead to tension pneumothorax. In our experience of more than 800 cases now, we have quite a good number of redo cases, 5 of our own and then about 40 referred cases. But on the large, it is a safe surgery, no mortality, and the results are quite good. What one needs to do is to have a proper hiatal dissection, always use a sling, identify and assess the anatomy properly, don't miss the uppermost short gastric vessels, preserve the vagal nerves, be careful with the posterior wall of esophagus and G junction, ensure adequate length of abdominal esophagus to prevent the rep under tension and rep migration. And this is another paper showing that complete takedown and re-establishment of the normal anatomy, recognition of a short esophagus, proper placement of the rep are essential components of the procedure. Always dismantle the rep before doing the another rep. Proportion of symptom and quality of life improvement was about 80% in redo cases, and estimate of recurrence across the studies was about 10 to 11%. So always explain to the patient properly. To conclude, ladies and gentlemen, laparoscopic revision anti-reflux surgery is a feasible and safe procedure that provides symptom relief and improved quality of life to the vast majority of the patient. Recurrence rate seems to be low, around 10 to 11%. And this surgery should be considered a valuable treatment modality for patients with failed anti-reflux surgery. It's technically more demanding due to adhesions, altered anatomy, inability to find the correct planes, increased complication rate as compared to primary anti-reflux surgery. Most common complication, as I said, is pleural opening and can be tackled very easily. Use of MASC is restricted to repair large recurrent hernias. Revision anti-reflux surgery can be done effectively and provide cure for recurrent reflux following previous laparoscopic or open fundoplication. Thank you very much for your patience.
Thank you, sir. We'll quickly take a few questions. You had an incredibly large experience. What is the top 3 reasons for revisional surgery in reflux primary surgery that you note?
What I have noted is mainly rep migration is one of the most common thing. Majority of the redo cases we have done, what we have seen is hiatal window has widened again. The reason may be anything. In some of the patients which came from outside, I noticed that hiatal repair was done with Prolene, and there was a slippage of the Prolene material, and that led to the early rep migration. And then I had a talk with that particular center whose patients were coming to me, and they also switched over to Athibond since last several years. And since then, that reason is not seen anymore. However, in spite of using Athibond, I have seen rep migration in our own patient as well as patient coming from outside. And I think in our own patients, 3 patients I remember distinctly, they were all operated long time back. And the endoscopy video which I showed, that was a patient I operated before 20 years. And he came back with recurrence. And I reoperated him again and he's fine. When I operated him first time, his weight was around 45 to 50 kg. When he came back now, his weight was 70 to 75 kg. So one of the reason may be long-standing long time, one, and second is a lot of weight gain. But other reason for redo or revision or recurrence is recurrence of reflux. Sometimes patient is having symptomatic reflux, and if you look inside, you will see that though the wrap is in place, there is some laxity around the wrap, and then the reflux is there. So one need to do proper investigation in such cases, that why there is sometimes there is a pyloric stenosis or pyloric spasm, and that may be the cause. Sometimes esophageal motility is not good, and 360-degree wrap was done, and patient may have dysphagia. So the dysphagia may also provide a cause for the revision surgery.
Thank you, sir.
And yeah.
We are completely out of time. We'd love to hear more from you. And please do keep in touch with our delegates on the social media platform. And we look forward to hearing more from you. Thank you.
What I suggest, John, you can take few more questions, discuss it, show it if there is a time or wherever there is a time.
Right. Yes, we can do that. So I'll just continue this recording because we'll keep it on the online platform.
I think we'll pause
may not be on
this
the
moment.
live one.
So
I
the
think
full Q&A session
more questions
to the audience later on. So Subhash Khanna, would you like to conclude your talk in another 5 minutes?
Okay. Let me see if I can.
Yes, sir.
In case any problem. So
no problem. Go on, please.
Let me go straight to the therapeutic part. So if there is any problem, then I will just
let me no problem. So we can record and put it online later. Not an issue.
All right.
It's much clearer and clean now, sir.
Thank you. As I have only 5 minutes, I will go to the next part. Is let me see if I can. Okay.
You can go full screen, sir.
All right. So we are talking about the development endoscopes. These are the self-propelling colonoscopes, and some of them are disposable. These are already they are not prototypes. Some of them are in use, although very few are in India. I will switch over to what is new in ERCP. Modified capsule endoscopy is also there. There are various types of capsule endoscopes which or wireless capsules which we use. And of these, the most recent development is the colonic capsule and the esophageal capsules. The pill cam was already there for years, but what we are trying to do is trying to give external control to these wireless capsules so that when we want the legs to come out, and we should be able to take a biopsy. And more important than that is we should be able to hit a target lesion. These are the 6 different varieties of the new capsules which have come up, of which one is a hemostatic capsule where you can have an OTSC clip which you can load and fire at the bleeding point or at a area of perforation. Then you can have a ablation for photodynamic therapy you can do for H. pylori in one of these capsules. So there are different types of capsules which are available. The robotic endoscopic capsules which can be manipulated from outside are already there, so the surgeon should know that. From ERCP, which have been we had been doing a lot of basic work like removing the foreign bodies from the track. Sorry, again the net is giving solution. And we have moved over to therapeutic endoscopy, and this is one big area where so these are the routine thing which we are doing endoscopically, taking out the worms, taking out the coins. But from there we have moved on to the therapeutic endoscopy, and the major development in the recent past has been, apart from refinement of our endoscopy techniques of CVD exploration. Say here we are trying to go very selectively into the conval duct with a guide wire rather than with a sphincterotome. So we call it a selective cannulation. Even before we have injected the contrast, you can go in and do a cannulation of the CVD rather than the PD. Then we have also moved on to the techniques of balloon sphincteroplasty, avoiding the sphincterotomy. So with any of these controlled release expansion balloons, CI balloons, we can expand the ampulla to 15 to 18 millimeter, and you can take out the bigger stones, and you can also take out the stones, and you can also introduce the spy scope. And this is one area which surgeon must know, that if there is a post-cholecystectomy leak, he can himself go in and put a stent there and take help of these. So these are all new things. A suppurative cholangitis patient who is admitted in your under you in your ICU, who is in septic, even he can be trolleyed into the operation theater, and you can always go and put a stent there if the patient is critically ill. If possible, you can also take out the stone. But then the new thing in ERCP is a Colangioscopy, which is not very new now, because we must have done it over 100 cases by now, where you can take in a French or about 3 millimeter scope inside the conval duct. You can do a biopsy with a spy bite. You can go and visualize the hepatic duct, and you can take out biopsy for any suspected lesions there. And that's it. And this is a very older video. With the modern digital spy scopes, you can get a wonderful view of the hepatic ducts. So today, I don't think we should. So this is how we can take a laser fiber inside either 200 microns or 400 microns and can pulverize any size of the stone. In the last ERCP training program, the first one held in Guwahati, we could take out a stone of about 4.5 centimeter. So this is a development for the surgeons that they have to pick up, because it's starting from multiple hepatic duct calculi to a larger stones of any size. They can pulverize. If needed, they can do in stages. There are developments in bariatric surgery. Although most of us are restricting ourselves to intragastric procedures. There are various types of balloons which can be put in the stomach for weight reduction, and they follow the same. They work on the same principle of delayed gastric emptying. And there are other procedures by which you can reduce the volume of the stomach, and you can also give a malabsorptive procedure. We'll just have a quick look at primates. Orbera was there, it is there. Obalon is multiple balloons. If the patient cannot tolerate, you can always give him balloons at intervals of 250 ml. These balloons have a capacity of 450 ml up to 900 ml. The double balloon reshape is the one where to save ourselves in case there is a balloon rupture. The second balloon will prevent its migration into the gut. The sparge balloon is readjustable balloon, which can be kept for an year, and you can always inflate it whenever the patient wishes. You can drag out one of the stems here, and then the ellipse is a swallowable balloon which gets disintegrated on its own later on. The balloon is placed under vision, and a very simple procedure. I think any average endoscopist can always go and place it. You always dilute, put some dilute methylene blue there in case the balloon there is a rupture. We always tell the patient that you can keep and watch on the urine. If the urine becomes greenish, you have to inform us so that we can take out the balloon. Extracting the balloon is slightly tedious and I always prefer giving anesthesia because puncturing this old balloon becomes a bit difficult, and you need to have a long three-pronged or two-pronged grasp to take it out. So this is also slightly tricky here. Apart from this, the most latest ones, there are other methods of the latest is a ESG or endoscopic sleeve gastrectomy. It is popular in some centers, but because of the cost factor, it is slightly prohibitive because the cost of disposables is also quite high. But you can always create a stomach, something like a sleeve gastrectomy, what you would have done in a sleeve gastrectomy.
You have a minute, sir.
Yeah, all right. There are malabsorptive procedures like endo barrier, which can bypass duodenum and jejunum. You can also bypass the whole stomach even, and also you can do a radiofrequency or ablation of the duodenal mucosa for a metabolic procedure. So these are various things which are coming up. Another latest thing which has come up, we were using all these metal stands called self-expandable metal stand, SCMS, both for esophagus, colon, duodenal pyloric obstructions, and also the biliary tract. But the latest development is the availability of lumen opposing stands. These are small. You can always do a bypass between the. You can also drain the gallbladder. The patient is very sick, is not fit even for a cholecystostomy. You can always do an internal drainage of this. So these are different types of stands which are available. And talking about lumen lamps, lumen opposing metal stands, and you can do a cholecystostomy. You can always do various types of bypass procedure. I think I got Dr. Vishwakarma has said it. My time is over, so I can stop here if needed. Thank you very much, Dr. Suviraj, for giving the opportunity.
Thank you, sir.
I'm ready to take any questions.
No, sure. I think we can take one question. Dr. Deepraj, would you like to ask a question to Dr. Subhash Khanna?
Yeah.
Yeah, good afternoon, Subhash. Nice to see you.
Same here. Thank you. Same here. I was having some problem with my net today. Sorry for that.
So what is your take on these so-called procedureless gastric balloons, which are like small pills which are to be swallowed and then they are inflated, so they do not require endoscopy, they do not require any anesthesia, any sedation. Any thoughts on that? Have you had any experience with these procedureless gastric balloons?
We will not say that these are entirely endoscopic procedures because these balloons can be swallowed, and from outside you can always inflate the balloon with nitrous oxide up to 250 ml. So these balloons, we have not had any personal experience. Usually they are put at a month's interval. You can go up to a maximum of 3 balloons and inflate it to 250 ml. Very recent trends are the swallowable balloons which are coming up, which inflate on its own. I have no about that. But the balloons
that's the one I'm talking about. The patient swallows the balloon, is attached to the tubing, and they can be just inflated under imaging radiology control.
Yes.
We have Dr. Mohit Bhandari covering it also.
Yeah. Okay.
So somebody's covering it. Okay.
Yes. I think we'll, sir, we're going to record your talk and put the full thing online. So don't worry that you missed out on the talk. So thank you very much. Thank you to Deepraj. I think we're totally out of time. So we'll slip on to the next talk, which happens to be me. I'll try to finish it quickly so we have time with us for the rest of this session. Dr. Deepraj, with your permission, can I start?
Yes, please. Go ahead, Suraj.
Thank you. I'll share my screen. Thank you very much for joining us today, all of you esteemed dignitaries. I hope you can see my screen now, sir. Deepraj, can you see it?
Yes, we can see your screen.
Thank you, sir. I chose this topic primarily because we are facing an evolving problem in minimal access surgery. And I've termed it as turf versus choice, the issue of laparoscopic cardiomyotomy. This is one of the proud things we did in forward surgery in minimal access. But now the ground is shifting under us. We have our endoscopic friends, the medical gastroenterologists, now increasingly perform endoscopic procedures like the peroral endoscopic myotomy. And they are gaining fabulous experience and outcomes with this. It's sometimes maybe robbing us the experience of teaching our fellows and residents this procedure. I wonder how the next generation of surgeons is going to be when they come across a case of achalasia cardia. Often these are referred by physicians and medical gastroenterologists. The whole algorithm is shifting. So yes, we're picking up more of achalasia cardia, and I believe it's probably because of better diagnostics and more awareness among physicians and medical gastroenterologists. And we all know the history of the treatment of this, and the history of this treatment is still being written. Broadly speaking, the two most important or practical issues that approaches we use today is POEM as well as Heller's cardiomyotomy, largely done laparoscopically. So I'm going to focus on that and see how the current scenario is changing the issues regarding decision-making in the surgical outpatient. We're all very familiar with this picture, and residents as well as MBBS students know this well when it comes to replying to questions in MCQs. The real thing we need to be aware about is that this is a disorder of inhibitory innervation of the esophageal motor complex. And coming from classical manometry, where we now know the definition of achalasia cardia is the failure of swallow-induced relaxation of the lower esophageal sphincter, and also presence of abnormal peristalsis or the absence of normal peristalsis in the esophageal body is the diagnostic feature of this condition. HRM, which is high-resolution manometry, has changed this even more now because we're able to now classify this motor disease by its types, essentially by the nature of the contractions of the esophagus into type 1, type 2, type 3, namely the Chicago classification. And we are aware about the outcome differences, which I'll come to shortly. Coming back to classical surgical teaching, we now know that treatment is essentially palliative. We really don't cure this disease. And the goals are essentially to relieve the primary symptoms, which are dysphagia or regurgitation, and improve the esophageal emptying and prevent the development of megaesophagus, as well as of peptic consequences, and even the development of squamous cell cancer in the esophagus. We've now moved on from pharmacological and initial endoscopic treatment to a laparoscopic or minimal access treatment, and back to endoscopic treatment in the form of POEM. A brief discussion about laparoscopic Heller's cardiomyotomy. It is still regarded as the gold standard. Why? Because we have excellent short-term results, up to 80 to 100% relief in symptoms in the first 3 months, and reduction in the mean LES pressure up to 80%. And the 5-year recurrence is down to about 5 to 15%. Some of the retrospective studies is about double this amount. And with surgical teaching in the postgraduate and senior residency stages, a surgeon does accrue, in the past, he would accrue enough experience, about 15 to 20 cases, to gain confidence in this procedure. Morbidity and mortality are extremely low in the current modern day context with good perioperative optimization and care. The key issue is that you have to add a fundoplication, whether an anterior or a posterior one, because without a posterior or without a fundoplication, you would result in a GRD status in up to half the patients within a 10-year period. The good patient is a patient generally about 40 years of age. Pre-treatment LES pressure is greater than 30 millimeters of mercury, and a significant drop, about 50% or less than 18 millimeters of mercury in the post-operative period. Conversely, what predicts failure? Is it male gender? history of daily chest pain, severe preoperative dysphagia, a sigmoid esophagus, and type 3 atalesia where there is a hyperactive esophageal body. A key reminder to surgeons is to have a detailed surgical counseling and consent session, because it's a functional disorder. One needs to clearly explain not just the surgical issues, but the long-term functional status of the patient and the need for screening in the long term and surveillance. A clear liquid diet for 24 hours before surgery, general anesthesia, split leg position, steep reverse Trenenberg, and DVT prophylaxis. Our personal preference is to have a supraumbilical optical trocar with a left bias, and this is a classical foregut upper abdomen surgical disposition of the trocars, bilaterality, as well as a left lateral trocar in the anterior clavicle line for the assistant and a subcostal subxiphisternal position for the liver retractor. Decision essentially commences after a diagnostic laparoscopy by retracting the liver, opening up the lesser omentum, preserving the hepatic branch of the vagus, and then opening up the phrenoesophageal membrane in a semi-circumferential manner anteriorly, entering the posterior mediastinum. You can see the fissile tissue, and then progressing superiorly for at least 8 centimeters, exposing the anterior esophagus, dissecting away the crust as well as the left vagus. We open up the muscular planes just above the G junction, and then in a deliberate, slow fashion, in a submucosal plane, we open up cephalad in a controlled way using energy sources like the harmonic, making sure not to perforate the mucosa. Once this is done, we complete the dissection prograde by progressing to 2 to 3 centimeters on the gastric body. Here the fibers are oblique. We have to be more careful, more deliberate. Patients who undergone a pneumatic dilatation or Botox treatment in the past would have the mucosa tethered, and there is often a high risk of mucosal perforation at this point. Once this dissection is complete and you mobilize the musculature away from the mucosa, we hitch the edges of the myotomy to the crust with 2-0 ethibond interrupted sutures. And once this is complete and you confirm the integrity of the myotomy as well as the mucosal integrity, we slap on the anterior stomach, the fundus, and a bit of the body as a door fundoplication, an anterior 90-degree fundoplication with interrupted sutures. I'm going to run through the video here. This is a little old, but it's a well-done video. That's why I keep sharing this again, although we have recent high-quality videos. I'm repeating the video so that the essential message is conveyed very clearly. Opening up the lesser omentum, as you can see, we're preserving the hepatic branch of the vagus here. After preserving that, we still open up the lesser omentum, expose the hiatal region. And once this is done in an anterior 180-degree area, we open up the phrenoesophageal membrane. I usually mobilize the superior half of the gastric fundus and cardia to allow the fundoplication to take place later on, a gastrolysis done there. Exposing the crura allows us to enter the posterior mediastinum. As you can see, subsequently here done with blunt dissection, you need to be careful not to open up the pleura. These are common steps generally in foregut surgery, and those who have done a sufficient number of hiatal repairs and fundoplications will be comfortable. Once the area has been exposed, you carefully dissect away the left vagus, and then we gently open up the submucosal plane with a Maryland forceps, and then subsequently transect the circular and the longitudinal fibers. Ensure the myotomy is complete by breaking any intervening muscular strands. And then we hitch the myotomy edges to the crura so that stays open. Once that is complete, we slap on the anterior fundoplication, the door fundoplication, by bringing up the gastric fundus and hitching it with 2-0 bond to the crural edges. And this provides an additional layer of security in case you made a perforation in the esophagus or the stomach. And you could close the mucosal red with a 4050 micron. A water-soluble contrast esophagogram done on post-operatively. One, to rule out a perforation or an obstruction, and followed by about 2 weeks of liquid to purine diet, and then slowly to a regular diet. It's very keen to advise and counsel the patient regarding post-operative functional assessment, not just clinical assessment, which you could carry out with the Descartes score profile, but also have a time barium swallow as well as endoscopy. If you have the facilities, do get a pH testing at 6 months because GRD is your main issue. And then a screening endoscopy primarily to survey for squamous cell carcinoma, which is again an unknown feature. We don't know what the risk is, but this is something that you could consider and counsel the patient about. Our brief results, as you can see, compared to our previous cohort about 5 years ago, our numbers have shrunken, and that's primarily because of the referral bias. Endoscopists, medical gastroenterologists primarily do POEM now. We've had extremely good results, very low morbidity, simple post-operative issues like post-operative fever, 0 mortality. We've had a follow-up of our last group of patients for about 5 years. Virtually everybody's had relief, with most patients, about 70% having very good symptom relief. The occasional patient having reflux symptoms and requiring intermittent PPI usage. None of them have required a repeat intervention. Of note, I would like to introduce the idea of peroral endoscopic myotomy, not because our medical gastroenterologists are taking over, but this is a territory that surgeons with endoscopic interests need to be aware and should be doing it. We as a teaching institution are mandated to teach this to our fellows. Overall, the efficacy results are parallel the Heller's cardiomyotomy, and that's great. But the learning curve for POEM can be a little longer than for Heller's cardiomyotomy. The key difference is that POEM entails a high rate of gastroesophageal reflux, and this has been quite consistent in the early as well as the intermediate results. We're still waiting for the long-term results, and reflux defined by pH monitoring can be as high as 88%. And so that is a worrisome thing. And again, patients who are younger and type 3 who can have a long cardiomyotomy in POEM, which is a definite advantage for POEM, have good results. Now, what I've gained from our medical gastroenterologists, they've carried out about 400 or more cases in the last few years. Their average length of stay is about 2 days with less than 2% mortality, with less than 2% morbidity and no mortality. And they claim a very high rate of symptom relief, but around a 15% patient load having reflux symptoms. And they, as a standard, give PPIs for up to 3 to 6 months. They claim to have had 2 patients requiring interventions, one laparoscopic Heller's cardiomyotomy to deal with persistence of symptoms, and 1 patient requiring a fundoplication because of severe reflux complaints. The comparison in literature between the Heller's cardiomyotomy and POEM has essentially shown the risk of GRD being the clear demarcation between POEM as well as laparoscopic Heller's cardiomyotomy. And this is something that must be mentioned in your counseling and consent. If we add the manometric findings for the achalasia subtypes, we still find that GRD is a significant disadvantage, is an issue with POEM and somewhat with laparoscopic Heller's cardiomyotomy. So you adding a fundoplication is an absolute must. And yes, the type 2 achalasia responds best to all kinds of treatments, and the type 3 really benefits from a POEM because you can do a 15 centimeter myotomy and give that patient good relief. If you look at the guidelines coming out now, after 2 meta-analyses and a lot of publications and a few RCTs with early and intermediate results, for a fit patient, a laparoscopic Heller's cardiomyotomy is considered the first line of treatment. You consider a peroral endoscopic myotomy when the patient actually accepts a significant risk of GERD and the chance of the patient requiring rarely a second procedure. So this is an issue there. And the management algorithms are constantly shifting. There are a number of them online, and you can see this. As a first line, there are endoscopists who prescribe a POEM first after counseling the patient and only advise Heller's cardiomyotomy if there's failure of treatment or the patient is resistant to treatment. So I'd like to summarize by saying that while POEM has been validated as a treatment option for aphasia, and the best patients may be an older one or those with greater comorbidities because of the risk of GERD, the current standard of care is still a laparoscopic Heller's cardiomyotomy along with a fundoplication, the ideal patients being someone who's young, fit, high baseline, low esophageal pressures, and those are unprepared to accept a higher risk of GERD with endoscopic procedures. Please note that this is going to become a challenge for teaching our fellows and residents in the future. So please step over and do accrue endoscopic experience for your sake and for their sake. We've got this website up. You can visit the CPG page of Clinical Practice Guidelines. We have some of the global guidelines on the management of achalasia cardia there. Thank you very much for patient listening. I'll be happy to take any questions if there may be.
Hi, Suviraj. That was an excellent talk and
Thank
a
you,
nice
Dr.
coverage of the poem also. I would just like to add one point that many times we are doing the surgery for people who have undergone a previous balloon dilatation.
Right.
And in these cases, the chances of a perforation, especially around the G junction where you start getting the circular muscle fibers, is quite high. So as a surgeon, we must be very careful. In fact, some people say that a good myotomy in these cases, you invariably do make a hole. So find the hole and stitch it. So that was only additional comment I wanted to make.
Thank you. Very apt, sir. Very apt. Any questions? Or I think we're out of time here. So Deepraj, would you like to add something or convey a
just
question?
one thought. What's your position on intraoperative checking on the completeness of myotomy by doing an endoscopy? I mean, do you do it yourself? Do you get your gastroenterology colleagues to visit you in the theater and get them to check that the myotomy is complete? Do you do it ever? Because there is some literature which suggests that checking this intraoperatively improves the outcomes and results.
Yes, out of I think 5 of us, 2 of us get an intraoperative endoscopy done. I personally don't get it done. I'm a little worried about the integrity of the mucosa, especially in a previous patient undergoing an endoscopic procedure. But yeah, 2 of my colleagues get it done, and it's right out down to personal preference. It's a good add-on, I think, if you're doing it yourself. But I think it's down to surgeon comfort right now. And I think your point is well taken. That's an add-on that we probably looked at by surgeons. Yes, thank you. I think we'll close this session because we're out of time and we have a very heavy session coming up now. I request Dr. Raman Goyal, sir, you could open up your mic and we'll welcome the bariatric session in, which is a very, I think the heaviest and the most demanded session going by our pre-registration survey. Also request the chairpersons, Dr. Sandeep Agarwal, Dr. Sarfaraz Beg, Dr. Tarun Mittal, Dr. Amar Venupusa, and Dr. Srihari Anikindi to come in. Over to you, Dr. Raman, to introduce the speakers. We have Dr. Mahendra Narvaria, Dr. Randeep Udavan, Dr. Ricard Corselis from Cleveland Clinic, and Dr. Mohit Bhandari speaking to us. Dr. Narvaria could open up. Dr. Raman, are you there?
Yes, I'm very much here.
Oh, sir, over to you, sir.
Hi, good afternoon, everyone. Thank you, Suviraj and the GI surgery team. I have been in every program physically present for your meetings, and it's an honor to be there in the current one. And I would rather let the chairpersons do the honors of introducing the topic and the speakers. So may I invite the chairpersons to take charge and invite Dr. Mahendra Narvaria to start his first presentation. Okay, so may I invite Dr. Mahendra Narwaria, who is going to talk on redo bariatric surgery post Roux-en-Y gastric bypass. And as you know, Dr. Mahendra Narwaria is a past president of OSI and a very senior bariatric surgeon, a close friend. Mahendra, over to you, 15 minutes.
Thank you, Dr. Goel. Thank you, Suviraj. Thank you, IMAS team, though I'm part of IMAS team now. And thank you for the invitation. I'll just take you through this difficult topic of revision, which we are facing nowadays quite frequently. And I'm just covering only Roux-en-Y revision because the revision itself is a very big subject, which can be. So revision surgery in bariatrics can be categorized as a conversion from a procedure from index procedure to some other procedure like sleeve to Roux-en-Y, sleeve to MGB or something like that. And it can be corrective, wherein we are addressing the complications arise because of the previous treatment, whether it is incomplete surgery or because of previous complications, or it can be reversal just to restore the original anatomy. Reoperative bariatric surgery is an incredibly complex and demanding area which requires considerable primary bariatric surgical experience. Revision surgery, although technically challenging, but it can be or maybe produced with desirable outcome if performed by right person in right time and of course by right surgeon. So how can we define a failure when we don't know the definition of success in bariatric surgery? Because till now there is no clear definition of what is success in bariatric surgery or failure in bariatric surgery. Is BMI below 30 is a long-term goal by us, or is it personal extra weight loss which is greater than 50%, or comorbid resolution combined with weight loss is our goal? Or it is difficult to talk about revision if you don't have a definition when if they have failed. So in Roux-en-Y gastric bypass, we can have a good outcome, means there is no post-operative complication, adequate weight loss, resolution of most of comorbidities, and a happy person with happy surgeon. We can have a hot complications like bleeding, we can have leaks, we can have stricture, or we can have internal hernias. And cold complications can be dumping, excessive weight loss, steatorrhea, inadequate weight loss, weight regain after adequate weight loss are few of them. So Roux-en-Y gastric bypass, though considered as a gold standard, its long-term failure rate reaches up to 20% in super obese patient when BMI is more than 50. The most common indication of reoperation after Roux-en-Y gastric bypass for inadequate weight loss is for revision, and this is the most common reason which patient require and we request to you to go for revision surgery. A failed Roux-en-Y gastric bypass is when Roux-en-Y failed to meet the patient's and surgeon's expectation, inadequate weight loss, failure to adequately control the comorbidities, weight regain after initial weight loss, or complications like dumping or steatorrhea. So we need to have a good preoperative counseling. We need to set a realistic goal for the outcome, whether it is weight with it or it is a comorbid resolution. A surgeon's goal of surgery may be different than what is a patient's expectations. So we should not be only sticking to that, and we should always try to address the patient's expectation, discuss in detail, and try to achieve a consensus before surgery as to what should be a reasonable outcome after the surgery. Identify at-risk patients likely to not follow diet or exercise adequately. There are patients who are having poor follow-up, and there are patients with conditions which put them at inadequate outcome like limited physical activity, patients on steroids or anti-epileptic or antipsychotic drugs, or patients with unreasonable demands. So a preoperative evaluation by a psychiatrist or psychologist is a must before we opt for revision surgery, and even an endocrinologist evaluation is mandatory. So why a Roux-en-Y gastric bypass failed, whether it is due to anatomical consideration like enlargement of the gastric pouch or the dilatation of the stroma. And the Hennigan has found about more than 70% of patients, the weight recidivism was because of abnormal anatomy. That means dilatation of the pouch and dilatation of the stoma. The other anatomical consideration can be gastrogastric fistula. We need to rule out sometime, and it was originally identified in 1995 as an abnormal connection between the stomach pouch and the extruded stomach, and it was earlier more commonly seen when they were using non-partition staple line, but in recent technique, the risk is significantly less, and it is less than 1%. So gastrogastric fistula will allow food to pass through the extruded stomach, and which leads to no feeling of satiety, and they can eat more. So there is no two Roux-en-Y gastric bypass which are same. The different patients are having different physiologies. There is a different technique in terms of pouch size, stoma size, or lymph length, and there is different eating patterns by the patient, and there is compliance and dietary issues and exercise issues which are there because with the patients. How to approach a failed bariatric surgery? We need to evaluate the eating behavior, which should be evaluated, and we need to have modification of eating behavior. We need to evaluate the anatomical by endoscopy or by radiological investigations. Endoscopy, we can evaluate the stoma size and even pouch size. We can have a 3D reconstruction by CT scan and to measure the pouch size. And pouch size more than 120 ml is considered or acceptable for revision surgery with result. Currently, the most common indication after Roux-en-Y gastric bypass in bariatric surgery, some patients are deemed to fail or become less responsive after a certain time. Up to 1 in 5 patients after Roux-en-Y gastric bypass have weight regain despite of initial good weight loss. So almost 20% of people may come back with the weight regain. So we should not be in hurry to offer a second surgery. Patients with initial adequate weight loss, which is about 60 to 70% of extra weight loss, will get a maximum benefit from the revision surgery. Patients with inadequate compliance after primary surgery will have less likely to respond to the secondary surgery for the revision. And thus, there are different type of procedure like BPDS type of procedure are to be offered to such patients. Before revision surgery, we can have conservative management, or when we have not significant weight gain, we can have conservative management like dietary modification, counseling of these patients to change their dietary habits, and use of GLP-1 agonist like dulaglutide or liraglutide, and nowadays semaglutide, which is recently introduced by Indian market, can be used. And metformin has modest weight loss, although beneficial in patients with sugar craving or those who are having reactive hypoglycemia. So the other options which are there as endoscopic process like pouch calibration, which can be reduced by endoscopic devices, and we can reduce them in the stoma size by overstitch kind of devices. And in surgery, we can trim the pouch, or we can bend the pouch, or we can have revised gastrointestinal anastomosis. We can distillation of the jejunal anastomosis by reducing the common channel, which can be 50 to 150 centimeter, and we can convert it to BPDS or SADS or a new technique called modified Oagb type of technique, which can be offered to these patients. Endoscopic options like sclerotherapy, organ plasma, and those have tried, but there is no significant result with these processes, so we don't offer it more frequently. So even the publications are not favoring a good outcome. So what left with us is surgical option, wherein we can trim the pouch, or we can bend the pouch, or we can do both trimming and bending the pouch, move the jejunal anastomosis distally to reduce the common channel, or we can revise to other processes like BPDS, SADS, or modified MGB. So by putting a band, it can be adjustable band or a ring which can be placed on the pouch after resizing the pouch. This is a small video showing how resizing of the pouch is done and band is placed. So bougie is placed so that we don't injure the We identify the pouch, which is quite wide here, and we can then excise it. So you can see the pouch is significantly large here. Big size of pouch, which is trimmed using a stapler. Usually, I prefer to use a green cartridge to excise this pouch, or we can use the purple cartridge, or we can use the black cartridge. So here we have used the black cartridge because stomach is thick walled here. The upper part is thin, so we can use the blue here. And then we make a dissection around the stomach, create a window through which we can put a band. And this band can be then placed and fixed. This is a non-adjustable band. This is a ring which can be placed. So this will decide the stoma. So here, even if there is dilated stoma, it will not have any effect because the band will decide the stoma size. So in a study of 29 patients with weight regain at 5-year post-2 gastric bypass, there were different approaches were studied and applied, which includes increase of alimentary limb, application of silicone ring or gastric glycation, and overall offering of the silicone ring in 19% out of 29 was associated with increased extra weight loss, which is about 20.6% after 9 months. In another study by Bessler, is reported a gastric band on revision patient in 8% post-2 gastric bypass. Prior to revision, the mean BMI was 44 plus minus 4.5, but after revision, excess weight loss was 38.1 plus minus 10, and at 12 months, the mean the BMI is almost as equal to the pre-surgery BMI. So similarly, in another study, they reported positive finding after using a gastric band as a revision technique in 11% of failed 2 gastric bypass. The mean BMI was which was reduced was 6.3% with approximately 20.8 plus minus 16 extra weight loss at 12 months. So we have different publications available which has shown a significant weight loss of about 29.1% extra weight loss. This is adjustable band placed on a Roux-en-Y gastric bypass with weight loss by Garner group, and this is another modification where we do the distal anastomosis by disconnecting the Roux limb and reconnecting it closer to the ileocecal wall, and usually it is 50 to 150 centimeters. That is why it is called distal Roux-en-Y gastric bypass. And here we need to measure the entire small bowel and to decide the commission length. Very short commission channel lead to more malabsorption and steatorrhea, resulting into not only weight loss, but also to have loss of skeletal muscle mass, which is undesirable or not acceptable. So this is distal Roux-en-Y gastric bypass from the proximal. So disconnecting the Roux limb and reconnecting 150 to 100 centimeter by different authors has reported significant complications. Like in Phobis series, the reported average weight loss was about 20 kg with BMI loss about 7 kg per meter square in 65% who were converted to distal Roux-en-Y gastric bypass. Nevertheless, almost 23% of these patients developed protein energy malnutrition, which required, and almost half of them required revision surgery just to treat this complication. So
you have 1 minute, sir, to go.
So we don't offer this surgery to most of our patients in our Indian context. So we can have another procedure like BPDS or SADI-S or even modify mini gastric bypass. So I'll not take you through all this, but I'll just take you through one procedure which I usually do in last almost 5 years, wherein I convert a Roux-en-Y gastric bypass to a modified Oagb type of technique. Here we disconnect the roux limb about 15 centimeter below the anastomosis of gastrointestinal anastomosis, and we resect the rest of the roux limb till anastomosis, so making a loop, and this loop is then brought here and joined, and this length can be about 250 to 300 centimeter, which is joined with the jejunum. So we have jejunal-ileal anastomosis, and this is the small video just to show how we convert it. This is a dissection at the stomach pouch, identifying the roux limb. So this is dividing just about 15 centimeter below the gastrointestinal anastomosis. And after this, I will resect the rest of the jejunum till the jejunal anastomosis, that means complete roux limb, leaving the mesentery here as it is. And then we'll make a loop. This is like dividing at the jejunal anastomosis. And then we do this anastomosis with the pouch and jejunum, which is attached with the pouch, which is about 250 to 300 centimeter. So there is no major dissection or alteration required in this technique, and most of the time the food habits are good and they can lose weight without any difficulty of nausea and vomiting. So with this, I conclude my talk, and we can have questions on this topic.
Raman sir, you can unmute yourself.
Yeah, thank you, Mahendra, for a very interesting talk on a very difficult topic. I'll invite the chairpersons of this session to take the proceedings forward. We are honored to have Dr. Sandeep Agrawal from All India Institute, Dr. Sarfaraz Beg from Kolkata, Dr. Tarun Mittal from Delhi, Dr. Amar Venapusa from Hyderabad, and Dr. Shihari Anikhandi to chair this session. Over to you, chairpersons, to conduct the proceedings.
Yeah. You have 2 minutes of Q&A for Dr. Narwariya.
Yeah. Good, if I can, speak. First of all, thanks for the invitation, Dr. Suviraj, and congratulations on an excellent CME. So, Dr. Narwariya, it's a very comprehensive talk, and two things. One, supposing after band, pouch resizing and banding, it fails, as you said in some of the literature, what will be the next option? And two,
I think we can convert it to single loop duodenal DS. I think it was there in my talk, but since the topic was too large, we could not complete it. But we can always convert into BPDS type of technique, wherein we rejoin the stomach and do a re-sleeve, and then doing a duodenal switch with a single anastomosis. So it is loop switch kind of procedure.
So maybe can you do it in one stage, like you can resize the pouch and then excise all the roux limb, not just leave 15 centimeter, and do a one stage resizing the pouch and Oagb. Just a thought, what would be your comments on that?
Yeah, that is what I do. Because since the pouch is small, we cannot go too high there because we want to have good length, so to avoid the bile reflux going back to the pouch. So I make I divide the jejunum about 15 centimeter below that, so there is no risk of bile coming or going to the pouch. So there is no pouch bile gastritis in the pouch, and the quality of life is good. This is what I do, and I had shown this in, I think, our OC Chennai conference or Calcutta conference.
No, excellent. I think excellent. I think you should publish it. Innovative. Thank you so much for your talk. Thank you.
You could introduce the next speaker, Dr. Randeep. Yes.
Thank you.
Our next speaker is Dr. Randeep Budavan. Dr. Sandeep or Sarfaraz, you could introduce him.
Yeah. So I'll take this forward. So we invite now Dr. Randeep Vadhavan. Well, he is the President-elect of Obesity Surgical Society of India. What better description of him than this? Good friend, and therefore it's going to be a pleasure and a privilege to listen to his talk on redo bariatric surgery after sleeve gastrectomy. Dr. Randeep Vadhavan, over to you, please.
Thank you very much, Sarfaraz, for the introduction. And can my slides are my slides visible, and am I audible?
Yes, they are visible and you're audible as well.
Thank you so much, Sarfaraz. And at the outset, I'd like to thank Dr. Suviraj, Dr. Sudhir Kallan, and the team for inviting me here. And I congratulate them for an excellent session we've had so far. So from RYGB revision to sleeve revision, so how do we define? Most of the cases of sleeve revision are because of the weight regain. And how do we define weight regain? So I was looking at the data, and this is what I found, that by and large, the definitions are that either there's an increase of body weight by more than 10 kgs, which is the commonest definition which has been given from the Nadir weight, or an increase of BMI of 5 kg per meter square, or if the BMI actually reaches beyond 35 kg per meter square, or greater than 25% of excess weight loss regain. So these were by and large the 4 definitions which have been given over the years, and most of the data is around these 4 definitions. Now, why does the weight regain happen in a sleeve? Proposed mechanisms are technical factors. Technical factors, if the bougie size is more than 40, so by and large, anything between 32 to 40 is kind of considered to be okay, and anything beyond 40, there are higher chances that these patients can regain weight. Leaving a large fundus or leaving a large antrum, well, again, that's an anatomical thing, and that's primarily because of the fault in primary surgery. Sleeve dilatation will happen, and we know that. Ghrelin levels can actually go up again. They go down because we know that 70% is around the fundus. Once the fundus is excised, the ghrelin levels goes down, but once it goes up again, one can have a weight regain. Follow-up support system has always been emphasized by all of us, and it's extremely important. The ones who follow up will probably regain less, or probably not regain, or minimal regain, I would say. Lifestyle behavior, again, is extremely important. So these are probably the mechanisms by which a sleeve can actually regain weight. Dr. Mahendra has already discussed about the medical treatment, about the counseling bit. I'm just going to go for the surgical part. What are the options available once a patient regains weight after a sleeve gastrectomy? Re-sleeve gastrectomy is one of the options for a failed laparoscopic sleeve gastrectomy. And this is a paper which was actually published nearly 8 to 10 years back. And this, by and large, shows, if you see this graph, it shows that the Nadir weight from roughly about 44 reached about 30 and then went up to 35. But after a re-sleeve, again, there was a decline in BMI. And this BMI actually went down to nearly 30. And the excess weight loss after a Nadir weight, after a regain of weight, was nearly about 70%. But then there's a caveat there. The caveat is, in the present series, only patients showing the persistence of a large part of the gastric fundus on upper GI series were considered for revision, thus suggesting that revision of sleeve by a sleeve will probably work if there is an enlarged fundus. That means maybe there's something wrong with the primary surgery. So enlarged fundus, a large antrum, probably a re-sleeve may work. Again, next statement, revision of LSG for insufficient weight loss or weight regain in the presence of a persistent of the gastric fundus on upper GI series is technically feasible and leads to good results and resolution of comorbidities in the short term. So we were doing re-sleeves initially. We found the results weren't very good. We started doing banded sleeves. And again, we found that at the end of 3 years, our own data says it's the total weight loss from the Nadir weight was anything around 12% at the end of 3 years. Again, not satisfactory. So what has been described in that paper is what we follow right now. We would only and only do a re-sleeve with a band in patients where we find that there's an enlarged fundus or a very large antrum, somewhere where probably the initial surgery or the primary surgery was incorrectly done. Otherwise, we would not opt to do any re-sleeve in a patient where a revision sleeve. We would opt to do any other procedure rather than doing a re-sleeve. So this is a ring that we generally would apply in any patient that we do a re-sleeve. This is a minimizer ring. It was shown by Dr. Narvaria as well. And we'll keep it at 7.5 centimeters. So that's a standard that we keep. So this is 7.5 is what we keep loose on the sleeve. But even then, like I said, at the end of 3 years, the weight loss was, total weight loss was just about 12%. So our indications for doing a banded re-sleeves are very, very limited these days. Two important statements. One, laparoscopic sleeve gastrectomy has become the most utilized bariatric procedure worldwide. According to IFSO in 2018, it was 45%. Probably it's at about 53 or 54% now. The other important statement, however, many patients undergoing secondary surgery following lap sleeve for inadequate weight loss or weight regain is anything between 2.4 to nearly 20%. And most of the data is showing this percentage. Comparing conversion to one anastomosis gastric bypass or Roux-en-Y gastric bypass, now that's a very nice paper which was published this year. So from Nadir, looking at Roux-en-Y gastric bypass at 28 months, 29 months in fact. Roux-en-Y gastric bypass total weight loss was about 20-odd%, while Oagb was 25%, statistically significant. At the end of 5 years, Roux-en-Y gastric bypass is at 16%, while Oagb is at 23%. So they concluded that conversion of LSG to Oagb compared to RYGB results in increased weight loss, but a higher risk of GERD and potential nutritional deficiencies. So by and large, if we see the literature today, the conversion to RYGB after from a sleeve is only and only for patients which have intractable GERD, not for weight loss. This is a short video of how we do when we convert our sleeves to a Roux-en-Y gastric bypass for patients who have intractable GERD. Now, these are patients who may have just had a little regain of weight, not significant enough, but primarily are coming for intractable GERD, which is not, they're not responding to medical treatment. Crural dissection is extremely important. Lengthening of the esophagus is extremely important, which we would do in all our upper GI procedures, as well as primarily for all our fundoplications as well. We generally would use one of these barbed non-absorbable sutures to suture the crura. So crural dissection, like I said, extremely important. It probably may require just 1 to 2 bites, but we would always close the crura. Once we've done that, as you can see in this patient, a large antrum, then we would convert that into a Roux-en-Y gastric bypass, a short pouch. Once we've gastrotomy, and here in these patients, like I said, the weight loss, these patients don't require too much of a weight loss. Primarily, these patients require a treatment for GERD. So we would generally keep the biliopancreatic limb at about 80 centimeters, do a gastrojejunostomy. We generally do it by an omega loop fashion, so everything in the supracolic compartment. Thereafter, just making it a roux. Then closing the gastrojejunostomy by an absorbable sutures, jejunojejunostomy, and then followed by closure of the mesenteric defects and the Peterson's defect. We would generally keep the elementary limb at 70 centimeters. So biliopancreatic at 80, elementary limb at 70 centimeters, closing the crura is what we would do for these patients. This was a paper which was published by the French registry, and they said that the rate of revision surgery after sleeve gastrectomy actually goes up over the years. So from 4.7 to 12.2% from 5 to 10 years. And most of their patients were actually converted into a gastric bypass. They didn't mention whether it was a Roux-en-Y or an Oagb or a re-sleeve. And they, of course, found that the complication rate was 3% more than what you would get in a primary surgery. Two important statements again. Development of GERD with post-operative incidence reported to be between 7 to 20% in sleeves over a period of 8 to 10 years. Again, a 10-year follow-up, excess weight loss 71% at 12 months and goes down to 53% at 10 years. If you look at the total weight loss, it could be 23.2 at 2 years and goes down to about 16 at 10 years. And therefore, these patients will require a revision surgery. How about Oagb? Excess weight loss at the end of 12 months, fantastic, almost 84.9, total weight loss of nearly 29. And if you look at the last day of follow-up, which was nearly 19 months in this study, they found it was still at 72 and the total weight loss at about 24%, which is extremely good. And they mentioned that Oagb is safe and effective for weight regain post-sleeve gastrectomy. And in all these patients, the biliopancreatic limb was kept at 200 centimeters. So one of our videos, we generally would keep in all our sleeves, which we convert to Oagb, we would keep the biliopancreatic limb at 200 centimeters. Some additions you would always find with the liver in certain cases, dissecting dissecting at the lesser curve, firing the first stapler just distal to the incisura in the antrum, a long gastric pouch. We always size the pouch as well. It's a malabsorptive procedure. There could be an argument you don't really need to size the pouch, but we always do that. And thereafter, of course, a gastrojejunostomy at 200 centimeters. Side-to-side anastomosis closure, and we would always do a leak test in all our procedures, primary or a revision surgery. What about single anastomosis duodenal ileal bypass? So no, this the cohort was only of 8 patients. The data this paper has been published this year. No short-term surgical complications were found in this group of patients. They found that the BMIs actually went down to, after doing a sleeve, went down to about 25 or 26 was nadir. Then it went up to about 33, 34. After a SADI at about 12 months, it was again gone down to about 22. They didn't find any major complications except diarrhea. Stools were 2 to 3 times a day. Apart from that, nothing, no other complications. But then these were not Indian patients. These were Caucasians. So obviously, now this comparison of one anastomosis with SADI-S at 18 months, total weight loss was nearly about 22% in Oagb, while in SADI-S it was 27%. Excess weight loss was 52 vis-a-vis 65.78. When they looked at resolution of comorbidities, they found by and large similar, except there were nutritional complications in SADI-S, which is expected because most of their anastomosis was at 300 centimeters proximal to the IC junction, while at Oagb it was 200 centimeters from the DJ. So that's the difference, and that is why more complications. Zinc levels went down further, vitamin D levels went down further, protein levels went down further, and all were statistically significant. And in Indian patients, probably more significant. They concluded that both SADI-S and Oagb are effective and safe revisional procedures for weight regain after a sleeve. Short-term outcomes are comparable. However, SADI-S is associated with less upper GI complications, and we can understand that because the pylorus is intact. Could be a better option for patients suffering from GERD post-LSG. Moreover, the underlying bile reflex may get worse with Oagb. So they thought that probably in all these patients where the reflux was an issue, a SADI-S is probably a better procedure than an Oagb. So finally, friends, in conclusions, revision of sleeve for insufficient weight loss or weight regain in the presence of a persistence of gastric fundus on upper GI series is technically feasible, leads to good results in terms of loss of weight and comorbidities in the short term. Well, I would say if I look at all the data which is present right now, a re-sleeve with a band would probably be an option only if there's a very large antrum or a very large fundus Otherwise, it's not the right procedure. It would not give a good weight loss in the long term. And therefore, as far as possible, a re-sleeve, even with a band, should be by and large avoided, except, like I said, for a large antrum or a large fundus. Conversion procedures are safe and feasible for weight regain or inadequate weight loss following a sleeve. Conversion to OAGB results in increased weight loss but a higher rate of GERD compared to RYGB. So coming to my next point, any patient coming with GERD, invariably it should be intractable GERD, it should be an RYGB. The question is, patients having a BMI more than 50 and having GERD, what do you do then? So we'll come to the next statement there. SADI, if the BMI is above 50 post-sleeve failure and the patient is without GERD. So they say without GERD, but the next statement is with GERD. So if you have a GERD and a BMI more than 50, you know this patient requires a good weight loss. And at the same time, RYGB can probably settle the GERD, but may not be very good for weight loss. So I guess SADI-S would probably be the option for patients who have a BMI more than 50 with GERD. Less than 50 with GERD, RYGB probably would be the answer. Less than 50 without GERD, OAGB probably would be the best option. This is what they have said, Mohammed and Jamal, and they said we do not perform a re-sleeve. Finally, both SADI-S and OAGB, MGB are effective and safe revisional procedures for weight regain after a sleeve. The short-term outcomes are comparable. However, SADI-S is associated with less upper GI complications and could be a better option for patients suffering from GERD post-LSG. Moreover, the underlying bile reflux may get worse with OAGB, and therefore suggested OAGB may be avoided in cases where the patient has got GERD. Thank you very much. And again, I would like to thank Dr. Suviraj, Dr. Sudhir Kallan, and the team of Sir Gangaram Hospital for inviting me here. Thank you.
Thank you. Sarfaraz, you've got 2.5 minutes of Q&A's time. Over to you.
Yeah. So Dr. Randeep, excellent presentation, so comprehensive as well as some clear messages. I would like to take a spin-off from this talk. For any bariatric surgery, especially when you're talking about sleeve is easy to revise compared to Roux-en-Y and OAGB. Do you think that is one of the reasons why people are more happy or there is more frequency of revision of sleeve? Do you think that's one of the major reasons?
I totally agree, Sarfaraz. That's one of the reasons why sleeves are revised more than what an RYGB or any other procedures are. And it's easy to revise, and that's definitely one of the reasons. Of course, we know long-term data is showing that 20% patients will regain sufficient weight, and they will come into the criteria where a revision can be offered to them, and that's one of the reasons as well. But yes, easier revision is definitely one of the reasons. Sure.
So would you tell us whether there is any way of finding out which patient is going to do well with revision? Is there anything out there in the horizon telling us, okay, this patient is good for revision, this patient is not good for revision? Because, you know, you could do a sleeve to an OAGB. Again, if this patient comes back with a weight regain, with an added malnutrition, what next? So we are looking at younger patient living for another 40, 50 years. So some wisdom out there from you, please.
So I think I'll go back to absolutely the primary thing which we need to do if a patient comes with a weight regain is counseling, and don't rush in to do a bariatric procedure. Send them to your nutritionist, send them to your psychologist, tell them to go through an absolutely constructive nutritional program. Ensure that they lose some amount of weight, they are following up, and they are compliant. The ones who are compliant and are the ones who are going to do well with one of the revision procedures. The ones who are not compliant and you hurry up to do a revision procedure, you be rest assured those patients are again going to fail the second procedure. So I feel one needs to be absolutely sure and give a lot of emphasis on counseling, and then only take up these patients for a revision procedure.
Dr. Sandeep and Dr. Mahinder both have raised their hands. So I think we'll go with Dr. Sandeep first. He raised his hand first.
One quick question, last time, about a minute for that.
Hi. So Randeep, excellent talk. Just two quick technical points. One is, even if the patient does not have reflux and is being operated for weight regain, I think we always dissect the hiatus, because we haven't found a single case where there's no hiatus hernia actually. In all our revisions, we have found a hiatus hernia, irrespective of the fact whether they had GERD or not. So I think it's always, so I think to say that sleeve is easily revised, I think if you are in the practice of doing a complete dissection to the hiatus, it's really not easy, and it should, but that step should always be done. Point number one. And two was about resizing the pouch in Oagb. I would slightly disagree, because the rate of complications, I mean, if you have a small excess fundus, I would just leave it if you are doing an Oagb with 200 centimeters, because the chances of leak are high. And so that's why we have stopped resizing the pouch, restapling or removing the excess fundus if it is not too big. We can put, maybe if you are too particular, put some sutures, don't restaple it. Those are the 2 points.
Yeah, I think we're out of Q&A time. We'll have to invite the next speaker.
Okay. Yeah. Can I answer that question? No. Okay.
Okay, quick answer, and then we'll.
Thank you, Sandeep, for those queries. I totally agree. The hiatal dissection is absolutely paramount in all revision surgeries. Even when you're revising an RYGB, you'll find that those crura are still wide apart, and you probably require to put a couple of sutures there. Resizing the pouch, I would, by and large, as a matter of fact, I would do it in all patients if I find that it's too large, irrespective of the fact that these could be malabsorptive procedures. That's a protocol that I follow, but I agree you can very well leave it as well. Thank you.
Thank you. Thank you. Thanks.
Thank you very much. Maybe I'll just introduce our special invitee, Dr. Ricard Corcelis. He's a senior staff surgeon at the Digestive Disease Institute at the Cleveland Clinic in Ohio. He's a global surgeon. He's originally from Barcelona in Spain, as well as he's worked at the UAE. Over to you, chairpersons and moderator, to bring in Dr. Ricard.
Thank you, John, for the invite, and all the team for the Sir Gangam Hospital. I don't know if you can see my screen.
Yes, we can. Ricard, you can.
Okay.
Please go ahead.
Perfect. So my topic today, let me see if I can just play. Yes, so I'm going to talk about the one anastomosis gastric bypass and when to revise the technique. Now, as all of you know, the concept of a loop gastric bypass is not new. It was firstly introduced by Mason in 1967, and at that time, it was already shown that it was a reflux-inducing procedure. Now, the technical details of the operation, I'm not going to explain that much. We have a fantastic expertise on the field here in the podium now. But basically, there are several variations of the technique described by Lee or my colleague Carbajo, in which the anastomosis can be side to side. But the potential advantages are clear. It's easier to learn and to do. The learning curve is shorter, it's around 30 cases. OR time, of course, can be reduced. And that translates in a low perioperative morbidity. In addition to that, there's one less anastomosis. So it looks like the Oagb would be the ideal procedure. Apparently, it's very safe, effective, easy to do. It's clear that shows an improvement on comorbidities and substantial weight loss over time. Quality of life has been reported. It's also more than acceptable. There are no risk of hernias, and it's reversible. So this is the reason why the technique has been spread out all around the globe. Now, this is data from a recent study published by Ligia Griziani. This comes from a Bariatric Surgery in 2018 now, and you can see in blue color how Oagb is around 7% of the cases, and that's important because
online.
Sorry?
Randeep, can you mute yourself, please? Yeah, Dr. Ricardo, please go on. Sorry about the trouble.
Yeah, no problem. I was saying that it's been an increase, progressively increase on the technique over time. But this increase is even more substantial when you look at data from the Asia region and the Middle East. No, you can see that the percentage of one anastomosis gastric bypass is around 20%, and this is much more when compared to other regions in the globe. No, so again, apparently there is no OR risk because we avoid the second anastomosis. There's no risk to close mesenteric defect. And that's a potential advantage over the Roux-en-Y gastric bypass. The learning curve from the Roux-en-Y is longer, that's true. And supposedly it's easier to manage complications at the gastrointestinal anastomosis after a mini gastric bypass. But is that all true? I just want to put here on the presentation and comment on the Omega trial. As all of you know, the Omega trial is a prospective RCT involving 9 high volumes hospitals in France. The main outcome of the study was weight loss, and patients with GERD and esophagitis, as well as with Bariatric Session were excluded. This was a 1-to-1 randomization, mini gastric bypass with a Bipolimab 2 meters versus Roux-en-Y, 150 and 50, 1-to-1 randomization again, and around 100 patients per treatment arm. You can see that the outcomes on the right side of the screen, when you look at the percentage of excess BMI loss, those outcomes favor the mini gastric bypass with an excess BMI loss around 89%, whereas on the Roux-en-Y it's around 77-78%. Regarding diabetes remission, there were no differences among groups, but the study was not attempted to compare diabetes. Again, it was on weight loss. But the investigators of the Omega trial also reported the following results and conclusions. So regarding intraoperative complications, there was no difference among groups. It was a little bit higher in the mini, but it was not statistically significant. When you look at early post-op complications, the same, no difference among both groups. And regarding late complications, again, the same, no statistically differences. 20% Roux-en-Y, 16% mini gastric bypass. But here is the thing, when they look at the serious adverse events based on the Dindo-Clavian classification, the mini gastric bypass had almost twice complications. So overall complications for the mini were 67 patients versus 38 within the patients undergoing the Roux-en-Y, and the p-value was strongly significant. When they also look at the surgical complications, those were 42 versus 24. Again, more complications within the mini gastric bypass group. And of these complications, 20% were nutritional, and 10% of patients required conversion from mini to Roux-en-Y gastric bypass. Not only that, a subsort of almost 50% of the patients had endoscopy follow-up over time, and they found that almost 20% of patients had bile in the pouch, 10% of patients had esophagitis, and 1 patient intestinal metaplasia. Whereas the more important thing here is that no patients undergoing Roux-en-Y had bile in the pouch. So my point here is a mini gastric bypass the holy grail? I don't think so. We don't know the degree of or the grade of gastritis. Bile reflux is very significant. Marginal ulcer is approximately at least double the one you can find after the Roux-en-Y. And malnutrition is truly a real concern. So with the popularity of the mini gastric bypass, of course, more complications have been reported after the technique. However, it's very little the information we have for the publications on conversions after mini gastric bypass. Let me just point out this study, which was published by it was a multi-center retrospective review involving the group of Eric De Maria and Aurora Pryor. This study comes from 5 database centers in the US. They identified 32 patients that required conversion from the mini to the Roux-en-Y, and bile reflux was the most common complication. Unfortunately, this type of reoperation is complex technically, and they found they reported 3 leaks, which means like 10% of leak rate, which is high, obviously. And other complications of the mini at long term, which are more concerning, are the potential risk of esophagitis that can develop on intestinal metaplasia and hypothetically risk of cancer. This is a study that we published when I was previously at Cleveland Clinic Abu Dhabi. This is our experience of conversion from mini to Roux-en-Y. This is so far the largest series ever published in the literature, and it's a humble series involving 16 patients. Now at the Cleveland Clinic in Abu Dhabi, I know that they have more than 35 patients, and they are working on reporting and publish this updated data. So again, the study is about 16 patients. They were converted from the mini to the Roux-en-Y, and the mean interval time between the initial mini to the Roux-en-Y was 2 years. The reason for conversion is here in the table, but and those are the imaging studies that we used to find in these sort of patients. Abundant bile in the pouch. Here you can see an anastomotic ulcer, more ulcers at the afferent and efferent loops. Some patients even have stenosis at the anastomosis that requires balloon dilation. But again, at the end, those patients end with a revision. The operative details in this study are shown in the screen, but basically the majority of them were, the revision was completed laparoscopically, 75% versus 25%. Estimated length of stay is substantially longer than in a usual revisional case. It's approximately 5.5 days. Here is the technique that we develop when we convert those sort of patients. I'm going to play a quick video. If I'm extending a little bit too much, just let me know, and then I'll fast forward the video. But basically, the operation starts. The first thing we do is we measure the length of the efferent and afferent limb. In this case, this patient had a very short efferent limb. This is a lady, 31 years old, female patient with profound malnutrition. She had anosarca. She had a complete depletion on iron levels, and she was admitted in a hospital for TPN for 3 weeks before the operation. That patient had a very long afferent limb that can explain why the patient had this profound malnutrition. Then we start dissecting the pouch. I like to do the retrogastric approach. I used to use this instrument, which is like a Goldfinger that can easily and very nicely help you dissecting planes. Once the pouch is dissected, we transect the anastomosis, of course, over the previous one, and we create a small tiny pouch, which is about 15-20 mLs. Once the pouch is created, we proceed to divide, which was the previous Oagb anastomosis. You can see in the screen how the assistant is pulling up the B2 anastomosis, and next step is to divide the mesentery of the efferent and afferent bowels. We use in this case, we use the 10 load. So again, you need to reconstruct the intestinal continuity before you can do the anastomosis, because in this case, for example, it was not viable not to do a third anastomosis. Sometimes you can avoid that, but in the majority of cases like this one, you have to do this third anastomosis, which is that reestablish the continuity of the small bowel and then do a standard Roux-en-Y. So complications, early complications are more than you would expect, because that is related to the technically complexity of the case. The majority of them were related to superficial surgical site infections in the cases that required open surgery or conversion to open surgery. There were 2 cases of reoperations and 5 patients were readmitted. 2 of them due to an acute cholecystitis, 1 then due to persistent nausea and vomiting, and 2 patients due to wound infection. So as a take-home message, I think that I'm staying on time, but I would like to say is that conversion is feasible technically, although it has more complications than one would expect. And we need further studies at long term to really know what's going to be the future of Oagb. Finally, my humble recommendations are, and this is based on my experience on revisions in these sort of patients, is that, and here we have experts in the podium that do Oagb frequently. We don't do in Cleveland, but as far as I saw in Abu Dhabi, I think that the pouches have to be really very long. You can't do an Oagb using a pouch the same size like a room wide. First thing. Second thing, I think that you should be measuring the whole small bowel. Third thing, I believe that the Peterson defect should be closed. And finally, the fourth and more important aspect here, I think that those patients should have endoscopic follow-up. If you do these 4 steps, I think that the Oagb is a more than acceptable procedure. But the problem is that if you don't follow these 4 standards, then you end up having a lot of complications. And I think that with that, I can conclude my presentation. Thank you.
Chairpersons, you have 2 minutes of Q&A time left.
Is Dr. Tarun Mittal or the other co-chairs here?
Amar is here. Amar is here.
Amar, would you like to?
Right.
Yeah.
Hi, Dr. Sarfraz. This is regarding actually the talk. It's a nice presentation regarding Oagb. So one question to Dr. Richard. Did you see any patients with weight gain after Oagb? So if patients gain weight after Oagb, what will you do?
Well,
you have been talking about the complications, right?
That's an excellent question, and I did see few patients with weight regain after Oagb, and in those patients, I think that you have to be very careful trying to indicate a surgical salvage therapy. I don't think that surgery is an option in these patients. I think that those patients have to go to a multidisciplinary team and an obesity medical comprehensive program. I don't believe that those patients, by converting them to a room wide, that is an option. I don't think that you should be indicating surgery for weight regain after Oagb patients. In my opinion, those patients, as it has been said before by someone here in the podium, we have to be very careful not spreading the message that every single surgical candidate is for revision.
Yeah, Dr. Ricard, can I compliment you about the presentation, and as well as have a couple of questions, Dr. Ricard?
Thank you.
Sure. So I think that you did mention about your revisions in terms of complications. Chiefly, I think you mentioned malnutrition, and you showed a video of conversion to Roux-en-Y. Would you have done otherwise, just reversing it with a gastrostomy instead of doing a Roux-en-Y? What are your thoughts on that conversion?
Yes, I think that that's again an excellent question. The majority of my cases have been revisions from Oagb to Roux-en-Y because of a profound biliary reflux and consequences about reflux. You're right. In terms of malnutrition, you have the option of a reversal to normal anatomy. We've done in a very, very few patients and selective patients, just and the minority of them which are not included. But that's another option. Technically, it's doable, and you can think about that. I would say that my preferred option would be a Roux-en-Y, absolutely. And that also is under a medical comprehensive program behind. Absolutely.
Yeah. Yeah. And my second question is, did you see these cases of malnutrition in patients with large BP limbs or even with patients who had less than 200 centimeters BP limb?
No, I think that the majority of them have a very long BP limb, like this case that I mentioned. No, this specific lady, for example, the upper GI series, you could see easily how the contrast was directly going almost through the large bowel. So, because of the very short efferent lobe and a very long BP limb. Again, you can see malnutrition in a standard BP limbs length, but the majority of them are very, very long BP limb. That's why I was saying that I think that you should measure the whole bowel if you do mini gastric bypass, because of the variety of the length of the bowel. If you do always a 250 or 200, and what if the patient has a 4 meters bowel? I mean, I think that that's the main point and take home message. If you do this, I think that you should measure the whole bowel.
Point taken, Dr. Ricardo.
Thank you. We're out of time completely. I'm going to request the moderator and chairpersons to move on to the next talk. Thank you very much, Ricard. Raman, could you comment briefly? I failed to introduce you to Raman Goel, the past president, immediate past president of the IIGS, senior bariatric surgeon and mentor to all of us. Sir, would you like to introduce, or maybe I'll request Dr. Amar to introduce the next speaker?
Okay, I think, yeah, Amar, please go ahead.
Yeah, our next speaker is Dr. Mohit Bhandari. He is an excellent surgeon and he is well known throughout the world. He has been very active in conducting several programs. Now he is showing a lot of interest in endoscopic procedures, and he has been forefront to popularize these procedures like endoscopic sleeve gastroplasty and revision from sleeve to endoscopic revision. So he's from Indore. He's the founder and director of the Mohak Bariatric and Robotic Surgery Center. And now I request Dr. Mohit Bhandari to share your experience with endoscopic bariatric interventions. Over to Dr. Mohit.
Good afternoon, everybody. This is Dr. Mohit Bhandari from Indore in India. And at the outset, I would like to thank Dr. Suviraj John and the entire team there at MASC 2022 to have invited me for this particular lecture. Endoscopic Bariatric Intervention 2022 and update. I bring greetings from Indore, from Sri Aurobindo University and Mohak Bariatric and Robotic Surgery Center. I work with Professor Manuel Galvao, and I'm a consultant to Apollo Endosurgery, Pentex and Olympus. So I leave it to your wisdom to judge my lecture in the light of my disclosures. Manuel Galvao joined Mohak Bariatric and Robotic Surgery Center around a year back. And he's the director of bariatric services, bariatric endoscopy services here at Mohak Hospital. So the first 5 years of my international exposure was built in by Professor Phoebe, and we still continue. And Manuel is the next one to expose India and our department to the most international modalities we have. And now this has become a household name. I've done close to 17,000 bariatric procedures at Indore and around 2,000 procedures outside Indore at different other centers like Mumbai, Hyderabad, and Ahmedabad. But more importantly, we have contributed extensively as far as India and Asia is concerned to the endoscopic procedures in last 4 years. So you can see that we have done a couple of swallow balloons, endoscopic sleeves, and several others. And that has made, a very interesting and remarkable difference in the kind of case mix we have. So like any other center, we started from sleeve gastrectomy and now our journey with the swallow balloons. But we know that endoscopic treatment or endoscopic bariatric therapies, they play a very important role. because everybody cannot undergo bariatric surgery. And at the same time, we know that most drugs which have been approved by US FDA are just giving 5 to 7% of total weight loss. Whereas bariatric surgery is 30 to 35% of at more than 25% of total weight loss. We need something in between them. So, we have this endoscopic sleeve, intragastric balloons, and several others in between the pharmaceutical and the RYGBs or the sleeve, which we talk about. And that's why they play a very important role. At the same time, we also understand that there are certain patients who have complications due to bariatric surgery, or weight recidivism or weight regain due to bariatric surgery, who gain by endoscopic bariatric procedures, as revisional surgery is still complicated. Still, most centers will not be able to do it because of maybe more complications, more issues. So that's the role of endoscopic bariatric procedures. They are lesser invasive, they are easily reversible, the cost is obviously, if we consider the total cost of admission in surgery, the cost overall comes low with the endoscopic procedures, and they have a very good repetition capability. So if we talk about the primary therapies, let's discuss today about the swallow balloon, the intragastric balloon. Why I keep the swallow balloon before the intragastric balloon? Because I personally feel that after we have the swallow balloons, which can be put in a 5-minute outpatient procedure without endoscopy, without anesthesia, there is no need for us to go for the intragastric balloons. I don't think they have any future, because why do you have to give anesthesia and intubation for patients who, can do this in a 5-minute outpatient procedure? At the same time, we'll discuss about the endoscopic sleeves and then the nutrient diverting therapies like the endobarrier, the mucosal resurfacing, and the magnetic anastomosis. But and also, the revisional procedures like the argon energy source with the pouch tightening and outlet reduction for weight regain. Let's talk about the primary therapy. So first, let me discuss about endoscopic sleeve. We're the first one in the country to start this procedure. It's very simple. There's a overstitch device by Apollo which used to suture, and this particular device is a little complicated because if you do a full thickness endoscopic suturing of the stomach, starting from the antrum, coming up till the fundus of the stomach, and that's the device where Proline 20 suture is being used.
Prepare to load the needle body by closing the needle driver handle.
What we principally do is, take full thickness bites by this particular device and oppose the mucosal surface of the stomach. So healing basically takes place by mucosa and serosa, but it's a full thickness bite. And if we see here, I think most surgeons would know what exactly endoscopic sleeve would mean, but this is the device, and once these sutures are taken, this is a cinch which is used to basically keep the device in place. So this is, very simple procedure of full thickness endoscopic suturing, and very popular also. At the same time, we have now the single lumen device. We don't need a double lumen scope to do this particular procedure, and it does exactly the same what the single lumen device does. Basically create a tubular stomach, just like you see in laparoscopic gastric plication. And this can be done by endoscopy. There is no incision on the skin of the abdomen required. And we are just coming close to 1,000 of these procedures, which is the largest volume probably in the Asia Pacific region taken together. Our center after Manuel joining us. It's a complex procedure, definitely, and it involves a lot of instrumentation because India doesn't have a double lumen scope, single lumen scope or device, pardon me. So we are using the double lumen scope still, and we use this Apollo overstitch device, which has there's a needle exchange catheter there. So that's there, the needle exchange catheter. This is the Apollo overstitch device, and you can see the device is mounted on a double lumen scope like that. There are different suture patterns. I'm not going to go into the details of these patterns, but these are the different suture patterns you can use. At the end of the day, the ultimate aim is to reduce the lumen of this particular stomach. And once the lumen is reduced, we get something like a sleeve gastrectomy. Again, you can see this is a helix which is pulling the tissue. We use a full thickness device to take the suture. And once the suture is taken, we can, oppose the 2 layers of the stomach to create a tube. something like this, where there is a principle of delayed gastric emptying. You see a very thin tube, just like this. And when we do radionuclide studies, we feel that there's a delayed gastric emptying here. So 240 minutes, the radionuclide does not come into the pylorus. And that principle is exactly opposite to sleeve gastrectomy, where we find that it's very different. In sleeve gastrectomy, you have a GLP-1 secretion. We all know that there's a fast transit time. So this is how it looks from inside. So you can see I have both the endoscopic and gastroscopic view. A nice tube being made, and this is something very interesting. You will not find this video anywhere else, because what you're seeing here is both the things. So you see here, this is the laparoscopic view, and at the same time you see here the endoscopic view. So how it looks in laparoscopy when we deal in endoscopic sleeve. Usually never put a laparoscope, but this was a special case where the patient had very severe non-alcoholic steatohepatitis, and this guy was referred to us by a gastroenterologist. He wanted liver biopsy, so we did a nice laparoscopy. Again, the physiology is of a delayed gastric emptying, you can see here. And if we see the procedure, this is the helix pulling the tissue, and we take full thickness bites. And this is done in a U-shaped pattern. We don't go towards the lesser curvature of the stomach because it obstructs the lumen. And that's how we create a very nice lumen, by taking this full thickness bites. This is our experience at Mohawk Hospital. We have done cases where we had a very good weight loss of 20% at 12 months, almost fantastic resolution of comorbidities, and we published this as a standard procedure. Along with us, Barham Abu Dhabi and several others across the world, including Lopez Nova, Manuel, published, but merit trial is very important, which paves the way for US FDA approval of endoscopic sleeve gastroplasty. Most of the studies would say that 7 to 9 cases the learning curve. My personal experience is 35. And this particular study by Sharia et al. Expresses that 35 cases are required to establish some sort of competence in endoscopic sleeve. And I agree with this kind of studies. I think more than 40 cases would be required. We published the first Indian experience of endoscopic sleeve, and me, Manuel, and Dr. Mathur and several others from our center, including Dr. Fubi, published this study. Most studies, if you see across the world, would say that endoscopic sleeve would have 10 to 15 to 20% of total weight loss at 1 year, which is very good. Another procedure called as post-2, the same principle of gastric apposition, but the device is loaded through a different scope. It's a pediatric scope. This is the same like endoscopic sleeve, but here they say that this is more durable. We are starting with the post-2 program at our center very soon, so we will come up with our own data comparing endoscopic sleeves with the post-2. So I'm not going to go into a lot of these, but I will talk something about the swallow balloon. So this is the new program we started at Mohawk Hospital. It's no surgery, no endoscopy, no anesthesia balloon. Patient will use to swallow this balloon, then it is filled at the same time. It's a 5-minute outpatient procedure, and patient can go home. The balloon passes in motion after 6 months. So we have done 110 cases till now. Fantastic weight loss at 2nd month of around 7.80%. This is our video, so you can see that this is being done inside the hospital. You give the capsule to the patient swallows it with water very easily. You take an X-ray and confirm that the pill is inside the stomach. So the patient takes an X-ray, and once the X-ray is confirmed, you do the filling of the tube. And once the filling is done, as it's seen here, another X-ray is taken to confirm that the tube is particularly filled. And then, after the second X-ray, which is being done, and you see that the balloon is in place, the tube is being removed, and the patient is discharged. This entire process takes 5 minutes to 7 minutes. And I think all these balloons, Orbera, Reshape, Spats, Ellipse, the Ellipse one is a 550 ml balloon, which I think by Allurion technology is going to survive the test of time. Rest all balloons, when you talk about, either they have very poor tolerability, or the weight loss is not sufficient and bad GQLI score, and giving anesthesia for 2 times to put in the balloon and to remove it will not, make them very popular in times to come. Endobarrier sleeve, another procedure which is based on the foregut hypothesis. We put a silicon polyethanol tube called as endobarrier, and we all know the mechanism that as the food will pass, bypass the first and the second part of the intestine, the foregut comes into play, and that's the area where the benefit of type 2 diabetes is being taken, as we all of us know. So this is just to mention here, this still being done at different, at different locations just as a part of a study. The first device went out because of a lot of liver abscess, DO perforations. The second device again is being tested now. It's still not approved for the clinical use. Let's talk about the magnetic anastomosis. Again, this is something which is still not approved for the clinical use, but it's very interesting. It might, in 2 or 3 years to come, might become a standard of care. So endoscopic sleeve in combination with magnetic anastomosis can become the standard of care, just like a gastric bypass. You can see this kind of procedure coming up in future, and the studies are going on. Manuel is working on it, and hopefully we'll be able to do first of its kind in India. So you see on laparoscopic evaluation, it looks so beautiful. This is the anastomosis here, and that's the kind of thing which we expect. And I think that's going to be the future of laparoscopy, the endoscopic procedure. Mucosal resurfacing, this is something which I'm getting involved with. The DMR project, it involves circumferential hypothermal ablation of the duodenal mucosa. The mucosa is lifted with the saline to protect the outer layers of the duodenum, and then the mucosal resurfacing is done. A very interesting procedure. And now what they're doing is that with this catheter, they burn the mucosa, and once the burning is being done, the ablation being done, this takes care of the type 2 diabetes. So you basically first lift the duodenal mucosa, and once the duodenal mucosa is being lifted, you give circumferential burns to it. Once the circumferential burns are given, you have a mucosa which is completely ablated, and that particular mucosa will not do absorption, and then that takes care of the diabetes. So this is, a lot of studies are being published again here also, but it's still, it will come to India very soon, where me and Manuel are going to bring the first DMR program, but we'll put our data forward. I'll not talk much about it now. The secondary therapies, as you know, for weight regains, revision surgeries, obviously you give an argon energy source where 65 to 75 watts at 2 to 3 liters of flow burns on mucosa. And what we see is this. So this is being done at our center very regularly. You see, this is a revision case for endoscopic sleeve, where you can again do an endoscopic sleeve and take care of the stomach which has failed. So this is the beauty. Endoscopic procedures can be treated. At the same time, you have the procedures where you can repeat them for n number of times, as much as you want. At the same time, as I talk about the argon energy source, you can give the circumferential burns, as shown here. These burns are given to create fibrosis and to create good base for the endoscopic sutures to be taken and to reduce the outlet. And then a full thickness suturing is done to reduce the outlet and also to reduce the size of the pouch. So again, this is being done regularly at our center. We do revision courses for bariatric surgeons who want to learn these techniques quite frequently, and me and Manuel would be glad enough to train all of you to do all these procedures. The same can be done for Roux-en-Y, and the same, as I said, give circumferential burns to the outlet. You can see here. And then obviously use a full thickness suturing device to reduce the outlet and the pouch both. We do regular courses on revisions on endoscopic sleeves for weight regain after sleeve gastrectomies, gastric bypass, and mini gastric bypasses, and we club them alongside the surgical revisions. And all of you are welcome to attend our courses. We'll announce the courses for this year, and you can register for these courses. So what I would say that the overall treatment for obesity requires a multidisciplinary approach. You need to have endoscopic technique in your armamentarium to treat a certain number of patients who do not deserve a bariatric surgery, who do not want a bariatric surgery, or who are very high risk for bariatric surgery, and that would, believe me, 90% of your practice. So if you do not have endoscopic procedures in your armamentarium, you are not a complete bariatric surgeon. At the same time, the other spectrum, the complications, leaks, bleeds, strictures, stenosis, and obviously weight regain requires endoscopy. So here is for you. You have to learn endoscopy. You cannot escape away from it. Dr. Phoebe taught me that whatever we do as an innovative approach, we should always maintain our database, put our data in a prospectively maintained audited database, and then assess where are we going. If we have negative results, we should report them. So a negative result is not a loss of face. It's just a reflection of your wisdom. Thank you very much, everybody.
Thank you, Mohit. I think that was an excellent overview of endoscopic procedures in India at the moment. I think if Suviraj, if you are allowed to have one or two.
Please, sir. Please. You have about 3 minutes. You could go on.
Thank you. So before the chairpersons take up the questions, just one or two. Mohit, since you have been doing endoscopic sleeve gastroplasty now for more than 3 years, what percentage of cases do you need to revise?
Excuse me, sir. Dr. Aman, I am Himanshu here. Actually, Dr. Mohit is inside the OR. So he's not able to join right now. He's with me, but right now he's in the OR. He's in a case.
Okay.
So sorry.
Okay, so this was a video then.
Yeah.
Thank you. No problem. So over to chairpersons, and I think it was a very interesting session, but I will invite chairpersons to have their final comments.
So thank you. I think it was an excellent session with a very comprehensive coverage of all the revision procedures. I have nothing much to add, I think, and thank you. Thanks.
So Suviraj, I think let's wind up here and hand over to and thanks to all chairpersons for conducting this session so well. Thank you.
Thank you. Thank you very much, sir. Thank you for your involvement and your presence with us. It's been an absolute treat to actually go through this, especially with your new, maybe you could just, I think this is really important. Could you just briefly introduce, the role of the Journal of the Bariatric Surgery, which you're carrying on a leadership role? Because we have with us, made a lot of young surgeons, a lot of young enthusiastic bariatric surgeons. They need to document, archive, and follow up on their databases, and you offer a wonderful place to platform their work. Would you like to introduce that initiative to them?
So Obesity Surgery Society of India has started this new journal, Journal of Bariatric Surgery, and it has an international editorial board. And we are likely to come with the first issue during OSCON in April. And this is a peer-reviewed journal, and we look forward to more and more publications from India and from other countries. We are trying to use it as a platform to encourage research awareness among the surgeons in India. So I'll be very happy. I see a lot of young faces on the screen today, and I would invite all of you to submit your articles. And we are very much in a process to encourage people to start keeping data, as Mohit was saying, and we are ready to help them analyze it and to help them publish. So I think it's a new territory for surgeons in India, and the more we get involved into it, the more we'll be respected worldwide, and we'll earn more respect for ourselves. So thank you so much, Suviraj, for giving this opportunity.
Thank you, sir.
To speak about JBS.
Thank you. Thank you very much. Thank you, all the chairpersons and all the speakers. I think we'll switch right over to the next session, which is the hernia session, and we are no person less than Dr. B. Ramana from Kolkata, who's a senior hernia and abdominal reconstruction pioneer globally, who's going to moderate this session. And I'll request him to invite the chairpersons. Ramana, do you hear us?
Yes.
And do you have the list with you, or should I call in the chairpersons?
Please. Please.
Yes. I'll go ahead by introducing the chairpersons for this session. We have with us Dr. Suresh Vashist, a senior surgeon and past president of the ASI from Gurugram. Meenakshi Sharma, prominent AWR minimal access surgeon from Gurugram and past vice president IAGS of the North Zone. Ashish Dey, consultant surgeon from Sir Gangaram Hospital, along with Dr. Neeraj Damija, consultant minimal access surgeon to Sir Gangaram Hospital, and Dr. Kedar Patil, who is a very experienced minimal access and AWR surgeon from Pune. Over to you to welcome our speakers, Ramana.
Thank you very much. So this is going to be a very interesting session, and I look forward to learning something from the speakers. So let's have, without any further ado, Dr. Mukund Khaitan. He's going to talk of something that sounds kind of new, boundary hernias. Please take over, Mukund.
Thank you, Dr. Ramana, for a kind introduction. So here, the topic given to me by Dr. John was to talk about the boundary hernias. So able to see my screen?
Yes.
So it's full screen or it's yeah. So when we talk about the boundary hernias, as we say, they comes in different sites and sizes and shapes. So you can see incisional hernia. They are more or less, most of the time, they are incisional hernias, secondary to some sort of an surgeries, either hepatectomies or nephrectomies or appendectomies or cesarean scars, or maybe splenectomies, and some tumor extirpative surgeries also leads to these sort of an incisional hernias, and they come anywhere in the abdominal wall, whether anterior or the anterolateral abdominal wall. So before coming to like how we define the boundaries of the abdominal wall. So anteriorly, when we see in the midline, we can see the xiphisternum above and the pubic bone and the pubic symphysis and the anterior ramus of the pubic bone on the either side. And then as we go laterally, we can see the costal margin superiorly and the iliac crest inferiorly. And then joining this iliac crest and the pubis will be an inguinal ligament down, and posteriorly we can see this between the costal margin and the iliac crest will be the lumbodorsal fascia. So these are the boundaries which are forming the anterior and the anterolateral abdominal wall. And these, any hernias which are close to this, plays a major role in terms of giving challenges to the surgeon for a surgical repair. So when we talk about the boundaries of a lateral abdominal wall, so cranially you can see the costal margin, caudally you can see the inguinal ligament and iliac crest, laterally you can see the paraspinous fascia and the muscles, and medially you can see the linea seminaris. That is the boundaries of the lateral abdominal wall. So before coming to the hernia per se, I just make you through some anatomical structures which are important when we talk about an abdominal wall reconstruction for a boundary wall hernias. So we should remember certain lines and certain spaces, and we should be very much familiar with them before venturing into the repair of these abdominal wall hernias. So the three lines which are important is in the midline, we can see this linea alba, which we all know that which are joining points of the aponeurosis of all the three muscles on the either side and forming the anterior rectus sheath, and then they combine in the midline to form the linea alba. Laterally, at the lateral border of the rectus muscle, you can see the linea semilaris, which is formed by the aponeurotic part of all the three lateral abdominal wall muscles and mainly contributed by the internal oblique aponeurosis. And then as you see, this is the posterior rectus sheath. So anterior rectus sheath is covering the whole of the rectus muscle, and the posterior rectus sheath ends somewhere between 3 to 5 centimeters below the umbilicus and as forms an arc, and which is called as an arcuate line or the semicircularis, linea semicircularis. Then coming to the spaces. So after those three lines, one should know about the spaces of the anterior and the anterolateral abdominal wall. So in the midline, we can see the pre-peritoneal space. In the epigastrium, we can see these two fatty triangles with the bases of them are apart from each other and their tips meeting towards the umbilicus. So in the epigastrium, it is a pre-peritoneal space which is formed by the falciform ligament, and in the hypogastric region, one can see this pre-peritoneal space by a pre-peritoneal fat pad or a perivesical fat pad. As we go laterally from the midline,
behind the rectus muscle. So these spaces behind the rectus muscle and posteriorly bounded by the posterior rectus sheath are the retrorectus spaces. And these retrorectus spaces, as laterally I told earlier, was bounded laterally by the linea similaris. So as we cross the linea similaris, so we will see the pre-peritoneal space or the pre-transversalis fascia space laterally posterior to the transversus abdominis muscle. So one should have a good idea of how to connect these three spaces and preventing injury to these three lines. Then something about neurovascular bundle. So at different three sections of the abdominal cross section, one can see in the upper third, the transversus abdominis muscle crosses the linea similaris and is ending, fleshy fibers are ending posteriorly in the rectus muscle. And as we go down, we can see this, the fleshy fibers of the transversus abdominis are ending at the before the linea similaris, and when we go down, so you can see the internal oblique is coming more medially. So this dotted line shows the linea similaris, and you can see the nerves are crossing this area and then piercing the posterior rectus sheath to supply the anteromedial compartment, that is the myofascial compartment. Here again you can see the nerve is traversing between the transversus abdominis and internal oblique, and then piercing the posterior rectus sheath and thereby supplying the cutaneous branches and the muscular branches to the rectus muscle. And in the endoscopic view, you can see this is the posterior rectus sheath, the rectus muscle on superiorly, and the neurovascular bundle climbing up like a lamppost sign as described by Dr. Manna et al. In one of their publications. So coming to our lateral abdominal wall hernia classifications. So the lateral abdominal wall is bounded superiorly by the costal margin, inferiorly by the iliac crest and the inguinal ligament, and medially by the linea similaris, and posteriorly by the paraspinous fascia. So these four boundaries, and then the anterior axillary line, an arbitrary line at the level of anterior axillary line divides it into an anterior and the posterior compartment. So anything between the anterior axillary line and the paraspinous muscle is a L4 zone, that is the lumbar area where we will see the lumbar hernias. Then the anterior compartment is further divided by an arbitrary line which is 3 centimeter above the umbilicus and 3 centimeter below, that is a 6 centimeter width. And when we draw a horizontal line, so it divides this anterior compartment into 3 compartments. The upper compartment, which is near the costal margin, is subcostal hernias. Middle part is called as the flank hernia, and the lower one near the iliac crest is the iliac hernias. And as we see, these midline hernias could be subxiphoidal, but we here, as we are talking about the boundary hernias, so we'll be talking about the subxiphoidal or maybe a suprapubic hernias, that is the M1 and M5 zone hernias. The lateral hernias, they all are having some or the other bony boundaries near to them, and they are all included into a boundary wall hernias. And then we talk about the width. So any which is less than 4 centimeter is W1 hernia, which is between 4 to 10 centimeter is W2 hernia, and any hernia with a width more than 10 centimeters is categorized as W3 hernias. And if there are recurrences, you can plan it as a yes or no. What are the principles when we talk about the abdominal wall reconstruction per se? So it talks about a tension-free approximation of a well-vascularized tissue, and the tissues can be under physiological tension. And then there is the core part of the abdominal wall reconstruction is reconstruction of the linea alba, which we call it as a central tendon of the abdomen. And that can be combined with or without separation of the abdominal wall components. And then the reinforcement of this repair with a suitable prosthesis, and ultimately the outcome should avoid surgical site occurrences. So what are the characteristics of these boundary hernias or maybe a lateral spaces? So these lateral space, they lack much of an aponeurotic tissue because there are more muscular tissue. Laterally, there are 3 muscles and less aponeurosis. And then this is a narrow space with a wide bony boundaries. So the space is narrowed. Posteriorly, the space is getting narrowed and having a bony boundary. So it gives you a lot of challenges when we deal with these hernias. And most of the time, the surgeries happening over there are a muscle cutting incisions, and which leads to a denervation injury and a retraction resulting in ultimately a bulge of that area. And there are higher chances of neurovascular damage. Why? Because the nerves are traversing between the nerves for a longer duration of time, and that is how they are more likely to get injured while doing a muscle cutting incision in these areas. And what are the other characteristics of these defects? So there is a higher proportion of muscle fibers than aponeurotic tissue, as I told, and the muscle fibers have a lower tensile strength, as we all know, and they are prone to larger and more broad-based defects. And this is why they are more prone for a more broad-based defects in the lateral hernias. And the defects are asymmetrically located because of the lateral position. And this asymmetric distribution of forces also contribute and thereby leads to an enlargement and disability of these hernias. Then secondly, the denervation injury per se leads to a region of weakness surrounding the hernia and bulge, and the overall bulge looks more than the total anatomical defect. Then something about the cross-boundary defects. When we talk about boundary wall hernia, one should know about the cross-boundary defects. So the cross-boundary defects are when the defects are extending beyond either the anterior or the anterolateral abdominal wall. Like a subcostal defects, like the certain subcostal defects are caused by a direct excision injury, and they extend beyond the costal margin into the chest wall or maybe into the diaphragm. Then the paramedian defects, as we talk about, so when they cross the linea similaris, they are called as a paramedian defects, like we know a primary hernia, epigastrial hernia, which is a paramedian defect. Then the iliac crest defect, when we do an type 1 hemipelvectomy, so these can lead to an iliac crest defects also. And then the parastromal defects per se are also categorized as the cross-boundary hernias.
Mukund, I must just tell you that you will have another 6 minutes to speak, so you can time yourself accordingly.
Yeah. So a role of CT scan is more important. This is an essential part to assess the size, the number and relationship of the abdominal wall defects. It also helps to know about the position and size of previously placed mesh. And it also used to assess the loss of domain in cases where the hernias are large, irreducible hernias. So I'll not go into details into these videos of the CT scans, how this, and they can come like a iliac scan, so M2, 3, 4 hernia with L3 hernia, or M1, 2 hernia with L1 and L4 hernias, or a caucus M1 with L1 defect, or maybe a L2 with an associated L4 defects. So what are the different approaches when we talk about? So I'm today talking mainly about an endoscopic or laparoscopic or minimal access approaches to manage these boundary wall hernias. So MIS approach can be a transperitoneal approach or can be an extraperitoneal approach. When we talk about a transperitoneal, we can do a laparoscopic or maybe robotic way. Similarly, extraperitoneal can also be done endoscopic or robotically. So what are the different approaches? Laparoscopic, we can do a TAPP repair or maybe a IPOM plus repair, a transabdominal retromuscular repair, or maybe an endoscopic RS and then the TAR repair. The same can be replicated by a robotic platform. Then the transabdominal retromuscular can be done robotically. And the other entity is a lateral ETAP approach where we don't cross the linea similaris at all without doing a transverse abdominis release. And the different planes of reinforcement when we talk about the lateral hernias. So it can be an overlay mesh above the external oblique aponeurosis. It can be an intramuscular or called as an interparietal plane where the mesh is placed between the external and the internal oblique. And then it can be in a TAR plane that is anterior to the transversalis fascia and between the transverse abdominis muscle and that fascia. Or it could be a preperitoneal between the fascia and the peritoneum, or could be an IPOM where the mesh is intraperitoneal. And the different procedural steps. But before telling that, the challenges during lateral hernias are a distorted anatomy, as we all know. We know that it has a muscle denervation, it is associated with bony boundaries. The supracostal and the retroperitoneal dissections are definitely more challenging. If there are associated midline defects, it becomes challenge how to access that areas. And then there are previous scars or previous meshes if the patient is having a recurrence, or there will be a lack of tough fascia because there are less of aponeurosis and more of a muscle tissue, and then the endoscopic deployment of a larger mesh. So port positions can be an ipsilateral port position if the defect is just approaching the linea similaris, or it is far away, at least 7 to 8 centimeters from the midline, or maybe in the contralateral area where the scar or the defect is approaching or closing near the midline. So what are the steps when we talk about here I am showing just a picture of the subcostal hernia. So retrorectus dissection initially doing an inferior crossover. Once the crossover is done,
Then you have to do a bottoms up TAR. So you can see the bottoms of TAR over here, and then a part of a top-down TAR so that we can combine these two TARs near the defect, and then we deal with the contents and reduction of the contents. And then the dissection goes laterally to go more, at least 7 to 8 centimeters beyond the lateral border of the defect. You see the lateral border, and then the superior dissection to go above the costal margin and dissecting into a pre-peritoneal space to, and identifying it by a transition like by this fat, and maybe you can see the diaphragmatic fibers they are interrelating with the transversalis abdominis muscles. And once this is done, then the posterior repair and anterior repair is done, and then a larger piece of mesh has to be measured. So it has to be tailored according to the size what we have dissected, and then the mesh is deployed depending upon the surgeon's preference. The mesh can be fixed or can be left alone. So here is a small video where you can see this is an ipsilateral placement of the ports, such as the patient is having a left-sided flank hernia. So we are dissecting into a retromuscular space. We can see the inferior epigastric artery above, and then we are dissecting close to the posterior rectus sheath. So here you can see that we are dividing the posterior rectus sheath near the arcuate line, and then started doing the transversus abdominis release. So this is the recursion in the neurovascular bundle above. So this is the posterior lamella, posterior rectus sheath, which is formed by the posterior lamella of the internal oblique muscle and the transversal aponeurosis. So once we divide, we have to remain in this plane, which is a pre-peritoneal, pre-transversalis fascia plane. And as we go up, we'll see that these muscle fibers becomes fleshy. As we go above, the transversus abdominis muscle from aponeurotic becomes fleshy. And then once the desired area of the transversus abdominis release is done, then the dissection goes into a lateral part over here. And then we go laterally all up to the retroperitoneum, and you have to see the psoas muscle and the iliopsoas over there. And once that dissection is complete and hemostasis is done, as you see now, we have done a lateral dissection. Now we are dissecting the contents down. So here most of them are the omentum over there. Even if the bowel is there, you can open up the sac, reduce the bowel, and then tackle the sac. So here the advantage is you can remove whole of the sac. You can utilize the sac for the posterior repair. In such,
we are running out of time, so wrap it up in a minute.
5 to 7 centimeters. So once this dissection is done, then a posterior repair is done. Once the posterior repair, you can use a barb suture or maybe a normal suture. And once the posterior is done, then you can do an anterior repair using a barbed or maybe a delayed absorbable PDS suture, or be a Prolene or a barbed PDS suture to repair the anterior defect. And then the mesh is measured and the mesh is deployed. And in most of the hair, it is a L3 hernia, and that is why the mesh is being fixed to the Cooper's ligament. Otherwise, in this space, hardly any fixation of the mesh is required. So there are a number of literature is available which talks about like anatomical consideration, how to do a lateral abdominal wall reconstruction, anatomy and technique for that, the surgical treatment of subcostal hernias, or an extraperitoneal approach for complex hernias, and a novel approach, like it all based upon a technique which is the Beliansky et al. With Dr. Ramanna have described, that is the ETAP approach, and the ETAP-R is an extension of that approach. And then there are other so many articles on the endoscopic management of these hernias. So the key features of successful endoscopic repair of the boundary wall hernias, when we talk about a subcostal hernia, as an inferior crossover is mandatory. One should have a flexibility of numbers and the placement of the site of the ports, a bottoms of TAR to start, which is a virgin area, a careful dissection and reduction of all the content should be done under vision. The most important part is the supracostal and the lateral dissection so as to give a good prosthetic coverage, a proper closure of the defect so as a better integration of the mesh will occur. And when we talk about the flank hernias, the crossover, if the hernia is not encroaching up to the hernia similaris, crossover is rarely required. Inline trocar placement can be done. A bottoms up or a complete or partial TAR can be done in such cases, or maybe a top-down TAR can be done. And here the lateral and the inferior dissection is more important. The superior dissection is not of much importance. A defect closure is always of prime importance when we talk about an abdominal wall reconstruction, and that is reinforced with a good amount of mesh. Thank you for your patience here.
Thank you. Thank you for completing it in time. And I definitely empathize with you. It's a very, very big topic, and even a 45-minute lecture would kind of constrain the amount of experience and insight that you can contribute to this subject. I would just like to summarize in just a few seconds that lateral hernias, by and large, are complex hernias. They need special consideration and knowledge of abnormal anatomy, and this should properly be the domain of an AWR surgeon. This is not for a generalist. In order to identify those patients who will benefit from specific surgical interventions and to execute those interventions very professionally and competently in order to give a long-lasting outcome to these patients. These are difficult cases, and these are going to demand the maximum out of you when you take up these cases. So thank you very much for a very, very detailed exposition of the topic. I will next invite Dr. Daksh Sethi, who is a young AWR and bariatric surgeon working in Gangaram Hospital. So he's going to talk about the initial outreach to AWR. Am I correct, Daksh?
Yes, sir. Yeah.
Please take over.
Can everybody see my slide?
Yes.
Yeah. At the outset, I'd like to thank Dr. Ramanna for their wonderful introduction and Dr. John for giving me this opportunity. So I'll be talking about a very basic topic compared to what Dr. Kitan has talked about, that is starting out on an endoscopic approach to AWR. As we see in the past decade, there has been a decrease in lap IPOM over time, and primarily because of a lot of reasons that they say that it is a more or less a bridging repair and an increased incidence of sublay plate placement of mesh, either open or now more recently endoscopic. So why are we looking beyond IPOM? Because we want defect closure, but that was available in IPOM Plus. We want a proper closure of the midline so that we can create the central tendon, a sublay placement of mesh, that is a retromuscular replacement. Component separation may or may not be required in certain cases, a giant prosthetic reinforcement of the visceral sac, or in other cases where there are loss of domain, where we require a progressive pneumoperitoneum or Botox. So the abdomen as an organ, we see the surgical anatomy, and it is basically the integrity of the abdominal wall that is vital and protects the internal organs and provides support to the spine and maintain an upright posture, which aids us in performing other important functions like micturition, cuffing, and defecation. So to maintain this anatomy is what is important, and that is why we require an abdominal wall reconstruction to recreate the abdominal wall and restore function and structure. The integrity of the abdominal wall is vital as it serves to protect the internal organs, as I've already stored, and maintain an upright posture. So these are the various places where we can place mesh, the onlay placement, the inlay placement, and this is the most common now that we are practicing, that is the sublay or the retromuscular repair. What is the rationale behind this? This attempts to recreate a near normal or a pre-existent anatomy, reconstruct anatomically and physiologically to that end. A wide mesh cover is possible, and simultaneously we can discover incidental hernias. For example, if we have taken up for a patient for a ventral hernia, we may or may not see an inguinal hernia which may be present, or a femoral hernia, or any other incidental hernia, maybe a previous port site hernia or a drain site hernia that is not visible clinically, can also be tackled in the same sitting. It has valid and proven mechanical robustness, lower SSIs, the mesh is extraperitoneal as against an IPOM where it is intraperitoneal, and thus, as we are using Prolene meshes, there are major cost savings. What are the principles of an AWR? It is a tension-free approximation of well-vascularized tissues. There's reconstruction of the linea alba, that is the central tendon of the abdomen, with or without separation of the components, and reinforcement of the repair with a suitable prosthetic mesh. First of all, for any AWR, you need to read the CT. Pre-operative assessment of the CT is very important. You don't need a CECT. You can do with an NCCT if you're not doubtful about the bowel. or the obstruction. So it helps us to assess the size, the number, and the relationship of the abdominal wall defects. Can also be used for loss of domain to calculate the volume of the hernia sac as compared to the intraperitoneal cavity volume. As we can see in this CT, here we can see the various muscles, the external oblique, the internal oblique, and the transversus abdominis muscle. This is the rectus muscle. This is the level of the linea semilunaris, and here is the linea alba. So we can see the condition of the various muscles in a CT and whether they would be amenable to closure in the midline and the location and size of various effects. Note that the transverse abdominal muscle does not insert into the lateral border of the rectus muscle, but rather passes medial to the linea semilunaris and posterior to the rectus itself. This is another CT. Here we can see the hernial sac developing and a small defect through which we can see the sac. Similarly, coronal section of the same CT. Here we can again see the hernial sac. Similarly, this is a CT of a lateral hernia. We can see some sort of interparietal hernia and weakness developing here. And as we go down further, we will see the hernial defect here, along with the giant sac. Can you just excuse me a moment? I'll just on my charger.
You have another 9 minutes, just informing you.
Ramana, you could, while he reconnects, you could just sort of explain the whole approach to starting on AWR to the classical hernia surgeon. You know, that was the essential objective of this talk.
Right. And I think we should let Daksh cover his perspective on this. And it's always interesting to see how younger surgeons look at such an exciting new specialty which is evolving as we speak. And I'll just go back to one of the topics that were the highlights of your excellent program today, which was Mukund's talk on lateral hernias, while we are ready for Daksh. It is that patient selection is going to be a very, very critical factor in success. There are patients who have a huge bulge, and to most people it may look like a hernia, but an expert would really understand the difference between a hernia and a lateral denervation. And if you operate on a lateral denervation, you're consigning that patient to worse outcomes vis-a-vis operating on a genuine hernia. So just a simple difference between them is going to be critical in determining outcomes for the patient. Anyhow, I think Daksh should be ready by now.
Yeah, sis. I apologize, my laptop just ponged off. Sorry.
No, that's all right.
Yeah. So coming to the indications of the AWR procedure, it is basically used for large defects, multiple defects, boundary defects, as Dr. Kitana explained properly, complex hernias, which may be parastomal, or recurrent hernias, or other recurrent hernias. What is key is pre-operative assessment and optimization. A surgeon must appreciate the magnitude and the range of surgical techniques required to repair these defects and the potential for a significant harm that he can cause with improper understanding of these techniques. Factors like obesity, smoking, diabetes should be taken care of before managing these hernia. Defect assessment first using CT and clinical examination is important. as seen in a supraumbilical defect that is seen here. There are various endoscopic techniques like ETEP-RS, ETEP-CHAR, SCOLA, EMELOS, endoscopic ACST, and they have different applications. I'll be mostly concentrating on ETEP-RS and somewhat TAR. These are just representations of SCOLA where we clearly mark them in the subcutaneous plane, a small picture of MILOS. So mainly coming to posterior component separation. This is the Reeve Stopa repair with retrorectus mesh placement, bounded laterally by the linea semilunaris. Enlarging the space can be achieved by TAR, that is the division of the transversus abdominis muscle, and this which allows us to place a very large prosthetic mesh with wide overlap to treat both lateral and midline hernia. These are the basic steps, the patient positioning and interna, and we'll get into these. First of all, it is important to mark the defect and proper surface marking that is especially on table required to mark the linea semilunaris for points of entry and accordingly have a pre-operative plan of the ports. These mostly remain the same but are subject to change depending on the conditions inside and how we need to approach either a top-down crossover or an inferior crossover. The positioning is important. Flexion of the table where in this position, the distance between the costal margin and the iliac crest is increased for optimal port placement and to avoid conflict of the surgeon's hand with the patient's thigh or the costal margin, depending on the location of the defect. For umbilical and infraumbilical defects, we prefer the ports up top and we go down in a triangulated fashion towards the defect. If it is a superior defect, then we have ports lower down and similar maintain triangulation for supraumbilical and subxiphoid defects. First of all, we start with an optical entry, and you can also do an open entry. This is entering into the left retrorectus space, creating the space on the left side. Here we can see the inferior epigastric. The left retrorectus space is dissected. Again, the inferior epigastric, this is the left retrorectus space. Then we see the medial edge of the PRS and go on to the crossover. This is us dividing the left PRS, and then we see the fat that is at the level of the falciform. And when we see the fleshy fibers above, that is where we divide the opposite posterior rectus sheath to go into the right retrorectus space. Here we can see it clearly, and then we insert another trocar on the right side. Here we can see the section, the opposite rectus muscle, and this is the cut edge of the posterior rectus sheath on the opposite side. Then we go down after seeing the lamppost sign, after seeing the volcano sign as described by Dr. Ramanna. We go top down or bottoms up depending on the hernia. We open the hernia sac, reduce the contents completely. Then we complete the dissection, examine both retrorectus spaces. This is the preperitoneal space. Then we move on to the inferior dissection. Finally, once the dissection is complete, we check all the visceral content with to look for any injury that we might have inadvertently caused. Then we start closing the defect. First, we do the posterior closure. Either we close PRS to PRS or the PRS peritoneal complex is closed. A TAR may or may not be required. And then we close the linea alba, that is the anterior defect closure, followed by mesh placement and desufflation. This is a small video of retrorectus dissection. Here we are going in by an open technique. First, we have created the left retrorectus space and inserted our first working trocar, going down towards the arcuate line and below to make space for the second working trocar. Here we can see the inferior epigastric in view. The second working
you have a minute for your talk and then Q&A.
Yeah. Then we go up towards the crossover. Here we can see we are doing the crossover. And this is the incision of the opposite retrorectus, opposite PRS, and then we insert a trocar. This is a small of the closure of the posterior rectus sheath. Here we are closing the posterior rectus sheath to the posterior rectus sheath, but we can close the peritoneum as it is to make it a PRS peritoneal complex to keep the mesh retrorectus. Small video of tower and anterior defect closure. Why do we require ETEP for ventral hernia repairs? It is a fast and easy creation of the extraperitoneal space. A large surgical field is available. A flexible port setup to all clinical situations. Improved tolerance of pneumoperitoneum. All the ports can simultaneously be covered by a mesh. Closure of the defect and the linea is better achieved. Mesh is placed in a retrorectus plane and not intraperitoneally, and boundary hernias can be repaired better. So, yeah, thank you.
Thank you for a nice overview of AWR. And before we have any questions from the audience or from anybody, maybe the chairpersons would like to comment.
Yeah, absolutely, sir. A good job, Daksh.
Thank you, sir.
You said that you can either close the PRS to PRS or you can do a peritoneal closure. So what is your departmental policy? Like if you ask Vlad, then Vlad will always say that he'll always do a PRS to PRS closure. If you ask Dr. Ramanna, he'll say that it is not absolutely mandatory. So what is your take, your departmental policy on the PRS closure?
Sir, in our department, we prefer to close the PRS peritoneal complex. We're not very dogmatic about closing PRS to PRS.
I believe that makes sense. Your comment, sir, Dr. Ramanna?
Oh, yes, absolutely. The biggest problem with ETEP repairs of all kinds is the posterior disruption, and the surefire way to invite posterior disruption is to close PRS to PRS. And obviously, there are pros and cons of this debate, and more insights are coming up with experience. But I would say play safe and just achieve a hermetic closure of the posterior layers, whichever way seems sensible. Don't go overboard trying to close PRS to PRS, because you're going to end up creating high tension repairs, and you're also going to do more TARs if you're just going to focus on achieving PRS to PRS closures. Anyone else would like to comment? One of the chairpersons? On any other topic, Dr. Oagb Alvi, please.
I just want to take this opportunity to wish our Ramana a very happy birthday.
Thank you so much.
And I must also add, it's also the birthday for Sudhir Kalan.
Yes,
exactly. So you guys are a neat pair out there. So many, many happy returns of the day.
Thank you.
Over to you, Ramana.
Yeah. So if there are any questions from the audience, we can take them. Otherwise, I would say that I would conclude essentially that our two speakers have done a very good job of covering a broad spectrum of AWR. And all these principles are good to keep in mind without being a fanatic about it. So it is important that a surgeon has multiple tools in his toolbox, even though it may be a cliched saying, but it is important that a surgeon repairing complex hernias has multiple operations at which he is at least competent, so that he is not wedded to one procedure. Like, I'm a TAM guy, I'm an ETEP guy. That kind of approach has significant limitations and would put you in trouble one day. Let me give you a simple example. If you're just an open surgeon and you open a large lateral iliac hernia, incisional hernia, with a patient who has a history of peritonitis, explorations, ileostomies, and now has a large hernia. In that patient, you open up from the flank and you reduce the contents, but you're finding your peritoneum is very, very badly stuck. You're not able to find a plane. Wherever you're trying to find a retromuscular plane, it is tearing apart. What do you do in that case? So if you have only one approach in your armamentarium, you're going to be completely stumped by a given case. So it is important for a surgeon to have all the procedures under his belt, or work in a team where if you don't have specific subsets of skill, somebody else in the team can take over. So if you're an E-type surgeon and you run into trouble with bowel, you can always call a colleague who is an expert with bowel. So there's nothing wrong in having limitations, but it's important in the patient's interest to recognize that, and a multidisciplinary team is always a very, very big asset for a center dealing with complex hernias. So I think, I mean, it's an endless topic and we keep having controversies and heated debates, but I think we should call it a day and let the program move on. Please go over, Suvir.
Thank you. Thank you very much, Ramana. Many happy returns day once again. And thank you very much, speakers, Dr. Ketan and Dr. Daksh, as well as chairperson, Ashish Day, for putting in questions. Thank you. We'll
for a great insight. Yeah.
Thank you. We'll switch over to the next session. We have with us to moderate the session, Dr. Nemish Mehta, who's a senior hepatobiliary surgeon in our country, who's also the vice chair of the Department of Surgical Gastroenterology and Liver Transplantation at Sir Gangaram Hospital. To accompany him as chairpersons, Dr. Abhay Dalvi, who's a senior minimal access surgeon, past president both of the IGS and past president of ASI. With Dr. LP Thangavelu, senior minimal access surgeon from Coimbatore, who's also current president-elect of the IAGS. Dr. Akhtar Ganai, a very senior surgeon from Srinagar in Kashmir. Dr. Saurabh Bansal, consultant surgeon, surgical gastroenterology, Sir Gangaram Hospital. Anupam Goyal, who's chair of the Minimal Access and Bariatric Surgery Department at Max Hospital, Mohali. Over to you, Nemish, to invite our speakers for the hepatobiliary session.
So, thank you, John, and I would like to thank the Minimal Access Department at Sir Gangaram to involve us for the hepatobiliary session. So let me invite the birthday boy, Dr. Kallan sir. Hi.
Thank you, Nimish.
And it is considered that the cholecystectomy is simple, but he's going to talk to you about challenging lap chole. Over to you, Dr. Kallan.
Thank you, Dr. Nimish. I thought that let us also keep the topic of laparoscopic cholecystectomy also in this session, because although we do a lot of laparoscopic surgeries and we think that gallbladder is simple surgery, you come across many situations where a simple gallbladder becomes a very tough thing. So I have with me Dr. Piyush, who is our second year FNB trainee, and Piyush is going to, basically make this presentation in 4 different parts. One is a simple gallbladder with a difficult congenital anomaly, which actually makes you wonder where is the cystic duct, where is the CPD, and gives you a scare. Second, I think is the most difficult condition according to me, is a Mirizi syndrome, which is type 3, 4, and 5, where the fistulation has occurred and you really don't know what to do. Then you have occasions when there is, this bleeding from the liver bed, sinuses open up. And lastly, but not the least, you have a very bad thick walled gallbladder. How do you take it out? So I think Piyush, over to Piyush, and Piyush is going to just show you small videos and show you how to tackle with these challenging situations. Piyush, please take over.
Thank you, sir. Yeah. So,
hi, Anil.
My screen is audible. My screen is visible.
Yes.
Okay. So, thank you. So, thank you, sir, for giving me this wonderful opportunity. And I'll be talking on difficulties and challenges in laparoscopic cholecystectomy. So, as sir has rightly said, that I will be covering the topic in these 4 headings. So, to begin with the first one, we all know that iatrogenic bile duct injury is the gravest risk of laparoscopic cholecystectomy, and majority of these injuries are due to misinterpretation of biliary anatomy. One such aberrant anatomy is the aberrant right hepatic duct, which has an incidence of approximately 5%. Now, on the basis of spatial relationship of the aberrant right hepatic duct with the cystic duct and the gallbladder, Isatsuku et al. Has classified this into 2 major categories, which are the type A and B, where the aberrant right hepatic duct communicates with the cystic duct, and the type B, in which it directly comes and joins to the infundibulum of the gallbladder. So let's have a look at this video. So this was a classical laparoscopic cholecystectomy with 4-port technique using a 5 mm 30-degree telescope. And we were following the
standard principles of Strasbourg critical view of safety by doing posterior dissection and anterior dissection. We have clipped and divided the cystic artery here, and then we are seeing the two structures going inside the gallbladder. Usually after dividing the cystic artery, we should be seeing only one structure, that is the cystic duct. But here in this case, we are seeing the two structures. So we have done the meticulous dissection, the posterior and anterior dissection, and then we confirm that there is another ductal structure which could be aberrant right hepatic duct. So as we can see here, the bile in the duct, and then we clipped and divided the duct. So there was a free flow of bile with the microliths. And then we have used hemolog for clipping the cystic duct, and we have divided the cystic duct. So there was no further bile leak, and we have put a biobag drain and removed the port under vision. And on follow-up, we removed the drain after 1 week, and patient did not have any bile leak in the drain, and her liver function tests were normal. So according to this classification, our case fits into the type 6 category, where the aberrant right hepatic duct directly drains into the infundibulum of the gallbladder, and which poses this as a risk for the bile duct injury. So coming to the second case, that is the Meiji syndrome. Meiji syndrome has an incidence of approximately 5%. In this syndrome, there is a stone which has impacted in the cystic duct or infundibulum of the gallbladder and causes obstruction of the common hepatic duct. So the various classification of the Meiji syndrome, and in which classically the type 1, which does not have any fistulous communication, while type 2, 3, and 4 have a fistulous communication with the bile duct. Depending on the degree of the obstruction, they are further divided into type 2 and 3. And then type 5 is the one which has the fistulous communication along with the biliary tree with the bowel. So let's have a look at our patient. So this patient had CBD calculi with the cholelithiasis, and patient had undergone ERCP with CBD stenting. On laparoscopic cholecystectomy, duodenum was densely adhered with the infundibulum of the gallbladder. Callos was completely frozen, and there was no way to go to the Callos triangle. So we used the suction irrigation for blunt dissection, and then we have opened the gallbladder here by doing a longitudinal cholecystostomy in this case. And we have removed the stones from the gallbladder by using endobag. So these were the large impacted stones inside the gallbladder. Now we can see that this patient has a cholecystocholedochal fistula with the common hepatic duct and the wall of the gallbladder. And there is a biliary stent which can be seen in the lower part. And there were stones impacted in the common hepatic duct. The further stones impacted in the proximal portion of the common hepatic duct, which were removed by using a bowel grasper meticulously. We have used a suction irrigation, and then with the 5 mm telescope, we have done a choledocoscopy. We have gone all the way to the hepatic duct proximally to see whether there is any stones left in the proximal portion of the hepatic duct. So we confirmed that there were no further stones in the confluence of the common hepatic duct. Proximally, there was free flow of the line. The right and left hepatic duct was visualized, and all the remaining stones were removed. Yeah, so following this, we have used the retrograde technique of removing the gallbladder. We have divided the gallbladder from the liver bed, and then 1 centimeter cuff of the gallbladder, infundibular portion of the gallbladder, we left over the Callot's triangle, and then we reposition in the biliary stent, and by using the harmonic, we have removed the gallbladder. And the longitudinal cholecystostomy was closed with the 2O vicryl. Okay, so coming to the third most common problem which we face routinely in the laparoscopic cholecystectomy is the hemorrhage from the liver bed. So this one, while removing the gallbladder from the liver, one of the sinuses has opened up, and hook is the culprit here, which usually causes more damage. And so one should use the gauze here and apply nice pressure. And we all know that surgeon is the most important clotting factor in any surgery. So surgeons should stay calm and use a proper technique of controlling the bleeding. And we should wait for 3 to 5 minutes at least. That is the normal clotting time. And then use suction. And following this, we can use a bipolar cautery and cauterize the raw area from the liver and control the bleeding. So in this way, we can safely control the bleeding from the liver bed, which usually happens in the routinely cholecystectomy. Now, coming to the fourth one, that is the specimen retrieval in difficult gallbladder. So in our institute at Gangaram Hospital in IMAS, we use endobag in all our routine laparoscopic cholecystectomy cases. And whenever we found there is a difficulty, we usually cut open the gallbladder laparoscopically and crush the stones if stones are quite large. And this way, we find that we can easily and safely remove the gallbladder without causing any other trauma to the patient. So as Lord Moynihan has rightly said that a gallstone is a tombstone erected to the memory of the organism which lies buried dead within it. But the organisms are sometimes buried alive. So we have to remember that if the gallstones are spilled inside the peritoneal cavity, they can be the nidus of peritoneal sepsis later on. So we have to be very cautious in removing the gallstones safely. Thank you.
So I think Piyush has summed up very well. What I would like to say as a teacher and somebody who's heading a program is that don't treat any gallbladder as a simple gallbladder. Please be careful about the anatomy. If there's any doubt, take some time, take the help of somebody and call them and take their opinion. Also, if we have a difficult gallbladder, first I say convert your 5mm scope into a 10mm scope so that you have a good vision. Secondly, drop in a gauze piece that really helps in difficult cases. Or use a good bipolar forceps for controlling hemostasis, because bipolar forceps is a very good instrument. And also the last thing, I've seen many people not giving respect to removal of the gallbladder, and they will just try and struggle to live it out. And in the end, you just, kind of roger the whole surgery by infecting the wound. And I have had patients who come with bad abdominal sepsis. It's a policy in our department. We put all the gallbladders into a bag, and then also, you cut open the technique you were showing. You cut open the gallbladder in the bag, crush all the stones, put it in a bag, and then try and remove all the specimen without contaminating the wound. So I think the message is that cholecystectomy, like appendicectomy, should not be treated as an easy this thing. If you have a congenital anomaly, take a breather, take a time, call somebody's help, take a second opinion. Because as we were showing in this case, the right in the aberrant duct opening into the infundibulum, with all our experience, we took 15 minutes to absolutely, I was there, I called Mukund Gintan, I called Suvirajan, all of us, and with lot of, I remember that this did give us a scare. And so I think it is very, very important that all cases should be treated with respect. So any questions, we are open.
So it is very nice. Thank you for such fantastic demonstration, Dr. Kallan. But basically, I've got a couple of points I thought we should discuss with the chairpersons and the audience if they want. One is, you have shown such nice demonstrations, so your skill set is different. But there are a lot of younger surgeons who are starting with this, and they should not get pushed into continuing with laparoscopic approach itself. So when would you advise them to convert into an open procedure or to seek help?
See, Nimesh, as you rightly said, that conversion is not a defeat. So a conversion should never come into the ego of a surgeon. So if you're in a small center, you're not sure of the anatomy, either you ask for help. If you can't get an help, convert it into open. Now the problem is that most of the youngsters have not seen too much open surgery. So that is also, Dr. Lal and me are fortunate. We have done open surgeries and we are not hesitant to convert. The problem these youngsters are there, they will be difficult to convert also. They have no experience of open surgery. So I would say that, what is the best thing to do? As you said, if I were in a smaller center, if I find a Mirizi syndrome and for 5-10 minutes I'm struggling, I think I'm going to injure the duodenum or the bile duct, I think I would do a strategic withdrawal. In the war also, it is never harmful to come back and then get your act together and then go back again. So I've had patients who failed cholecystectomy and wisely sent to our center, and then we could do it laparoscopically. So I think it's very, very important that you don't harm the patient. So primum non nocere. First, don't do no harm. And again, conversion is not a defeat, and conversion should be done. But Professor Lal, please tell us how to train these youngsters into open surgery. Tomorrow, if they have to convert, they have no idea about what to do in open surgery.
Very good evening. Yeah, I quite agree, Dr. Sudhir, that this is indeed a challenge. And at training institutions like ours and other prominent general surgery and GI departments, it is our endeavor to ensure that they frequently or at intervals keep doing open cholecystectomy. There is, certain set of patients who are very high risk for, pneumoperitoneum with their comorbidities of COPD and things like that. And scar is not much of an issue on them. So we definitely give those, make sure that our students get to see and possibly do open surgery. And whenever open surgery is being done in this area, in the hepatobiliary region, for other reasons, we ensure that they are able to see the normal anatomy. They don't even know how to do the Pringles maneuver.
Right. They
don't even know where to put their finger for the Pringles maneuver if they were to, in God forbid, in a situation. So you are very right. Those challenges still remain, and we at teaching institutions have greater responsibility to ensure that we are able to give that kind of training. And I quite agree with what you said. It depends on the skill sets of the surgeons who are encountering that particular problem. It depends on the facilities that are available in that particular center and how apt you are to have availability of senior help. If you are into a complication which needs to be managed, we need to convert and manage it to the level that that person can competently manage. But very rightly said, if you are not in a position to proceed, we also follow that policy of converting that cholecystectomy into a diagnostic laparoscopy. You do not need to go in and come out with the gallbladder every time. You can always, refer it if no other irreversible step has been done, then the patient can have a drain put in and the patient can be referred to a senior center without any apology.
That is the golden line I think we've all been speaking about. That if you have a problem, please don't hesitate into just converting into a diagnostic and coming out and referring the patient. And secondly, as I said, I tell my students here also that when you start off with a 5 mm laparoscope and you find a difficult case, you please first of all improve the optics by making it into 10 mm. Secondly, if you need help, put in an extra trocar. Sometimes an additional support, an extra 5 mm, an additional retraction also helps. Then a good suction and putting in a gauze piece. A gauze piece with a marker, very, very important. And gauze piece really helps, when we have a difficult case, I always drop in a gauze even before the bleeding occurs, I always drop in a gauze piece. Two ways it helps. One, immediately if I have a bleeder, it helps. It helps in the dissection. Also, when you put in a white gauze piece, what happens in this HD system, the three-chip HD system, the moment bleeding occurs, many of these cameras, especially the striker, and they become black. The red becomes black. So if you have a white body there, also the vision also remains all right. And doing suction over the gauze piece is also very helpful. So I think these small things. And lastly, I don't know, Dr. Lal, what is the policy at your center, but 100% of our patients, we remove the gallbladder in a bag. People say the cost of the gallbladder bag and other things. When the patient is paying so much for the procedure, another 2,000 rupees for the bag is really not going to, because we are putting subcuticular in all our patients. And I would say that almost SSI in our cases is almost zero. Proudly, we can say that SSI is almost zero. So if you calculate and the patient gets a wound infection and then he takes antibiotics for 20 days and then you do a small IND and he gets a bad scar, the cost benefit analysis does not say that you should not use a bag. So I think I would strongly advocate using a bag.
So thank you, Dr. Kalan and Dr. Lal. If there are any other questions, I think there was a question.
I think we should go on to the next speaker, please.
Anil needs to say something. Anil is my batchmate. We did our MS together. And Anil, you must give your own suggestions.
Yeah, hello. Am I audible? Yeah.
Yes.
Hi, Kalan, and hi everyone. And regarding your talk, I think you and Pawan have summed up very nicely. And I think I'm reminded of one of the invited
वो वाला कैमरा चेक करो ये वाला यहाँ से कौन घुस रहा है तो हाथ में डब्बा भी दिखेगा कल सुबह परसों ही दिया ना
Dr. Mida, please go on mute mode, please. Dr. Satish Mida, please go on mute mode. Please go on mute mode.
I think the team, the technical team can also mute him actually.
Yeah, that's right. So I'm reminded of one of the invited commentary written for packing in liver surgery. And in that, it was titled as calculated retreat is not defeat. So I think that's very nicely you said that as they say that I have not failed, I have only postponed success. And I think, in fact, that is part of the success that you have withdrawn in time and referred to, as Kalan said, that in fact, we also have a few patients in which they have been referred from another center, and even though I think mistakenly they thought that it may be malignant or something, but it was inflammatory adhesions. But it was good that they, referred, and subsequently we went ahead and did a laparoscopic cholecystectomy in that. So I totally agree with what Kalan and Pawan just summed up. So thank you very much.
So we quickly move on to the next topic. I invite Dr. Anil Agarwal, who's going to speak on the evidence-based medicine for treatment of carcinoma gallbladder and update in 2022. Dr. Agarwal, to you over, please.
Yeah, thank you very much. And thank you, Dr. Kalan, Subiraj, and the think tank for giving me this opportunity. And I'm to talk about the evidence-based surgical management of gallbladder cancer. And I asked him that whether should I focus on laparoscopic, but he said no, cover the entire thing about the open. And in the end, I'll speak a little bit about the laparoscopic approach. So I think we know that it comes in various forms: incidental gallbladder cancer, or what is limited to the gallbladder, loco-regionally advanced, and you rule out metastatic disease. So I think first of all, let's talk about incidental gallbladder cancer. Technically, if you ask, incidental is when you didn't suspect either pre-operatively, during surgery, or after removing the gallbladder and examining it. And it is, but however, if you look at the literature, so it is a histopathological surprise. However, if you look at the literature, mostly this term is loosely labeled to any patient which was taken up as a benign disease and for cholecystectomy and subsequently comes with a report of malignancy. So I think if you were to divide that, you could suspect in what is a gallstone disease, either you can suspect pre-operative, per-operatively on exploration, that is I'm talking about that on pre-operative imaging, if you didn't think it was malignant, then either during exploration, during laparoscopy or open, during different steps of cholecystectomy, or on removal of the cholecystectomy specimen. And I think here I would, for our younger colleagues, would re-emphasize that you have to examine the removed gallbladder, palpate it, and if there's any doubt, send it for pathology. So if you have frozen section histopathology or for imprint cytology. And the other thing is that on pathology, if it comes out either on frozen section or routine histopathology. So truly incidental are the ones which come out positive on routine histopathology. And I think these are the situations wherein when you examine the gallbladder and you realize that there is something which might be suspected as a malignancy, so you send it for frozen section analysis. And this is one of the papers that we talked about, because again, I want to re-emphasize, because quite a few of our patients come in after they have had a recurrence because the surgeon decided not to send the gallbladder for histopathology. And probably this was based on one UK paper, but whatever the amount of money you may save, you have to send it, because we realize that more of them turn out to be unresectable or needed more extensive resection. Now, what do you do when you have intraoperative suspicion of gallbladder cancer, which most of us, a lot of us do encounter, that you put in the scope and you think, oh, maybe imaging didn't show, but it is probably gallbladder cancer. So you take your, you assess that whether you can go ahead and do a radical cholecystectomy, or if there is one of your colleagues in the center who can go ahead and do it. If not, it is better to come back. Or the other thing is, if you thought that you could at least, do the cholecystectomy with a wedge of liver, without, this thing, then you can do that, because this is one paper by Professor Hahn group, in which they talked about that out of those 36 patients, 18 patients turned out to be benign. And doing the gallbladder with liver wedge may be possible by more surgeons than probably doing a lymphadenectomy if you are not used to doing the lymphadenectomy there. So at least maybe some percentage of patients can be managed laparoscopically in this way. Now, just a few important oncological things about when you encounter a gallbladder cancer, when you just put in the scope, preserve the integrity of the gallbladder, avoid bile spillage at all costs. So for this, we would usually suggest a double clipping. Minimal handling of gallbladder, which would mean that at least from what is a suspected tumor area, don't grasp that. And in fact, earlier on the literature which was there of outside metastasis was probably because you have handled the gallbladder from any which way and there has been bile spillage. Use the endo bag, which Kalan very nicely said that even as a routine practice, it is good to remove it in an endo bag. When in doubt, give up laparoscopy to open access if you're not a believer of doing a laparoscopic radical cholecystectomy. Carefully inspect the gallbladder once extracted. Perform a histological examination if required, and decephalate the peritoneum with trocar in situ. This is also important. So just a few points when you encounter unexpected. So just to take you through 3 slides in which we tried to analyze our data during that 6-7 years period. 145 patients which are labeled as incidental gallbladder cancer, we realized that if we went back to the imaging or the intraoperative findings, you realize that almost 50% of them, there was some suspicion. So it was wrongly labeled as incidental gallbladder cancer, and probably to another person, you might have probably diagnosed it as a gallbladder cancer. So I think when you analyze the literature, it is very, very important. So I think what usually, let's say for the management purpose, when the patients come with a report of histopathology of gallbladder cancer, what do you do? So there is a need for completion radical cholecystectomy in anything which is beyond T1B or positive cystic duct margin or positive cystic lymph node. I'm not going into the details of port site resection, which we as a routine do it. Now, coming to the other group, which is gallbladder cancer limited to gallbladder and loco-regionally advanced gallbladder cancer, which means that you have suspected that it's a gallbladder cancer on the prior ultrasound. So what do? You do select the patient suitable for surgery by staging the disease, ruling out distant metastasis, and lymph nodes. Endoscopic ultrasound is what we do nowadays for intra-aortic cable lymph node. Avoid non-therapeutic laparoscopy. In that regard, staging laparoscopy helps. And if still there is a doubt intra-operative, you can do an intra-aortic cable lymph node assessment and radical cholecystectomy both for limited or advanced disease, which can be again laparoscopic or robotic or open, of course. So if, let's say, in a conventional method, what would you do? You would do a diagnostic laparoscopy, give a incision right subcostal, confirm again that it is not metastatic, laparotomy to rule out metastasis, assess resectability, intra-aortic cable lymph node you send for frozen, and if it is resectable, you can increase the incision a bit. This was our paper in which we did analyze at the time when we were doing more of open, that 18.6% of patients turn out to be IAC lymph node positive. So if now that number has certainly reduced, because now we do an endoscopic ultrasound assessment of the intra-aortic cable lymph node and avoid surgery altogether. Now, so endoscopic ultrasound is helpful, and we initially took the help of Dr. Pramod Garg and subsequently Dr. Puri and Dr. Siddharth. So this is a meta-analysis of a paper in which they talk about staging laparoscopy is a mandatory thing in all gallbladder cancer. And the first paper that they've talked about is our paper. This is we published in Annals about an analysis of 409 patients. And what we realized was that even though the yield was higher in advanced gallbladder cancer, but in terms of avoiding a non-therapeutic laparotomy, it was comparable. So in fact, what we did was that some of the detectable lesions we missed. So now we do a two-port laparoscopy, which will help either to look at the hidden areas where we've missed earlier, or take a biopsy in those in which it was positive. And additionally, now we also do an intra-aortic lymph node biopsy, which can also be done by using the laparoscopic approach. And because most of the literature favors that if it is positive, then probably you will not help the patient by doing a radical cholecystectomy. Now let us see what all does it entail, radical cholecystectomy. Lymphadenectomy, hepatic resection are the parts which is done in all cases. I'll talk about the bile duct resection, and then when there is a advanced lesion and adjacent viscera or biliovascular involvement. So for early gallbladder cancer, a standard radical cholecystectomy, and standard cholecystectomy is what? Liver resection and lymphadenectomy. And the liver resection could be a wedge resection like in this one, or a segment 4B5 resection. Now, even though literature-wise both have comparable results, however, so doing segment 4B5 is based on this venous drainage, and it is said that probably theoretically early micrometastasis via cystic veins can be prevented if you did a segment 4B5 resection. But if you look at the Japanese literature, they did say that what is the bottom line is that do an R0 resection, and it doesn't really help that if you, it is comparable results whether you do a segment 4B5 or a wedge resection. So now just a few technical points about this thing, that segment 4B5. Segment 4B is easy to isolate because by clamping what is usually the extrahepatic pedicle, but what is important is getting into the segment 5 line, which you could do by indirect temporary clamping of posterior or anterior pedicle, or ligation or injection of the dye, or use of intraoperative ultrasound. Like this is showing that once you take this pedicle, that is segment 4B5 getting this colored. And this is intraoperative ultrasound. We have marked out the right hepatic vein, and that is where this pedicle will lie. And this is the branch of that. And so this is where you will have the segment 5. And from segment 4B, if you extend this line, it will give you an idea of segment 4B5. As you can see in this, that this line has been met here and coming down to segment 5A. So that gives a segment 4B5 resection. And I'm very happy to say that Kalai Rasan from Pondicherry, in fact, he has just published a paper in which they have done a fluorescein guided anatomical segment 4B5 resection in robotic approach. So coming to the lymphadenectomy, once you have ensured that intra-aortic cable lymph node is not involved, you take care of all these lymph nodes and the hepatoduodenal ligament along the hepatic artery almost up to the celiac and retropancreatic. And it is good if you can remove all that in one piece. However, the important thing is that you complete all this lymphadenectomy is done. Now, bile duct excision, some people like Professor Miyazaki talked about T2 and beyond to remove the bile duct excision. However, the literature doesn't support because it didn't add to the survival benefit. And in fact, we, like several other centers, would just reserve it for like this neck tumor, a papillary tumor in which you can see this tumor inside the bile duct, or choledochal cyst in which you can see this is a lesion and this is a choledochal cyst. Or sometimes you cannot differentiate in redo surgery between fibrosis and tumor. Now, coming to the adjacent viscera resection, that it would be liver infiltration or duodenum, colon, pancreas with biliary obstruction and vascular involvement. Now, the liver resection can be from segment 4B5, wedge of segment 4B5 to segment 4B5, right side segmentectomy or right hepatectomy. It could be required when there is a large tumor like in this one, or when there is a vascular involvement, like this is a large tumor in which you needed an extended resection, or vascular resection on when there is a vascular involvement, or just like there's a neck tumor. But keep this in mind that if you preserve segment 4A, which is not required to be sacrificed oncologically, it adds to the liver volume, especially in jaundice patients, and will reduce your risk of liver failure. Adjacent viscera involvement, duodenum, colon, and pancreas. If there is a small involvement, we would do a sleeve resection. Whereas there is a more extensive involvement, we do a distal gastrectomy and proximal duodenectomy. And this is our paper in which we talked about that it led to a survival advantage. If you did that, and in fact, in this study, we found that we could avoid doing a HPD in many of these cases. Colonic involvement, again, you can do a segmental resection or even up to a right hemicolectomy in some of these patients. Some pictures just to show you in this, they were both resected. That is the distal gastrectomy and proximal duodenectomy with colonic resection, or like in this case in which the diaphragm, colon, and duodenum was resected, or in this patient which presented with polycystocutaneous fistula, we also had to excise the rib as part of the resection, as in this case you can see. So, but you
have a minute.
Oh, is it? So I'll just rush on to. I thought I had not yet taken. It's been 11 minutes, no? Anyway, okay. So I'll push on to. So this is just the literature talking about that there is a survival advantage. So I'll quickly go on to I think the laparoscopic approach. So this is 57.5% was the resectability. I'll just quickly go on to the lab. This is a jaundice patient. It leads to survival benefit and tailored surgical approach. Maybe I think we are short of time. Right hepatic, you can do a segment 45 resection even with right hepatic artery involvement. This is our paper. And when there's a portal vein involvement, then what you would do is an extended right hepatectomy. Now, just to talk about laparoscopic, you can use the same thing, segment 4B5 resection like this, or lymphadenectomy as in this shown. The advantage is obvious apart from other advantages which you have, and you can do this is day 1 post-op and a obese patient, you can have a good advantage. This is our paper which we presented in ILLS conference, 179 patients, now it's 190 plus, and you can have a comparable results. This is the world literature, and we talk about there's a multi-institutional 235 cases, but now it is very nice to see that there are several series. This was the consensus statement by Professor Hahn, and these are the study. And these are some studies which are more than 50 patients, and people are now more and more adopting to laparoscopic or the robotic approach. There's a very nice paper from Tata Memorial by Mahesh Goyal about robotic. And the same thing can also be, we recently published our paper of adjacent viscera, in which there are a few papers in the literature, these 3 papers, and we published our paper in which we did the adjacent viscera resection. This is the paper in which 11 patients were resected, in which adjacent viscera was involved. I'm very happy to see this paper in which a HPD has been done by the laparoscopic approach in the JIPMER by Raja Kalaris and his team. So thank you very much for your attention. I thought I had 2 more minutes.
Thank you, Dr. Agarwal, for such a fantastic elucidation for the CAGB. I think the time given is probably a little bit short because this is a vast topic, and thank you for trying to cover it in a short span of time. Any questions from my co-chairpersons, please?
Can I make a comment?
Please go ahead.
Nimesh, I mean, you are here, Pavinder is here, Anil is here. I think there is one thing we need to, put across to our physician friends. I've seen this, all my physician friends, they say, unless the gallbladders become really symptomatic, they should not be touched. We have done a retrospective study about 10,000 cases of our gallbladders routinely, which had no radiological or intraoperative suspicion of malignancy, and then 8 to 10% of them showed severe dysplasia and pyloric metaplasia, and all these could have gone on to become cancer. Also, statistically, the fastest growing cancer is cancer gallbladder in men. So with this background, and again, the advantages, today's surgery, that dictum that only symptomatic gallstones should be operated was an era of open surgery, when the disadvantages of the surgery were so much that, big scar, long time, this thing, people used to say and don't. But now things have changed. I think this thinking of our physician friends needs to change, that only, gallbladder, unless they become, you have patients refer to us only once they have bad empyema or jaundiced or stone drop into the bile duct. So I think what is your take on, all of you, what is your take on that? But I think that must be cleared with people. Anil, Nimesh, Pavinder, all of you, please comment.
So Dr. Agarwal wants to take it, because
Nimesh, you can go ahead, then Pawan.
Yeah, so we do get a lot of cases referred to us. So CAGB is one of those cases where unfortunately they present to us, and if they present to us with symptoms, they are usually locally very well advanced, and many of these cases may actually require a right trisegmentectomy, which is an extensive resection. So you may not have the volumes. You have to reduce the jaundice level before you take them up for a major liver resection. You might have to do a PTBD. You might have to do a portal vein embolization. So yes, it's a big ordeal, and by the time you try and get these things sorted, when they come back to you many a times during this wait period of post PTBD and post portal vein embolization, they come with again further progress in their primary disease, and some of these patients again still become further inoperable. So in a way, yes, I agree with you on your comment that you should not take it so lightly, and if there are some gallstones or polyps or seen, you may try and go ahead and operate. But at the same time, looking at the other side, if we keep on saying that all gallbladders need to be operated.
I never said that, Nimesh.
Right.
I never said that.
Right.
I didn't say that the moment you see a 4 millimeter stone in an asymptomatic, you operate. But at the same time, at least you should have a balance, right? Balance.
Right. Correct.
You have a diabetic patient, multiple stones, has had 2 episodes of pain, has had fever once. They say, no, still wait. So I think that's what I'm trying to say.
No, I agree with you. So I think this is probably same everywhere. Dr. Agarwal and Dr. Lal, your comments, please.
Yeah, so I think, I agree. Symptomatic stones should be out with the current technology and expertise. There is no reason that we should sit on symptomatic stones. But obviously, we cannot make a statement that all stones, irrespective of being symptomatic or asymptomatic, should be out, because then unless we have statistics to show that the incidence of CA gallbladder in that particular area that we are working is more than the morbidity caused by the surgical procedure. So we are exactly ourselves not in that particular area. But yes, I agree with Dr. Kalan and yourself as well that people who have symptomatic gallstones, they should not linger on with it. It should be out, because the longer they stay, they cause plethora of complications. Sometimes you've seen people with pancreatitis, gallstone-induced pancreatitis, just having mortality for whatever it was worth it. It could have been saved completely. It's far more than even the mortality of malignancy sometimes. So I quite agree. Symptomatic stones should be out.
Dr. Agarwal?
Yeah, and Dr. Abhay Dalvi, do you want to say something? I thought he had some comment. Okay, anyway.
I am a strong believer of symptomatic stones and non-symptomatic or asymptomatic multiple small stones is a definite indication for cholecystectomy. The only people who you can observe are single solitary stone without any changes of pathological changes in and around the gallbladder. Patients who are less than age of 60 and who are non-diabetics are the patient, and a little educated patient
are the ones that can be observed.
I'll just make two small comments. One is, Kalan, as you said, that 2 episodes of biliary colic or something. I think even if there's 1 episode, symptomatic gallstones, yes, they need to come out. But as regards the asymptomatic gallstones, because certainly once the symptoms have started, you don't wait. Because in fact, the literature tends to support that if they have become symptomatic, the chances of their complications in terms of pancreatitis or malignancy, etc., is there. However, totally asymptomatic stones, the literature as of now, because as what Pawan said, that whether the risk of doing a cholecystectomy versus the advantage that you're gaining, because at the moment, what the literature stands today, that the risk of malignancy developing is not counterbalanced by the risk of the procedure. Because Kalan, one of the things when we kind of give it to the general public to say that you can go ahead and do a asymptomatic, because you know that maybe tertiary reference centers which are doing, the risk of morbidity, etc., is much less. But as Dr. Vinay Kapoor also in one of the meetings said, that do we translate that risk of malignancy into a biliary injury? Because we have seen that significant amount of biliary injury. So that would be a little issue.
No. I only thing is, Anil, what somebody might say symptomatic or asymptomatic, it's a very subjective assessment. You know, sometimes if you ask them point blank questions or the problem, says, yeah, thoda pain hota hai, but that is because of the gas. You know,
yeah, that I agree.
Denial is there. No, that denial is there. According to our Indian symptoms mean if the patient had so much pain that they had to go to a hospital to get an injection over and done, then he's symptomatic. If he's having pain after eating food and he's getting relief by taking a Drotin or something, then that is a mild symptom. They say that is not a symptom.
Right. So you are saying the same thing. Basically, that means that when they have started having symptoms, they have earned the surgery. They don't have to go to a hospital or to be on IV analgesic or to have a significant episode of cholecystitis to start antibiotics.
See,
so any biliary colic also would be a symptom which would warrant surgery.
Absolutely. So I think we are all on the same page. I'm not saying you start operating every gallstone that you see, but what I'm trying to say is that our, especially our physician friends, they're very this thing that okay, don't wait. Then they have problems.
So the take-home message from the discussion is that for asymptomatic, still we do not have enough literature to support advocating cholecystectomy. And even if slightest symptoms are there, yes, we should go ahead and perform lap choles. If you have any difficulties, don't hesitate to convert into an open. Let's move to the next topic. Again, Dr. Pavninder Lal is here with us, who's going to talk to us on laparoscopic management of CBD stones. Dr. Lal, please.
Thank you very much, Dr. Nimesh and the chairpersons and all dear delegates and audience. Greetings from my institution, Maulana Azad Medical College. And the topic is laparoscopic CBD exploration. So we at North India have a very high incidence of gallstones, and most of these stones are pretty different from the Western population. We get multiple large impacted stones with very dilated CBD, which is a mixed type of stones. And these definitely give a lot of challenge on extraction by just endoscopic means. It is not uncommon for any one of us see MRCP of multiple stones like this with very wide 2 or 3 centimeter wide common bile ducts. And even intrahepatic stones are not rare. Laparoscopic procedure has become very popular with all its advantages of providing shorter hospital stay, decreased morbidity, and very importantly, an intact sphincter of Oddi, because we are not, if we remove these stones from the top, we are not going through the sphincter, and therefore that remains intact. However, it is technically demanding, it is time consuming, and definitely has a learning curve. So we do a normal workup in addition to the standard workup. MRCP is definitely done for stones, and classically the techniques have been the transcystic approach and the transcholedochal approach. Of this, the transcholedochal approach is something that we prefer at our institution because of the dilated ducts that we get. We initially did transcystic also, but because of its very cumbersome nature and limitation of the gadgets that we can put in, we have now almost stopped doing transcystic and moved completely to transcholedochal. General anesthesia is used in all cases. The standard 4 ports of cholecystectomy are the ones which are shown here at A, B, C, and D. We add an additional E port, which is cranial and onto the right side, almost abutting the costal margin, and that affords view of the caudal CBD without causing much of a problem. So, and sometimes there is a port in between A and D for doing the cranial scopy if we are not able to get it from the camera port at A. So this is the flexible 4.5 French choledocoscope which we used in our initial 50 cases, but after that we have moved on to using the 8 French or 10 French rigid ureteroscope, which was a technique pioneered by 2 of us here at MAMC because we were familiar with the urology equipment. So we use that. A lot of surgeons use the PCNL nephroscope, but we have stuck ourselves to the ureteroscope, which we find is has got a lot of advantages in terms of the maneuverability and its way in which it can be maneuvered both into the cranial and caudal part. So this is the video. So the first step is controlling the cystic duct because stones can keep falling. So it is very important that we put clips or a tie around the cystic duct. And then you can see the dilated common bile duct. So we do a vertical choledochotomy. This can be done using a cold knife or by a very special micro needle if you have. And this initial incision should be small. It should not be very large, because we would like to do a choledocoscopy at this point of time. And a large incision, sometimes then the water or irrigation fluids tends to leak. So once this is nicely done, then the rigid choledocoscopy will come inside, and we will do the cranial choledocoscopy. This is the caudal one first, which is coming from the epigastric port. As you can see, the ureteroscope comes and we've gone down, and now the view comes and you can see the stone, multiple or single stones. They're very nicely visualized, and if they're very large, then they will not allow the scope to go into the duodenum, which is the point which we would like to confirm in each and every case when the clearance is done. And this would be followed by stone extraction. Stone extraction can be done using we prefer a 10 mm right-angled instrument, which is very robust, and majority of the times most of the stones are very nicely retrieved. In multiple stones situation, we like to keep a bag inside, which will be seen in the next small clip, so that all the stones are parked into the bag itself without them getting displaced. Here in this case, this was a single large stone. And then we do a check distal choledocoscopy, which should show the choledocoscope entering the duodenum, and easily one can recognize. You can see the duodenal mucosa and the transverse duodenal folds. That's the sphincter of Oddi, and you're into the distal common bile duct. Now this was the place where the stone was impacted, and this is once again going back into the duodenum through the sphincter of Oddi, which remains intact after this procedure. And sometimes small stones can be pushed distally also. That's another thing that happens. If there are stones which need more extraction, then we use a 3-wire Dormia basket. Again, the experience from urology comes in handy. Here you can see the use of the Dormia wire, which is being used to hold, and the stone can be pulled out. After the distal clearance is done, we do the proximal choledocoscopy. This is again showing the bifurcation of the left and the right. We're in the right duct now, and one can very nicely see all the segments, and intrahepatic stones can also be picked up. And then a 7 French stent is usually placed through the choledochotomy and passed across the into the duodenum, and the upper end lies into the common bile duct, and the otomy then can be easily closed. So that closure again is also a single layer closure of continuous suture. We prefer Vicryl, and you can see this is a continuous closure that is being used, and absolutely fine closure up to the end of the choledochotomy, so that there is no scope of any bile leak left. So after this, the and in all of our series, we have not found any problem with bile leak, because one, the closure is very, very carefully done, and secondly, we always have a stent inside. Division of the dilated cystic duct can be done by many methods. Here it is just to show that a very dilated duct can be divided with the help of a stapling device. So this is just an additional opportunity used to show the use of the stapler. And then once this is done, then the cholecystectomy is completed in routine fashion. And you can see the closed common bile duct. Another one to show the use of the Dormia basket. This is another one where we are using the 3-wire is the one which is normally successful. In the urology practice, we use 4-wire, but sometimes in small stones, we need 4-wire even in the removal of stones from the common bile duct. And here the guide wire is being used, and you can see over the guide wire, we entered the duodenum to see the closure. Sometimes if you're not able to go with the scope itself, the guide wire helps you to guide into the duodenum, and it is 100% clearance in every case. There is no doubt that there is any stone left behind, and always a proximal and a distal check choledocoscopy is always done. This is again a video to show the removal of the multiple stones, and this one was so tightly packed, as you can see, that there was no place to do a choledocoscopy in the initial setting. So stones are being removed with the help of the forceps as well as suction, and they are all taken into the bag, as was being shown in one of the previous videos from Gangaram Hospital. And all these stones would be put into the bag. The maximum number of stones are 71 from one patient that we have removed. And then this is the proximal choledocoscopy using the rigid 8 or 10 French ureteroscope, and one can easily see this is the lower end stone which has been found, and this will then need to be removed. And once this is removed with the forceps, then we do a check choledocoscopy, and this is the way your choledocoscopy. It's beautiful vision which comes from the use of the ureteroscope, and really speaking, there is no substitute to the way. And now we have also used holmium laser for large impacted stones at the lower end. Sometimes they cannot be negotiated, and I just want to show here how the holmium laser is able to very nicely split these stones, fracture them, and then those bits can be removed easily, either using forceps or using the Dormia baskets. So this is one gadget which is very, very handy if you are doing high volume common bile duct stones. In the selective cases where we have infected bile, that is the only place that we resort to the use of a T-tube drainage, and we take a controlling stitch. Initially, we should always have the youngsters to take a control suture before doing the choledochotomy, so that they are in better controlled. And then this is to show how a cold knife is being used, to cold scissors being used to make a choledochotomy. And presently it is only in infected situations that we resort to the use of a common bile duct. This is the flexible choledocoscope, one of the older videos. Now that we have given up on this, and once we find that we are not happy in doing a primary closure, either because of a lot of pus in the area, we would be happy to put a T-tube, and the T-tube is inserted in the classical manner that we do in the open surgery, nothing big deal about it, making sure that both limbs are nicely going inside and freely moving. And once they're in position, 1 or 2 sutures to close the choledochotomy incision, narrow it down so that there is no peritubal leakage, and then this can be removed in 10 days from the date of its surgery. And lastly, there is a video on the transcystic, just for the completion's sake, for the sake of the students here, that this is the otomy made into the cystic duct, and then over the guide wire we put in the balloon dilator. You can see that is the balloon dilator which is going over the guide wire. And once, because you need to dilate, cystic duct will not instrumentation to go through, and we need to dilate not only the cystic duct but the cystic duct common bile duct junction. So once we are across into the common bile duct, then you can see now the balloon is being used to dilate it. And once this is dilated, then the instrumentation, the flexible choledocoscope can go inside. So once again, over the guide wire, the scope is being negotiated inside, and the stone can be seen and managed according to, normally we would resort to a Dormia basket, because transcystic exploration will be done where the CBD is not dilated. So you can see here small stones, multiple stones, and this will be the perfect situation for a Dormia extraction. As you can see, just put them into the bag, into the Dormia basket, and keep extracting them till we have a clearance, and then the choledocoscope is able to enter the duodenum for a closure. So in all now we have excess of 400 cases. Initial 35 we use T-tube, all rest of them are with endobiliary stents, and we have had only very few 6 conversions, and most of our patients are female patients, and the CBD size ranged from 4 to 23 mm. That includes the transcystic cases. Maximum 70 stones. Average size varies around 12 to 15 mm. Average duration of surgery is around 140 minutes. We have had only 1 mortality because of sepsis and patient with cholangitis, but no other mortality. And operative times progressively decrease as the surgeon's experience increases. Post-operative stay has been about 4 days only, which is very reasonable and allows a very rapid work of patients. We have had a follow-up of a very good follow-up of several years now, and our stone clearance rates are very high as compared to the international literature, exceeding 98%. And our series was published in the surgical endoscopy, which showcased the entire publication. The comparison of operative times with published literature shows that our times are almost at matching with those with the other large series. The stone clearance rates are amongst the highest, as I said, and the conversion rates are almost at the lowest because we have had a good clearance rate. So to summarize, chairpersons, transcholedocal seems like the optimum route for common bile duct stone management. Brown calcium bilirubinate stones are common and are often large and multiple. Rigid choledocoscopy using 8 or 10 French ureteroscope is something that we prefer for CBD clearance. Primary CBD closure with and without stent can replace the conventional T-tube. The best treatment is one that is simple, reliable, readily available, and therefore, once mastered, laparoscopic CBD exploration can be performed with an operative time comparable to that for open, without the side effects of the damage to the sphincter, as happens with the ERCP or endoscopic sphincterotomy, and it offers a reliable single-stage management for gallstone disease. And thank you very much once again. These are the pre and post-operative pictures of the same patient. And it was a feeling earlier that if you have a dilated CBD, this is the era in which we were taught that your dilated CBD must have a drainage procedure. And now with MRCP, we have been able to follow our patients post-operatively, and we find that that's not true. The common bile duct, though it's not a muscular tube, does come back to a smaller size, becomes quite normal, and therefore we have not started resorting to do a choledochoduodenoscopy the way we were trained in our surgical practice. So thank you very much once again for this opportunity to share our experience.
Thank you very much for such a fantastic presentation. There was one question in the chat box is, once you put the stent in, how do you confirm that the distal end is in the duodenum? Do you again put in a choledocoscope or a rigid ureteroscope to confirm it?
No, we do not do any scopy unless there is a doubt. Actually, this is a very rigid tube. So once it goes across the thing, you have a feel of a give way. So you have a bit of a resistance, and then when it enters the duodenum, you get a feeling, a haptic feedback that it's gone into the duodenum. Also, with the experience, we know that around 5 centimeter, once it goes down from the site of the choledochotomy, then it has gone into the common bile duct, and you should have only 1 to 2 centimeters remaining to allow it to stay into the common bile duct. So we don't need to, unless there is a resistance happening, in which case we would then try to over a stent.
So thank you very much. I think we have overshot the time. Dr. John is getting a bit impatient. If there are any
remove those
any
stents.
questions?
When and how you remove those stents?
Yeah, Dr. Satish Meda is coming with a question. How do you remove? Yes, we remove it by by endoscopy, side wing endoscopy at the end of 6 weeks, just like we would remove any other stent. There is no need to do any sphincterotomy, and that happens at 6 weeks.
So thank you. I would like to thank Dr. Kallan, Dr. Agarwal, and Dr. Lal, all three of them for such a fantastic presentation. And I think we should move on to the next session again, which is being eagerly awaited. Dr. John or one from the organizing team.
Thank you very much, Dr. Nimesh, and all the chairpersons and the speakers. Thank you very much for I think that was a really, really involved and impactful and engaging session. I think this impact will go a long way, and we need this timely reminder time and again. Thank you very much. I'm going to now switch over to the next session and welcome the moderator for this session, Dr. S.P. Somashekar. He needs no introduction. He is the chair of the Department of Surgical Oncology and also robotic surgery, and also a HIPEC super specialist at the Manipal Comprehensive Cancer Center at Bangalore. And I know he takes care of Pan Manipal for the surgical oncology responsibility. Accompanying him as chairperson, Dr. Sumitra Rawat, chair of the Surgical Gastroenterology and Liver Transplantation Department at Sir Gangaram Hospital, B.B. Agarwal, senior surgeon, Sir Gangaram Hospital, Satish Midda, senior minimal access surgeon, Ranchi, and also incoming secretary of the IAGS, Vivek Bindal, chair of the Department of Minimal Access and Bariatric Surgery, Max Hospital at Patpatganj, Vaishali, Noida, and Mohali, Deepika Gupta, our own consultant surgeon, Department of Surgical Oncology at Sir Gangaram Hospital. Over to you, Dr. Somasekar, to invite the speakers.
Thank you very much, Suviraj. And this is the last session, but the most interesting session. I would know the speaker, so it's going to be one of the best. That shows everybody is still at the fag end of the day waiting for this. This is a colorectal session. There are 3 excellent speakers, which is going to cover the robotic TME, minimal access hydroductive surgery, and HIPEC, and then the video-assisted surgery for the fistula in Nano. So without wasting, I invite my close friend, Dr. Deep Goyal, to please give his thoughts and his experience and talk on robotic total mesorectal excision, how to optimize the technicalities for the outcome. Over to you.
Thank you, Somo. And can you see my screen now?
Yeah, it is seen well. Yeah, you can make it full screen now.
Okay, just give me a second, please. Yeah. Okay, so as everybody knows, and as Somu said, that this is probably the best session. And since I'm a colorectal surgeon with a special interest, so I always feel that this is going to be the best session.
Deep Goel, could you go on full screen?
I am at full screen.
Okay, we are seeing it on the slide, format still.
I am, okay, let me start sharing again. I am at full screen. Can you see it now? Is it full screen now?
No, screen is not seen. It's, yeah, we are not able to see your screen share. Maybe just
You need to
close
start
it.
sharing again.
Yeah, start sharing again.
Can you see it now?
Yeah, we see it still in a slide mode. Try full screen, otherwise we just run it as it is.
Is it full screen now? Because full screen.
Not yet. I think it's okay. Maybe from time Mac creates a problem. Go ahead.
Okay. So this
just you can click on the slide icon, slideshow icon.
That's what I did. That's what I did. I don't know, somehow it's not.
It generally sometimes it take time, but I think if you
No
can
problem.
click-
Deep, go ahead, please.
Okay, fine.
Okay, so this is the timeline of rectal cancer surgery starting from Sir William Miles in 1907, and going up to Gerald Bewes, who started TEM and now TATME. So these are our predecessors where they have contributed so much to the rectal cancer surgery, and today what we do is because of them. And coming to the principles of rectal cancer surgery, as we know, like any other cancer, we need to completely remove the organ involved. We need to, at the same time, preserve the sphincter function. We have to do something where we reduce the recurrence, where we will take help of our colleagues, medical oncology and radiation oncology. And at the same time, we need to make sure whatever we do, we need to keep in mind that we have to improve the quality of life of patient. This is how a robotic system will look. I will not waste much time on this. And coming to the board side.
Slides are not moving. The slides are not moving. We are stuck with the second slide.
I am not sure what is happening. Is it moving now?
You need to do screen sharing again.
Can you see now?
We are seeing your desktop screen, not at the power presentation.
Not the slide?
No, not the slide.
Deep, would you like to do one thing? While you sort it out, could we just run the next faculty? So, because yours is a very important topic, Anil, could you just help him out? Could we start with Selvasekar? Are you there? Or Atul Saxena?
Yes.
Oh, Selva, would you like to take on first? So, because Deep sorts it out.
Okay, no problem.
Yeah, see,
Hi,
try once.
good evening.
Yeah, just try moving the slides deep. Let's see if it is on, then we go ahead. Yeah.
Yeah, 1 second. Just give me 1 second. I have now. Yeah. Can you see now?
Yeah, can you make full screen?
Yeah, which is. I made the full screen and I can see it on my. Can you see it? No.
Can you move the slides? Let's see. Are they moving?
I am moving. Are they moving there?
Okay, no, not moving. Maybe then what we'll do is we'll go to Selva Sekar, then come back. You can sort of maybe change the system sometime if it is an old system. So, pleasure to invite Dr. C.R. Selva Sekar, who is going to speak on minimal access role in cytoreductive surgery and HIPEC. Word to you, Selva.
Thanks very much. Thanks, Somshekhar. Let me just start the presentation. Okay. Thank you very much, Dr. Suviraj, John, and the team from Gangaram Hospital for inviting me. Give a talk on minimal access cytoreductive surgery and HIPEC. Greetings from Manchester. This is the modern world we are living in with virtual presentation, but it's good to see you all. Pseudomyxoma peritonei, which is cited as an incidence of 1 in a million, arises from the low-grade mucinous neoplasm. This is a sort of picture which we used to see when the cytoreductive surgery program was set up at the Christie in 2002. We used to have patients coming in with huge abdomen with mucinous ascites and mucinous deposits throughout the peritoneal cavity. And the treatment, as we all know, is aim is to achieve a complete removal of mucinous deposits and add heated intraperitoneal chemotherapy with mitomycin C. At the Christie, as I mentioned, we started this program in 2002. Initially, advanced PMP was our main bulk of our work, but nowadays we see patients presenting with early disease. So what has happened is, like most of the advances we have seen today, what we used to do with open surgery, we started to doing it with laparoscopic surgery and in some cases robotic resection, as the previous presentation is on rectal cancer with using a robot. So the standard colossium technique used to be a zipisternum to pubis incision, and this is the way the colossium looked like. And then we reduced the colossium to what we termed it as a Vesuvius technique, where we had a periumbilical incision, and then we moved to a fully cytoreductive surgery in selected group of patients. This is, to make it very clear, not for every patient, but it's a selected group of patients. So risk reduction cytoreductive surgery evolved where if patients have a LAM lesion in the appendix with periappendiceal mucin, because they are prone for a pseudomyxoma peritonei at a later date. So these were the patients who were selected for this minimally invasive technique. So the end of the surgery, something which ended up with a scar with an up and down incision, became a scar about 10 centimeters in length and then to about 5 centimeters in length. What can be achieved? This is how the advances has happened in surgery in general. So when we look at the evidence, in low-grade, low-volume peritoneal carcinomatosis or peritoneal metastasis with a PCI score of less than 10, it is shown there is evidence to suggest that it is oncologically safe and feasible. And preoperative evaluation with the laparoscope helps in identifying patients who can achieve a complete cytoreduction. These are the areas where minimal access surgery has come into in the practice of cytoreductive surgery. And we at the Christie started doing the risk reduction cytoreductive surgery, and we published our initial technique and results in 2014, and this was followed by a further publication in 2020. So what are the indications for minimal access cytoreductive surgery? Early PMP with a low PCI score, we would say around 10. And the other areas are peritoneal metastasis with colorectal origin, with ovarian cancer, appendix cancer, endometrium, and also in gastric cancer. And also multicystic mesothelioma, which is a benign end of the mesothelioma spectrum, is where laparoscopic technique is being offered. What we would say is an optimum requirement is that MDT is the key here, having a good pathologist and a radiologist, because this helps to avoid surprises when we stick in the laparoscope. And we use the integrated theater, which we use because it is available, but this is not a necessity. But it helps in these long drawn operations for surgeon comfort. And also we prefer ligature and also having a HT system at least, because it is kinder to the eyes and also helps the theater staff to engage during the long drawn surgery. And patient positioning, we need an operating table which can go full head down tilt and head up tilt, which helps. And also a 30-degree scope. we prefer hemolog for when we take the gallbladder out because of the intraperitoneal chemotherapy, which can sometimes, we're not sure about the pressure system in the peritoneal cavity, so we prefer instead of ligature clips using a hemolog and having atraumatic graspers to avoid any iatrogenic injury in the long-run procedure. We at the Christie used it initially for risk reduction with the PCI of 0, and also we use the close technique, and this is our standard port placements. We use 3 12s and 2 5s, and this is a sort of specimen which we removed. Although I would like to bring it to the attention, although the PCI score is 0 on CT, these are radiologists who just look at peritoneal disease day in and day out. They are not able to identify all microscopic or mucinous deposits, which has been found in about 23.6% of our patients in our series, and epithelium was found in about 3.6% of the patients, and residual appendix stump had tumor in about 3.6% of the patients. So they're not all risk reduction. There have been patients who have had disease at the time of surgery. And we also started following enhanced recovery protocol, which fits in nicely with minimal access surgery. There are 17 elements, as we all know, and these are the various variables which we have used over the years. And when we looked at our data and the hospital stay, we also grade using the NCI grading system, and we have a prospectively collected database of all these patients who have colorectal surgery basically at the Christie. And so far we've done 55 laparoscopic procedures, compared them with the open ones, which were done by a group of surgeons who were traditional open surgeons. There's no difference in the age or the BMI, but the previous operations or the ASA grade. But what made the difference in these are the operating time, as one would expect, is longer in patients who are laparoscopic surgery. The complications are similar, we would say. The length of stay is certainly, as one would expect, is shortest with the laparoscopic group. The mortality has been 0, morbidity has been less. It's all similar to all minimal access surgical technique. This is all to do with the short-term wound-related complications are less. The long-term or the medium-term oncological outcomes are similar between open and laparoscopic group. So what we would conclude is it is safe. It has to be done in a selected group of patients. Hospital stay is less, and enhanced recovery program helps to improve the benefits and works in synergy with minimal access techniques. And there's been no specific complications related to enhanced recovery program, which in some series have shown that there's a risk of vomiting and aspiration, which we have not seen. And what we're looking forward is is to increase the size and have increased experience, and also probably push the threshold to include higher PCI score and work with data from the other group. I would like to thank my colleagues at the Christie. I've got a video presentation. I don't know whether we've got enough time. It's a 7 minutes video. If it is okay, then I can share that. If you're short of time, then I can stop.
I think if we are within the time, we can go ahead. John is.
Yeah, I think we have time. If you can run through it quickly. Yeah.
Yeah.
Okay. Let me just share this. Stop.
Thank you for the opportunity to present our surgical technique of offering laparoscopic sagittal surgery and heated.
We are not able to see the video. That video is not screen shared. We are seeing your desktop.
Appendix
All right.
as risk
Sorry.
reduction treatment, and in those with lower volumes.
It says you're sharing. Okay.
Maybe you close. Open the video and keep. Then close other windows and then do screen sharing. Maybe then only that will come. Or start the screen share. When you select, you will have multiple views. Then select the video view. Otherwise, the desktop will come default.
Sir, when you click on the screen share option, what are you seeing? Click on the.
Okay. Is that? Can you see now? Or?
So that is a video, sir. So you want to play video?
Yeah. Surgical technique of offering laparoscopic.
Oh, you sir, open it first and then you have to share it. You open in the media player and pause it, and then again you press the screen share. Then you will see the window of video that you have to play.
Okay, I'll open the video and I'll stop.
Yeah, now click screen share. It will show multiple windows, the PowerPoint, the desktop, and the video. Click the video one and then share it.
Hansen is resected in a traditional manner by 10. Dr. Selva, alternatively, you can mail this to Anil. Anil, could you just connect with Dr. Selva?
Usually 7-minute video, very
tough. We can do it later on, a little maybe down the line, because I think maybe.
Okay.
Thank you for the opportunity to present
so it's not showing at the
moment of offering laparoscopic cytoreductive surgery and heated intraperitoneal chemotherapy with mitomycin C.
Actually, you have to pause that video, close all the windows, and start the screen share again.
So you pause the video, and once you press the share screen, just press the icon. Are you able to see that video window?
Video window.
No, when you press share screen, it will show multiple windows within the Zoom. You need to click the one you want to share. Otherwise, multiple windows will open and default desktop will come.
Okay, is that showing sharing now? No.
Thank you for the opportunity to present our surgical technique of offering.
No, not yet.
No, sir.
Okay, I think we probably leave the video off, or I can send it to. It probably will be a bit big, I think. I'll send it to Anil, I think, Anil or Satish.
Or alternatively, the PowerPoint last slide, you can paste the video and play it through the PowerPoint, then default it will come from there. It's okay. Okay, since there are no questions in the chat box or in Q&A, I'll just ask one or two questions. Since this is not a standard of care, what are the case selection, like what PCI you want to do? Because usually the omental bursa, lesser omentectomy part is little tough in minimal access. And doing a Gleason capsulectomy is little bit tricky in minimal access, even though it is possible. But these are the two areas which are quite tough. So what PCI selection would you recommend? And is there any long-term outcome recurrence pattern at 5 years in both arm? Are they different?
Okay, good question. As I mentioned to you, we use this technique when we radiologically, it is a low PCI score, about less than 1 to 3 is what we look at. Mainly disease localized to the right leg fossa. But as I've shown, as the video is showing, there is disease or in the right hemidiaphragm. But these are patients, these are not cancers, these are PMPs. So they are sort of mucinous deposits. Can you strip the diaphragm with the laparoscope? Yes, I think we can. It is like most things, it is more of an evolutionary technique rather than just saying that, yes, you can use it for everyone. And then you find that you're spending about 12 hours doing an operation, which could have been done with an open. So it is just not the surgeon as well. It's a whole team which needs to be brought in and they need to buy in. As you know, Somshekhar, basically with the HIPEC, it's about 90 minutes. And then on top of it, surgery, which is about 4 to 6 hours. And we have to be mindful. And that's the reason why when we started, we were doing it like a hybrid technique using hand ports, but now we have moved to fully a laparoscopic sort of a thing. So it is an evolutionary process, and low PCI score, I think the key is having a good MDT where the radiologist can help in identifying suitable patients for this sort of surgery.
Good, that's a good message. So predominantly low PCI and predominantly LMN, so maybe low-grade mucinous tumors of the appendix with low PCI. That's good to start as things evolve. Thank you very much. That has been very insightful and fantastic. And by default, it will be a closed technique of HIPEC because that gets the benefit of minimal access, right?
Yes, it is.
Good. Thank you very much. So is Dr. Deep Goyal ready? Deep?
Somu, I'll have to check it. I will just.
Okay.
Can you try once more, sir?
Yeah. Can you see it now? Can you see my share screen?
Yeah, just now happening. Okay, now open the presentation.
No, the presentation is gone.
We can see your desktop. Can you double click? Sometimes changing the computer helps. Sometimes it's a Zoom platform not updated and it troubles.
No, I just actually 2 hours back only I presented just now from the same computer.
Okay.
Okay.
So can you open the PowerPoint and keep it?
Yeah, that's what I've done.
Okay, not full screen, right? Yeah. Okay, now share the screen.
You click on share screen, yeah, and then
see the PowerPoint window, not the desktop window.
Yeah, I'm sharing the screen. Can you see now?
Yeah, just opening. Yeah, now double click it. Yeah.
Is it visible now?
Yeah, but you know that is not seen as a PowerPoint. Is it not dot PPT? Is it a video? No, no.
No, it's a PowerPoint. Okay. Can you see my slide now? No.
Not yet. We are seeing your desktop. Let's see. Sometime it takes.
Okay. Now?
Not yet. Must be opening.
I think I'll start sharing again. Start sharing again. That is. Can you see now?
Not yet.
God.
Yeah. Let's see.
Now?
Your desktop is seeing. Open the PowerPoint.
Yeah, but I opened the presentation and I can see it on my laptop. And it is showing that you are sharing the screen.
Okay, we are not able to see it. Can you try another system? Do you have another system?
I do not have the moment. Unfortunately, I'm at home.
Is this on your phone or anything? Mobile? No.
I have an iPad.
Deep, do one thing. Can you convert this into a PDF and then run the video separately? And while you do that, we'll get Akhil to maybe present or Somashekar.
Yeah. Okay, we will do that. So I invite Professor Akhil Saxena, who is going to speak on the fistula in ANO, the video-assisted anal fistula treatment. So, which is a novel technique. Over to you, please.
Thank you so much. Am I able to show the slides, my screen?
Yeah, we can see it. Make it full screen, please.
Yes. Is it okay now? Can you see it full screen?
Yeah, we can see it. Please proceed.
Okay. So I am thankful to the team Gangaram and especially Dr. John for giving me this opportunity. Now, as we know that WAFT has come about 10 years back in India, 10, 11 years back in India. And we were the one of the first one who procured it, had a lot of experience, lot of glitches, lot of problems initially, but now finally settled down with it. So to start with, anal fistula is an abnormal epithelialized pathway that connects the anorectal tract to the perianal region. And by Parkes classification, we all know there are 5 types: A, B, C, D, E, right from superficial fistula to the extrasphincteric fistula. So the origin of fistula is usually of cryptograndular nature most of the times, but then sometimes it can be because of the Crohn's disease, malignancies, trauma, infection, radiotherapy, and incidence is more in males than in females. Classical symptoms are perianal itching, some discomfort, some pain, some swelling, some discharge, and recurrent discharges. And then on physical examination, we find different kinds of fistulas, and the important investigations are endorectal ultrasounds and pelvic MRIs, which are to be done before the surgery. So a good endorectal ultrasound is often sufficient, but pelvic MRIs are a very good supportive for the before the surgeries. Now, surgery has basically 2 main objectives. We have to remove the fistulous path and treat the internal opening. That's the only 2 things. Now, as we know, the fistulous path is basically lined by the sludge and lined by the unhealthy tissue. So we have to remove that. And then internal opening has to be closed. Now, there are many different techniques which have been going on, like fistulotomy, fistulectomy. They have a greater risk of sphincter injury and thereby maybe sometimes fecal incontinence. Then there are lesser invasive techniques which are like plug, fibrin glue, but they have high recurrence rates. Then mucosal advancement, flaps and lifts. Lift is, we all know, ligation of intersphincteric tract is, they are far better with less of recurrence rates. Almost the success rates are almost equal to the WAFT. So the incidence of recurrence is very much variable depending on the what kind of fistula you are operating to what kind of surgeon is operating. So it's somewhere between 5 to 65%. Now, the association of video and surgery in the search of minimally invasive procedure led to the development of WAFT, and it was started in 2006 with a reported success rate of 87%. We are also getting somewhere similar success rates. The advantages are that they are minimally invasive, have shorter hospital stay, quick healing, less pain, no sphincter damage. That is the most important thing, and absence of perianal wound visualization and management of the accessory tracts and cavities. There are some drawbacks, including the cost of the equipment, the training of the surgeons, strict compliance or follow-up is not being done sometimes by the surgeons, how to use them. And in case of a very narrow internal diameter of tract, sometimes the scope cannot be moved inside. So we often convert such cases to lift. Recurrence rate is usually 20 to 30%, and we explain it to the patients beforehand. In patient selection, we go for a mature tract. Medium to high fistulas with well-formed single multiple tracts are also welcome. Complex fistulas like horseshoe fistulas, recurrent fistulas, sometimes fistulas associated with abscess, they can also be done. But then we explain the patient for multiple sittings. Some clear-cut contraindications are immature tracts, submucous or very low perianal fistulas, very high pelvic fistulas, and fistulas secondary to some pathologies like Crohn's disease, malignancies, tuberculosis, or radiation. We tell that if the surgery is successful, if there is no active discharge for at least 2 months, then we label that surgery as successful. Now we come to the special equipment we use. This is a fistuloscope. This is approximately 18 centimeter of length with a diameter of 3.2 mm at the tip and 4.8 mm in back, and has a channel of 3 mm. This has a removable handle for the easier maneuverability, and then of course one suction and one irrigation attachments. The other associated things are monopolar electrodes, one endo brush, one 3 mm grasping forceps, Walkman spoon, and we often use a curette, a gynae curette, thin gynae curette instead of that, then an endoscope, and of course endostapler or suturing by a Vicryl 2.0. So initially, in our initial stages, we were using staplers, but now we have shifted to purely suturing with almost similar results. The procedure involves 2 phases. One is diagnostic phase and the other is therapeutic phase. Usually it is done in a high lithotomy position under regional anesthesia. We do not need any pressurized fluid, just a bottle of glycine hanging at a height of about 1.5 meter is sufficient. First, identify the external opening through which the scope is introduced. The infusion of continuous jet of irrigating solution enables direct visualization of the fistulous lumen. It allows the assessment in the entirety of the tract. We see the caliber, the content, the direction, the depth, and we also search for the accessory parts. Sometimes we have to find some abscess cavities. It is something like that. You go through a path, then find a cavity, and through that cavity you can find one or two new tracts. So you have to search for all the tracts. And since this is 8-degree viewing angle, so it enables surgeon to decide to which direction you want to see it. And recognition of the internal orifice is of the most important thing, in which we have to isolate. And then I will show you it with a video. Can you see the video?
Yeah, it is seen. Please.
Okay, that's good. That's great. Actually, I was fearing that video might not be seen. So now we see that this is in the early diagnostic phase. We go inside the cavity, and it takes some time to focus. It takes some time to clear the muck inside, and then gradually you get a better vision. So don't be disheartened if you don't see a good picture initially. Then gradually you go inside, find the tract completely, access all the things, and sometimes we inject methylene blue along with a bit of hydrogen peroxide before the surgery, so that you can see that tract. Then you can see a lot of necrotic tissue in the entire length, and also do not try to push the scope, otherwise sometimes you can make the false tracts. So once you see the complete tract and accessory tracts and all the cavities, then we stop with being the diagnostic phase, and then we introduce the we see up to the internal opening. Right now you can see that we are going almost into the internal opening and into the rectum. So once you see the rectum and the internal opening, then you lift that thing, lift the then we lift the volcano. And isolate the internal opening, and after that you start with the therapeutic phase. Yes. So you start with the therapeutic phase after isolating the internal opening, and then you start coagulating with the ball electrode. Now you can see the ball electrode coagulating the internal lining successfully, and you have to come millimeter by millimeter all around coagulating the tract, and start from the internal opening to the external opening slowly all around. You see the complete burnt, charred out tract will be seen. Okay. And here you have to take care that you keep the ball away from the tip of the scope. About 3 years back, I had to change my scope. I have injured one of my scope because of this small factor. So please take care that the blue part of the or the black part of the roller electrode should be visible. The plastic coating should be visible, and then you coagulate the whole tract slowly, completely. Once you come near the outer opening, at that place, it is difficult to coagulate. Then you use a gynae curette, and then curette the whole tract completely. Again, you take the fine look. Now you see that the curettage part is now it is the fresh and the healthy tissue is seen. Reddish, fresh, healthy tissue is seen. Okay. Then some of the necrotic flakes which cannot be removed by the curette, that can be picked up by the forceps. At this time, you see that we are picking up some tips by the forceps, some dirty tissue, some necrotic tissue by the forceps. After that, as I was telling you about the therapeutic phase, after this, you can again use a brush also. And then This is a video of another fistula where we have put the methylene blue dye. The track initially could administer the scope, but after 3 or 4 millimeters, we could not proceed because the track was quite thinned out. So despite trying many times, we could not go through that track. And out of the fear of making a new track or a false track, we withdrew it, and then we converted the procedure to the lift. So we did the ligation of the intersphincter tract. So sometimes we can change the strategy as per the requirement. Now in one of the patients, we could go very high and almost like at the level of the levator veni, I could find big abscess at the level of levator veni. And this patient had multiple surgeries before in India and outside India. So we completely curetaged the tract, then dilated the tract and excised the tract. Still the cavity was, the cavity was quite big. So we used the vacuum dressings. Then we started doing vacuum dressings for him because the basic purpose is and the basic challenge is to heal it from inside. So the patient was admitted for about 2 months. We did multiple sittings, more than I remember more than 6 to 8 sittings and more than 6 to 8 vacuum dressing, and finally he got cured. He was finally. Now it is almost 2 years. He is still free of the that symptoms and the recurrence. So in post-operative care, we use broad spectrum antibiotics, analgesics, and dressings of the external opening as required. The principle is that we leave the external opening open, and usually at the end of surgery, we excise the external opening to widen it. And we send that particular part of the tissue for histopathology also to see for any tuberculosis or any disease. Then the patients are usually followed up regularly to see the recurrence of the symptoms. And to conclude, this technique appears to be a new, evolving, safe, feasible day care procedure with good advantages of reduced pain, early recovery, early return to work, and of course, no fecal incontinence. And now we are supplementing this technique with lasers also. Now we have a laser fistulectomy, but what we do that we supplement diode laser fiber under vision with the waft instead of using the monopolar energy, and that is also very useful. We are getting relatively better results, though we have done few cases with this. So with this, I stop and I thank you very much for the patient listening.
Professor Akhil Saxena, it's fantastic, excellent. It shows a lot of perseverance, patience is the key to starting learning curve. Congratulations for fantastic videos and patience. Thank you very much. I don't see any question in the chat box or the Q&A. Any of the chairpersons, if they have a question, please, you can address to this until Deep is ready. Deep, are you ready? Can we go ahead?
Yeah, Somu, I checked it with another link.
Yeah.
It is working there. So let me try again.
Okay, please check.
Can you see the slides now?
Yeah, we can see the slides. Can you make full screen?
I think there is some challenge in full screen. Can you try to slide, sir? Next slide. Can you click on the next slide?
Yeah. Can you see?
We are stuck with the first slide.
Let me.
Now it is there.
Yeah, it's moving. Please proceed.
Let's go ahead with the screen, this thing rather than full screen. Okay.
Yeah, we'll run like this. Yes.
Let me apologize to the audience and the organizers for this mess up. And this is what technology do sometime. So this is the history sheet of rectal cancer surgery, starting from Sir William Wiles in 1907, who first described the abdominal perineal resection, and coming to Gerard Buse in 1983, who described a transanal microsurgery. And now we have a TATME. So this is what our predecessor did for us, and what we have built on is because of them. So principle of cancer rectal surgery is complete removal of the organ while preserving the sphincter preservation and reducing the recurrence by multimodality approach. And at the same time, we have to improve the quality of life. This is the OT setup, console, table, and cart. And this is the port placement now in the new system. This is how we do it. Slightly vertical and starting from the right iliac fossa, going up to the left upper quadrant. You can have assistant port in the suprapelvic area, or you can have it in the right subcostal area, depending upon the patient physique and personal choice. This is a small video, and this is my favorite video because this was my first video, and I actually requested Somashekar to be present with me, but he was busy. So he said, why don't you go ahead? And I did this surgery. So first we position the bowel into the right quadrant, moving the bowel from the left to the right quadrant. And you can see the vessel. This is a relatively thin patient. And now coming to the into the sector promontory, making a nick into the peritoneum, waiting for the gas to do the dissection, using the monopolar cautery, making a slit into the peritoneum and reaching to the plane, which is avascular. You can see the nerve down there. So the beauty of the vision and the 3D vision is what guides us. That's the ureter you can see. Gently moving forward. Can you see it now? Somu, is it the video?
Video got froze. Maybe press the forward icon. Yeah. Yeah. We went back to the first screen. Yeah. Video is playing, but again from beginning. Yeah.
Okay. So, yeah. So gradually you reach from this point towards the pedicle, going up towards the origin. It's again freezing at this point. Okay. So I will go to the I have no idea what is happening.
Sometime an update happens in Zoom, and that couldn't have been go through.
That's okay. So what at this point of time I would like to take you to the vascular anatomy of the colon. You see, there are three kinds of vascular anatomy you can have. You can have only prominent marginal vessels, and you can have an arc of Raynaud, or you can have a accessory artery, middle colic artery. So these are the three things which we need to understand because it has an implication. If you see the vascular supply, type 1 is the commonest, which is around more than 50%, where you have a classical middle colic artery dividing into two, or you can have a type 2, which is around 10%, where right and middle colic artery originates separately from the SMA, and then you can have an aberrant middle colic artery, which arises from the right middle colic artery, and that is where we have to be careful. So if you see, this is called artery of Moskowitz. So why it is important, I'll explain to you in a minute. If you see this diagram, if you see this yellow thing is the anterior surface of the pancreas, and if you see the distance between the anterior surface of the pancreas and the marginal arcade, it is around 6 to 7 centimeters. So if you are dealing with this kind of anatomy, there is a lot of space to play around, and this all plane will be avascular. Then you look at the second type of anatomy where you have a arc of Raynaud. There the distance between the anterior surface of the pancreas and the arc is around 4 to 5 centimeters. So you still have a lot of space to play around and do the dissection. And if you look at the third type of anatomy where there is an aberrant artery, there is a more space between anterior surface of pancreas and the vascular arcade. And sometimes, this artery could be the dominant artery. So one needs to be very, very careful while doing the dissection in these kind of cases. So you need to understand the anatomy and before you do the dissection. Also, we need to discuss at this point of time whether low ligation or high ligation, which is better. Well, there is jury still out, but what we understand is that depending upon each choice, as long as you clear the lymph nodes right from the origin, it doesn't matter. You may change your philosophy depending upon cases. Now, this is the video. We have reached to the pedicle and taking the inferior mesenteric artery right at the origin after the left colic artery has been given. And now you can use different kinds of clip. We normally use metallic clips in my practice, but you can use hemolocks or you can use energy sources. Now we have vascular sealing device, robotic, one can use that even. And once you have done taking the inferior mesenteric pedicle, you need to mobilize the splenic flexure. Now, when we come to the splenic flexure, you need to have 3 different approaches: medial to lateral, lateral to medial, and supramesocolic. Depending upon each case and the site of the tumor and habitus of the patient, you might need to choose differently. You might have to, choose all 3 in a particular patient, or combination of 1 or 2 approaches. This is one of the articles which is, on cadaver, which is showing that if you only do M1, then your length which you get is around 46 centimeter. If you do M2, then you get 57 centimeters. And if you combine all, then you get around 85 centimeter length of the colon. Another article showing that if you completely mobilize the splenic flexure, you get up to extra 27 centimeter of the left colon available to you for anastomosis. A video in a different patient where we are showing how we mobilize the splenic flexure. This is the IMV, and that's the Girota's fascia, which is the important landmark. So you need to go on top of it, and that's the IMV right at the DJ. So after you take the IMV, what you see is the inferior border of the pancreas. So depending upon what kind of splenic flexure mobilization you are using, you will go onto the anterior surface of the pancreas as I was describing in the vascular anatomy. So the distance between the vascular arcade and the anterior surface of the pancreas is more in type 1 and type 2. One also needs to be careful that not causing thermal damage to the anterior surface of the pancreas. After doing this, coming back to the original video, after you've taken the pedicle, you continue to mobilize the splenic flexure and then go down once you have done that into the pelvis. Again, you need to appreciate the vision and the clarity of robotic system. These are the hypogastric nerve plexus. You can see very, very clearly right and left. You need to remain in this particular envelope, mobilize all the fat. And this was the plane which was described by famous Professor Bill Heald. Traction, counter traction, and if you see, we haven't used any modern energy sources. This is the monopolar cautery which we are using. And once you have done most of your posterior dissection, you will come to the lateral attachments and then to the anterior attachments. Again, it's very important to do your posterior dissection as far as possible so you can easily pull your rectum. That's the lateral dissection and going ahead towards the anteriorly. That's again back to the posterior dissection. You can see the sphincters there, pelvic floor. And that's the seminal vesicle. You can see prostate. You see how easily we are going down there. Coming back up after doing the dissection, we are taking this inferior mesenteric vein and mobilizing the splenic flexure again from lateral side. Here, Girota fascia, as I was telling you, is the landmark. Sometimes in thin patient, you can lose your track, which I'll show you in a minute in this particular patient, that we went into the wrong plane before we realized. You see here, we are going into the wrong plane. We are lifting the Girota's fascia. You can see the anterior surface of the kidney. And then doing the lateral mobilization to completely mobilize the splenic flexure. This is where you see the Girota's fascia. We are going into the wrong plane. Since it was a thin patient, it did not cause any problem. But otherwise, in a patient with significant fat, you will find it difficult and you will lose plane. Coming back to the pelvis after mobilizing, that's the seminal vesicle you can see. Again, a thing to appreciate is just the monopolar cautery. remain in the right plane, and it's just a cakewalk. And the vision in a narrow pelvis is really a boon in robotic surgery. Once we get used to of this particular technology, you find it difficult. And then you fire the stapler like you will do it in open or laparoscopic surgery. There is some evidence to suggest if you fire more than 2, then there are chances of leak more. This is the ICG testing to see the vascularity of the both ends. Just taking a couple of clips on small vessels there. That's the left colic vessel, if you can appreciate. And this is another vessel going down. And then putting the anvil and stapler, circular stapler from below, joining them like usual in any other form. And once you have done that, we sometimes take some stay sutures on the top of the anastomosis, 3-4 sutures, just to reduce the tension on the anastomosis. And then we close the peritoneum to avoid a small bowel going into the pelvis. So reduce the chances of a small bowel obstruction. And then keep a drain. So there is a lot of literature available. There is no level 1 evidence at this point of time to suggest that robotic rectal cancer surgery is superior to laparoscopic surgery, but there are a lot of literature coming out which is showing equality and ease of doing an operation. There's a very nice article by Kim who says, looking, this is the way forward. It is not a fad. And you have to look beyond the results at this point of time, because this is the technology of future. If you will not practice this now, you're going to lose the bus. I think this is what I would like to say, and I'm open for any question answers.
Thank you, Deep. That's excellent presentation. It was worth waiting until you got the technical issues sorted. Super presentation, fantastic videos. One question: any particular reason you choose a monopolar cautery spatula and not a hot shears? Because then you lose an option of a cold knife scissor when you dissect around the VLPF and PLPF laterally overlying the nerve gingivitis. So any particular reason?
I would agree. Just to reduce the amount of instruments we use this, and I'm quite, even in laparoscopy, I'm used to of using the hook or spatula. So that is just a transition from laparoscopy to robotic, but no other particular reason.
Super, that's very nice. Normally I put an umbilical tape at the rectosigmoid and tighten that. This was a good case. Sometimes you have one of those bulky rectums, and then you keep struggling, falling down in a male pelvis. And I hitch the bladder with a T-lift or a suture. Excellent video. If there are any questions from the chairperson, most welcome.
We have Dr. Deepika Gupta, who's an oncosurgeon. She actually trained at Bangalore, Kidwai, if I'm right. Deepika, could you come in?
Hello, sir. I have watched Somsekhar sir in so many conferences, actually.
All right.
Yes, sir. Actually, I wanted to ask about the last one, the CRS one. Sir, are you also doing minimal access CRS for like ovarian cancers or colorectal cancers?
I am not doing personally. No.
The minimal access is at the Christie. We do it only for the PMP, early PMP,
okay,
not for ovarian. Ovarian, it is a standard open approach.
Yes, sir. That's what I find out. Thank you.
Okay, thank you very much, Deep. Fantastic video. So I think if there are no other questions, with permission from Suvi John, shall we close this session and hand it over back to him?
Thank you. Somsekhar, thank you very much, chairpersons and speakers. We'll run a quick message from our president, which we couldn't run before. It's just a few minutes. So Dr. Sudhir would like to communicate his sentiments from the IAGS and personally.
Anil, could you just quickly play the
Friends,
video? Just, I think, about a few minutes.
Dear faculties, ladies and gentlemen, I would like to congratulate Dr. Suviraj John, Dr. Sudhir Kalhan, and Gangaram Hospital IMS team for organizing yet another the clinic for the upcoming junior colleagues and the postgraduates in minimal access surgery. I know Dr. Suviraj John and Dr. Sudhir Kalhan and their team for so many years, and I'm aware of this activity which they are doing for many years now. IGS is very proud and privileged to endorse and get associated with this event. I was involved with this activity before in past also, and as president of IAGS, I am privileged and honored to be associated with this activity, which is very famous and popular among the PGs and the junior colleagues. Friends, IAGS is our Association of Laparoscopic and GI-Endoscopic Surgeons of India, having membership strength of 8,500. We are a family of 35,000 family members and spread across the various corners of India, starting from Kashmir to Kanyakumari and from Ahmedabad to Imphal. Friends, IAGS is on the verge of completing 3 decades and has been at the forefront of providing
Anji. हाँ किसका हाँ इसके बाद बता दो या ठीक है ठीक है ठीक है इसके बाद लगा दो ठीक है
I think the video is frozen.
Anil, you could just play it.
We could do many online programs such as IGS Prime Time on various minimal access and GI endoscopy surgery topics. Every fortnightly, we were doing IGS Prime Time. During the year, after the month of July, we got a relatively COVID-free time period. During that period, till December, we could do advanced fellowship in laparoscopic surgery of upper GI surgery, bariatric surgery, colorectal surgery. First time we could do it in robotics, and we also did it in hernia surgery. We could also do FIAGS and EFIAGS at Rajmundry and Chennai, and for the first time, FIAGS in Goa. Friends, this would not have been possible without wholehearted support from all the IGS members and the organizing capabilities of various leaders of IAGS. Since last 1 month, we have gone back again on the online module because of the 3rd wave of COVID. And this program is one of the very important programs during this online programs. Dr. Suviraj has invited excellent faculties from across the country and abroad, and I'm sure you will all enjoy this revision of common minimal access surgery topics, which Dr. Suviraj has been doing every year, and he intends to do it more frequently. I think doing such a program every quarter, 4 programs in a year, would add very much value to it and will become a regular feature for every PGs and junior colleagues to attend it. My all best wishes to the organizers and to all of you. And once again, thank you for involving me and IIGS in this year's The Clinic program. Thank you all.
Thank you, sir. Thank you to Sunil. We'll request Olympus, who's been the academic support for our CME, to contribute the latest tech contribution. Mr. Anil, could you play your media?
Yes, sir. Thank you very much for this opportunity. Just playing. Thank you very much, sir. That's all.
Thank you very much, Anil, and thank you very much, moderators, chairpersons, and speakers. Most of all, a very big thank you to our attendees who've been with us through the day, starting actually before the sessions began at 2:30. And a big shout out to all of you. We thank God that we were actually able to hold this in a continuous, seamless fashion. So many things coming together during a pandemic week and weekend. Thank you especially to our IAGIS leadership who've been endorsing and supporting us throughout, and Delhi State Chapter of the ASI, the Association of Board Certified Minimal Access Surgeons. Our entire team would like to, convey our gratitude. I speak for Dr. Cullen, the entire team who's been laboring in the background. Thank you especially to our foreign faculty, Selvasekar, Ricard, who actually woken up much earlier than their day begins and stayed back on a busy weekend. Thank you very much for, I think, the entire leadership of the IAGIS, past, present, and future, who are here with us today. Thank you very much. And Deep, thank you for persisting and finally getting it. Satish, thank you very much for staying the whole day with us. I know you logged in much before and gave us some very valuable tech advice too.
Thank you very much. And we would actually open and request your comments on how to follow this up, because we are looking at doing this more regularly. Doesn't matter if the pandemic is there, on-site, off-site. We hope to do this in a way that's meaningful, especially to our trainees and young surgeons. Any comments, we'll be happy to take in. Otherwise, I'd wish you all a happy and blessed weekend.